And we would be felicitating you on this very stage. Okay, so I want all students to attend all the sessions, give a feedback at the end of it so that we can improvise and our alumni can improvise the next conference as and when they decide to have the next one. So all of you will remember all the sessions and give us a feedback at the end of the sessions. Happy learning, all students, and good morning to all the delegates. Hope we have a wonderful day. And the alumni will be taking over today's day, and we will be taking a complete back seat. So enjoy the deliberations, and we are going to enjoy them too. Good morning.
I am Sahil Sheikh, working as an audiologist grade 1 at SASLP. Most of the alumni do not know me because I am the most junior here. So I passed my master's in 2023. And welcome back to the second day of the Alumni Conference 24-25. I hope you all had a wonderful banquet experience, restful night, and are energized for another exciting day of scientific explorations. Before we proceed, let's take a moment to acknowledge the esteemed guests and speakers who are joining us today. Now, let's dive right into the exciting program for this morning session. Today, we will be stimulating our minds with a variety of engaging formats. Prepare yourselves for insightful panel discussions featuring our esteemed alumni experts. We will also delve into the real-world application through compelling case studies showcasing how theory translates into the practice in the field of speech and hearing. And top of it, our distinguished speakers will join us for a plenary sessions. Let's unveil the latest research and clinical practices in the field of speech and hearing. First, we will be having panel discussion on the topic of satisfying listening needs of older adults. To guide through these insightful conversations, I would like to invite Ms. Nikita Nanavati on the stage. She is currently an assistant professor in audiology at SASLP with a remarkable 13 years of experience in the field. Additionally, her pursuit of PhD in audiology, specifically focusing on vestibular assessment and management, demonstrates her dedication to ongoing learning and innovation. Please, ma'am.
Thank you so much. So, good morning, everyone. Welcome to the today's panel discussion on a topic of satisfying listening needs in older adults. So, today we have a distinguished panel of experts here to provide us insight on this crucial topic. So, firstly, I would like to invite all our panelists. So, starting with first panelist is Mr. Nihan Pradhan. So he has completed BSLP in SIS Bangalore and MSLP in SSLP Pune. He is working as a ASLP at Rajopadhyay's clinic. Also, he is working on digital rehabilitation for children and adults with hearing loss. He has worked at Starkey, Mandke Hearing Services and Phonics Speech and Hearing Center. Also, he has been training audiologists on facts of counseling, programming, fine-tuning, etc. He has done multiple presentations on community-based hearing health care at national and international programs. So I welcome you. Now I would like to invite Mr. Sadanand Gore on stage. He has done his BSLP at SSLP Pune. He has done his MSLP at Manipal University. He has worked as a clinical audiologist at Mandke Hearing Solution in Amplifon, Mumbai. Also, he has worked as a business development manager at Cochlear. Currently, he is doing private practice in Pune since 2021. So I welcome you. Next, I would like to welcome Ms. Sneha Kulkarni. She has completed her BSLP and MASLP at SSLP Pune. At present, she is a director and owner of Rejoice Speech and Hearing Clinic. Also, she is working as a consultant SLP at Dinanath Mangeshkar Small Steps Morris Autism Clinic since 2015. Her area of interest is diagnostic and rehabilitation audiology and childhood language disorders. And lastly, I would like to invite Ms. Shamangi Nakre. She has completed her BSLP from MRF and MSLP from SSLP Pune. She is currently associated with Cochlear Medical Device Company. She has worked as a consultant audiologist at KM Hospital and Jupiter Hospital, Pune. So thank you so much everyone for joining us. Now to start with, let's go back to the evolution of the hearing aids. So we all know hearing aids have undergone significant improvement since the days when ear trumpets and horns were used to transmit the signal to the ear. As digital technology came to the forefront in the field of telecommunication, its application expanded in the field of amplification. And now, With recent advancement in directional microphone technology, multi-channel and multi-frequency compression, wireless technology have greatly improved sound quality and speech recognition. New form of wireless transmission and better integration of this technology with hearing aids not only improve patients' ability to use the telephone, but also allow them to directly connect to the various external devices. Advances in noise reduction algorithm have increased the comfort and ease of listening for hearing aid users. Additionally, various devices and features are now available to assist individuals with hearing impairment who previously did not much benefit with the hearing aids. But despite this recent advancement in hearing aid technology and features, are older adults satisfied with the hearing aids? If they are facing any challenges, what are they? Are they able to use the technology and features effectively? How is their perception about cost-benefit ratio of the hearing aid? So, to discuss all these real-life situations and challenges, we have aimed this session. So, to start the session with, when we are considering older adults, we all know that they face multiple challenges related to the health condition. So when older adults come for the consultation or evaluation, what problems do they report regarding hearing and communication? So my first question of this, I request Ms. Neha Kulkarni to address on this.
Hello. Good morning, everyone. First of all, thank you to the organizers and the esteemed faculty for inviting us for this panel discussion. Since the topic is satisfying listening needs of older adults, the first complaint that any older adult, senior citizens which come to the clinic is ऐकू येतं पण समजत नाही काय बोललं आहे ते. So yesterday we had a very good discussion about what are the processing challenges and what are the challenges faced by people who have central auditory processing or ANSD. So kind of like that the older adults do complain that we can hear but we can't understand. So first major challenge is that. Second is listening in noise is also an issue, that they cannot participate in conversations that happen at home, participate in conversations that happen during a meeting, or so many of these older adults go to parks like Dada Dadi Park, Nanani Park. So there they cannot participate in the conversation that is going on, in the circle that is going on. Third complaint is even if they have heard complaints from their friends in the park about hearing devices, and they have developed their own kind of psyche that, you know, since he's not benefiting with hearing aids, maybe I will also not benefit with hearing aids. And the next and last one is that they don't want to get their hearing assessed. So typically when an older adult comes to us for assessment, when I ask them की तुम्ही का आलायस, नाही मला ना माझा मुलगा घेऊन आलाय किंवा माझी सून घेऊन आली आहे, ते म्हणतात मला ऐकू येत नाही. They say that I cannot hear, but I hear perfectly, मला सगळंच ऐकू येतं. So after our assessment, it is very important to answer all these questions and ask them, do you have any listening challenges, or do you face these difficulties? So as I said, we should list them out and then ask them whether they face these difficulties. I feel that this is the...
Thank you so much. Anybody would like to add something into that? Yeah. So thank you so much, Sneha. So now, as you have correctly pointed out, that older adults have so many difficulties, right? So what do you, Ms. Shamangi Nakre, what do you feel which are must-to-do tests in audiological evaluation for optimum hearing aid fitting? Is only pure tone audiometry enough, or should we add something else into that?
Thank you for this question, ma'am, because diagnostic audio has been my forte, so I'll take this up. When a patient comes to us, the evaluation doesn't start when he is in our consultation room. The evaluation actually starts when he's also waiting in your area. So something which we always learn is about questionnaires. Many of the students might be aware we have developed a lot of questionnaires. The simple basic questionnaire where you can save your time as well as when the patient is in the waiting area. We can start with an HHIA or HHIE questionnaire which tells about the amount of problems he's facing or the disability he's having with the current hearing loss. Once he comes into you, we basically start with a detailed case history, understand. While we are doing an evaluation, it is very important that when we are having a conversation, we have our MOCA test, which is really by heart, 30 marker MOCA test. We can screen it. We can understand how the patient is comprehending and answering to you. Followed by, we start with our pure tone audiometry. When we are instructing, it is very important in case history to understand if the patient is speaking loudly or he is very slow. If he's very soft while he's speaking, it gives you an indication that he might have a mixed component or a conductive component when he's come to you. Followed by that, if he's quite loud, you know that there is a sensory neural component involved, and you need to have a good intervention and counseling session with him. A pure tone audiometry. Many of us do pure tone audiometry. We don't at times have a 2-room setup, and we drop out on something called as speech audiometry, which we do as a mandate test in our colleges. But after that, it is not done, but it plays a very important role because at that time of evaluation, what happens is that we evaluate the PTA, but we don't understand how much the child individual is comprehending. What is he understanding? So speech audiometry is very important in presence of noise and in quiet, followed by an impedance audiometry to rule out usually the identification of middle ear component. Yesterday we saw in Kutsia's presentation and Madhuri's presentation where adults do acquire ANSD. So in that situation, we should be ruling out any special test if it is required. To rule out a special test, you again have to go back to PTA and your speech threshold correlation. So hence it is very important to do a speech audiometry. Many of us are MISHA members here. So I take a lot of pride in saying that our MISHA chapter has developed a Ramson test, which is a speech audiometry test, which should be evaluated in older adults because that helps you in hearing aid fitting later on to set a realistic expectation. And in cases of complications like RCPs and CPs rule out, you need to rule out with the OAE screening and ABR. So if I have to compile, PTA is just not just enough because it starts from when the patient is waiting. You understand what is the writing on the HHI or HHE questionnaire. You go through it before the patient comes into your cabin. You counsel him, and the test battery will include a PTA, speech audiometry, mandate speech audiometry. And there is something which people don't know much in older adults when we need to decide if they are not benefiting with a hearing aid or why they are not benefiting, or if I should put him on a hearing aid, what is happening. There is something called as 60-60 rule. That is something a Delphi consensus talks about, that if an individual has a hearing loss about 60 dB, has a moderate or moderately severe hearing loss, one should be talking about speech audiometry and getting it evaluated, because anyone having hearing loss or not comprehending about 60 dB SPL might be a candidate for a cochlear implantation or needs a optimization of hearing aid then and there itself. So I am not sure many people are aware of Delphi consensus, but that has been a mandate right now, and we should be including that in our daily practices. Thank you.
Thank you so much, Shamangi. As she has correctly pointed out that speech perception in quiet and in noise should be done, because PTA just gives us the threshold, but how is the speech understanding? And definitely our hearing aid fitting will depend on that. That after fitting the hearing aid, we are checking that why patient is not benefiting. But prior, we don't have a baseline. That how is the speech perception of the patient. So it is very important, and I think with MRAMSIN, it is very easy now to do the test because it is a very quick test to do. So I think we all should start incorporating that in our test battery. So moving on to the next question. When we are considering advancing technology and features, how effectively older adults are able to use them? Are they cost effective? And what is your opinion on this, Mr. Nihar Pradhan? So what do you feel?
Hi, good morning, everyone. So first of all, thank you to all the staffs for giving this opportunity to us. So I would say that I have started seeing hearing aids, I think, in 2006-07 onwards. So there is a, if I tell about the technology, then definitely there is a significant difference. There are many things which have come to the market. So like for example, if I start like the noise algorithm, how like, the Sneha, as she said, like, the noise management has a strong issue in a older population because, they have lots of issues because of the noise. So they are not getting the speech clarity. So like that, you have noise algorithm. Now you have Bluetooth technology through which they can have a wireless streaming. Then after that, you have rechargeability, because if you look at the hand dexterity of an old individual, they have difficulty in inserting the batteries. And the battery sizes are very small. And because of the cosmetic look also, people wanted to go for a smaller hearing aid. Again, the battery size goes small. So somewhere the rechargeability comes to play a strong role. And it's not the end. You have language translation, you have speech transposition, you have the latest one which I came to know, it is deep neural network. So here it is like the hearing aid is processing somewhere around 80 million sounds within 1 hour. So, these are the technologies. You have nanotechnology, you have waterproof. But when we look at India, the economical status, somewhere I feel it is not cost effective. Because all these advanced features you get it only in the latest hearing aids or only in the higher segment. So which would be costing like somewhere around 1 lakh. So, but if we look at the economical condition of India, then I don't agree with that part. And if I tell about few things, like one is rechargeability, one is Bluetooth streaming, how I use it like a therapy. Because India is still in a condition where people doesn't come on the same day for a hearing aid. So they come after 5 months, 6 months, or 1 year or after that. So in that way, when you have a Bluetooth technology, what I ask them, forget about the price. If you are affordable, then go for it. But why I am giving that? We should be always, try to justify why you are giving it. Then only you can have a difference between, other people and after having a degree. So what I tell them, this is a therapy. You use it for at least 10 minutes, that Bluetooth streaming, morning, afternoon, and evening. So that, because it is an older adult, most of the time if you look at the metro cities, they stay alone. So that is how they can train their brain, because they have a poor speech discrimination score. So that is how I always start that, like why they have to go for a rechargeable or Bluetooth. It always complements each other. So, that is how I start. So I think, yeah, I would like to stop here because, there are many things. So thank you.
I just would like to add one point. Now, since Nihar has spoken so well about the technology and everything, there is something also that older adults do like. They watch a lot of YouTube videos and serials and, podcasts and everything. So this becomes an very additional thing that you can tell, yes, you can watch your own whatever you want to watch, podcast or videos, whatever they want, you can directly use the hearing aid as your earphone. And that will give you a sound which is made for you. So it's not disturbing anybody else or anything like that. Also, there are some companies which do provide mask mode in the app. So even if a person is wearing a mask, the speech clarity is different. So that is also something. So if older adults do go somewhere to hospital visits or to doctor visits and the doctor is wearing a mask, so they can activate the mask mode on their app, and then the speech clarity is definitely better. And I've tried it with a lot of older adults and it does work, that they do report that yes, with the mask mode on the app, the speech clarity is better. So as I said, these are all the technological things which we have to tell the older adults. But with that also, another problem which we do face is that they do not have compatible mobiles.
Correct.
That pair with the hearing aids. So again, then they're like, आता मग काय नवीन मोबाईल घ्यायचा का याच्यासाठी. So it is something that we need to even tell the companies whether they can make it for some kind of normal mobiles which start from around 10,000.
But companies have started Bluetooth hearing aids which connect with any Bluetooth now at present. So that is also something that is coming up. So the companies are also listening to the feedback and modifying their hearing aids as to the people's feedback. So that is something that I would like to add.
Yeah. Thank you. And even I feel with respect to TV, older adults do watch a lot of TV shows, but again, they have some limitations over there. The clarity is not good and our hearing aid is not directly compatible with that. So,
Actually, you have an option, but that is again cost. There is a TB streamer, so which would be again, there is a cost. So that is how,
it's another accessory
yes,
actually
another
they have
accessory.
to purchase.
But again, that has got a duration. That has a durability. 1 year warranty. Then after 2 years, again, if something goes wrong, then repair issues, or again they have to go for a new one.
Correct.
So like even everybody would be knowing now the hearing aid comes with a 4 to 5 years of life. So if somebody is using a hearing aid at the age of 60, so that means they have to have at least 4 to 5 pair till they reach their 80 or 90. So it is somewhere it is not cost effective. So maybe through this platform, I would like to request everyone, if everyone can have that we can have a unity and talk to the company, because at the end we are the distributors or we are the dealer for that company. So we can talk to them how to reduce the price of the hearing aid, at least in the rechargeability or minimum the Bluetooth technology, so that we can have better pyramid. We are trying to have a triangle, but we don't have a base. We are just looking for the high peak, so which I feel is not possible. Thank you.
Yeah.
Can I add something? Yeah. Thank you. Yeah. So Nihar, in this, I partially disagree with you. See, what I have observed, sometimes patients don't really trust to buy a very high-end hearing aid in the first go. So what I have observed, see, I am just 2.5-year-old doing practice. They buy the basic machine, but after 1.5 years, when the trust is there, okay, this works, they are ready to invest more. Secondly, regarding the accessories side, like something like a TV streamer, so they will not buy on the first day itself, because they are still in the mindset of wearing the hearing aid. So something accessories like a TV streamer or something, we can always pitch them in maybe next 3 to 6 months, and give a trial for a couple of days, and once they are comfortable, they will invest into it. And thirdly, reducing the cost of the instrument can never be the solution. It will never happen, because companies will not do this, and no need to do that also. If there is a value addition, people are invested into cochlear implants of 10 lakhs, then if we can create that value through hearing aids, they will invest 1 lakh into hearing aids also. So I feel it's all about value addition, and reducing cost should not be. Otherwise, the industry will shrink. Right now, we have so many clinics, and all clinics are running profitable. It's because of the cost. That's true, because it requires expansion right now. It is at that stage. So, I don't think we should reduce the cost. I think it is about creating the value. If the patient is really feeling it is benefiting, it is changing my life, they will arrange the funds. Funds are never an issue. It's always the motivation.
But see, this is not one-time investment again.
Yeah, that's fine.
And
See,
the
we are
repair
not,
and everything also, it's recurrence. And it also, the cost is quite a big amount.
Yeah, see, I agree with you. Some section of Indian population will never able to afford a single hearing aid. But we are selling hearing aids to the person who have been earning throughout his life. So I think he has that much of saving to invest every 5 years. And if there's a diabetes, blood pressure, or knee surgeries, they will go for it. Then why not hearing aids?
Okay, thank you so much. Still, it is quite debatable topic.
I'll just add one thing here. There is there are some companies that are working on it, and the hearing aids have already launched. So maybe very soon you are going to get, it is already launched, so Bluetooth technology is already affordable now. And again, the rechargeable option you are getting in another 6 months.
So whatever features are there in the 5 years back in 2 lakh hearing aid, they are in right now 50,000 hearing aid. So with respect to that, if we see, the features are actually coming into lower range. So it is becoming more affordable for patients.
One more thing, I'm sorry, I'm going to add just one more thing.
That's okay.
I feel as audiologist and the younger population sitting here, we are not selling hearing aids, we are dispensing, we are prescribing hearing aids. And as you said, yes, it is a value addition. But as an audiologist, if you feel this person is going to benefit with X amount, there is no need to prescribe 2X amount. Just because, it is
So
cost
true.
effective for us. If a person you know is not going to benefit with 2x, 3x, 4x, I feel we should not give them an option also. I do tell them that this is an option, but I feel it is your call. Whether you want to invest in it or not is your call. As an audiologist, it is my job to tell you from 1x to 5x it is available. But going for 1x or 0.5x is your job.
Absolutely.
But
I agree
as
with you, Sneha.
fitting
See-
range is something that needs to be explained to patients because I've seen many audiologists not fit a proper receiver. Just because the M receiver is fitting right now and you have an M receiver, do not fit it. You order a P receiver or a SP receiver and then give the hearing aid. It is not justified to give an M receiver to a person who will not benefit from an M receiver. I'm talking about RICs if anybody else is just confused. So, sorry, yeah, please.
Yeah, absolutely. And this is typical I am finding because Signia has captured the market to a great extent right now. And there are some models like Signia, Stylato 1X and 2X. Technically, there is not much difference. It is just a tinnitus. If a patient has tinnitus, then there is value addition for 2X. But still, I am seeing that patients are getting prescribed 2X, which is not required. So 1X is enough for that patient. So as you rightly said, no, we should prescribe whatever is required. But at the same time, what happens if the patient is not, we know that suppose it's a sloping hearing loss, and we cannot give BT hearing aid on that. Even with the open fit, we know it won't be possible, and he won't be satisfied. It's better not to give a hearing aid in that cases.
Thank you so much for sharing your insight. So let's move on to the next question. So Mr. Sadanand Gore, what is your opinion on satisfaction with hearing aids after they are fitted? And regarding or in terms of listening, what challenges do older adults face after fitting the hearing aid?
Yes, first of all, thank you so much for the opportunity given by the committee. So I just want to tell a small incident. When I came to Pune for June 20 to 21, so I met one ENT. So he or she said, "Ki you audiologists are very good in dispensing the hearing aid, but we don't really care after whatever happens afterwards. So we don't, as private practitioners also, we know how much revenue we are generating, but we don't know how many patients are really satisfied. So from that point of, from that day, I decided that satisfaction should be the central part of my practice. Now, what is satisfaction? Satisfaction keeps on varying for each and every person. Somebody is having just mild hearing loss, and his satisfaction will happen only he is having natural hearing. Somebody is having severe to profound hearing loss, he will be satisfied even if he is able to talk to two people in the house. So satisfaction is different for every patient. And you cannot measure it directly, but you can see when the patient meets you. Secondly, it keeps on varying. So today he'll be very satisfied, and after a week it stops working, and he is very unsatisfied in the morning. And or he goes to some program, there he thought that he will be able to hear, and that realistic expectation is not there, and now he is unsatisfied. So this satisfaction also keeps on varying. We can never say this patient is satisfied. We can say this patient is satisfied today, right now. Tomorrow we don't know. So it keeps on varying. So
But I think, just to interrupt, see, patient is wearing the hearing aid in multiple situations. So he is going to measure in terms of all the situation, all his listening situation, and what he is looking is my all listening situation should be fulfilled, is what I feel. So in terms of that, he will be measurable. Definitely, he'll be able to listen at home environment and everything. But few situations might be challenging to him.
True, true. So it depends, as you rightly said, it will be challenging depending upon his audiogram, which hearing aid he is working, and what is his expectation from that. If he says, I'll go to the Khan, and I should be able to hear everybody is whatever is happening, whatever is everybody is saying. So it is not possible. So it depends on many things. So from that, first so my satisfaction, you can say, protocol started evolving from the day one, how we should do the follow-up all the patients. So first of all, I started integrating the phone follow-ups. So once the patient is fitted, next day only first follow-up call goes. Have you opened the box? Have you started using? So there is again, see, whatever counseling we do on the day of fitting, they will remain only 10% of it. Okay. Next day they might also have a confusion ki lal konta kanal lavayache. So this is common. There's nothing wrong with it. If we are also explained, and again there are senior citizens, so we have to understand that. So first follow-up call happens from our clinic. This is done by reception, but I am present for every follow-up call. And the second follow-up call happens after a week's time to see if they are used to, and is there any, some of them have not even started. They are still waiting for some muhurta to start the hearing aid. So then the third follow-up calls happens on the first month, because I feel the first month is crucial. So 3 follow-up calls are more than enough. If there is any challenge, then we call them at the clinic. And then after every 6 months, we ask them to visit the clinic. At the end of, just before the warranty gets over, we call them for servicing, because typically you will see if nothing happens, they will not come to clinic. And immediately something happens after warranty gets over, they will say, "Arey, atta just warranty sampli and now it is not working. It's expense for me." So it is compulsory for all the patient, if machine is working, but warranty is getting over within the month, send it for servicing. Okay. So whatever minor issues are there in the company, the lab will take care of it. So this is one, but again, when I started doing follow-up calls, then I realized there are some common things which, there are some common misunderstanding patients have, or some common challenges they have. So I started video recording. So I have a YouTube channel. If you search Gore Hearing and Speech Clinic, Pune. So we have around 2 lakh plus views, around 2,000 subscribers. Daily we get call across India, at least 10 to 15 calls just for consultation. So there I started uploading the video. So first video is most basic, is the how to use any hearing aid. So it is BT, CIC, RIC, rechargeable, portable, chargeable, or it can be standard charger. All the videos are there. And after that, there are a series of 7 videos. अपने मशीन को, sorry, I forgot the title, I need to see. कान के मशीन को कैसे बनाए अपना दोस्त. So day 1, day 2, day 3. So every day talks about something very crucial. So day 1 talks about, we congratulate them that they have taken such a big step on purchasing the hearing aid. And it's how it is a new physical experience, how it is going to be new auditory experience, how it is going to be new emotional experience. So this is more often what we always talk about, the empathy. That this is okay, we are with you, this is new, we understand, but don't worry, we will always support you. So this is day 1. Day 2, I'll make it very brief. Every video is around 5 to 6 minutes. I think students can definitely explore. You will get a lot of insights. Then day 2.
So I think that students can explore it.
Yeah.
So just can you highlight what listening difficulties do the older adults report when they come for the follow?
See, yeah. So they have some typical challenges. आवाज येतोय पण थोडंसं आणखीन clarity पाहिजे. So we have to see, as per fine tuning, whatever is required, we have to do the fine tuning. Secondly, they are still not very confident about wearing hearing aids. So these videos on how to use hearing aids, that will help. Thirdly, it may happen that suddenly the machine stops working. So we give them the backup and we send for repairs. And at the same time, what we also integrated is, once somebody comes for any complaint, suppose today they have come, we want some fine tuning, and fine tuning is done, patient is satisfied at the clinic, but is he really satisfied at the level where he was facing the problem? So we call them again, everything is done in software. So all the phone calls are scheduled through software. So we get the task, and after 3 days, we again schedule a task that we have to follow this patient, and we again do a follow-up, so that we are very sure now the patient is again satisfied. And one more thing I would like to add is, we also do the tagging. So every patient we do tag. Is he fully satisfied, somehow satisfied, requires programming, totally unsatisfied? So these are the tagging. So at every point of time, I'm aware, okay, how many patients are really satisfied and how many people are not at all satisfied, how many people require more follow-ups. So this way, satisfaction is kept at the center of the practice so that, see, I just want to add last one thing. Satisfaction is very, very important, not for our own growth, but because still there are misunderstandings about the hearing. I won't say misunderstanding. There is a perception about the hearing aid that hearing aids are noisy, they don't really benefit, and माझ्या एका नातेवाईकांना लावलं होतं पण ते आता वापरत नाहीत. So this perception is there, and it's our responsibility to remove this perception. And unfortunately, it is not only depend on the hearing aid. It is a lot of things. What is the mindset of the person? How are the family members cooperating with him? What are his listening needs? What is the audiogram? What is the technology he's using? But I think the best thing we can do is to be with the patient and make sure that he should feel कि कुछ भी problem हुआ तो sir संभाल लेंगे, madam संभाल लेंगी. So like that, if we give assurance, I think then we can increase the percentage of satisfied patients. Thank you.
Correct. And also satisfaction depends on, I think, whether hearing aid is fitted unilaterally or bilaterally. And during the fitting also, we have to tell them some realistic situations like group situation. If fitted monoorally, they will be able, they are not able to follow the full conversation, and which is going to happen. Localization is going to get affected. So all these points should be explained when they are going for monooral versus binaural, or if we see that speech perception scores are poor. So during our fitting session, I think we should include all those points. So the patient have the realistic expectations from the hearing aid. Yeah, thank you. So moving on to the next question. So Nihar sir, do you believe that various prescriptive formulas can alter the sound quality or speech perception? So if so, what are the indicators when you attempt using a different one? And do you observe any change in patient's response?
Okay. So first thing is, as I was a product trainer earlier, so I have visited many clinics pan-India. So I hardly see that, somebody changes the prescriptive formula. So, which is very important. Like, you should understand if something is there in the software, why it is there. There is a reason behind that. And whatever product you see today, there is a research behind that for almost for a year or more than that. So coming to the fitting formulas, so I'll just tell you, like, majorly there are 4 formulas which is, followed by most of the companies. And they have a patented formula, which, it is the company formula, company-owned formula. So what are these formulas? One is the company-owned, and then you have NALR. Then the latest one of NL1 is NAL2. Then you have DSL V5. Yeah. So yeah, I think that's all. So in this, I'll how it is effective. I'll just tell you in brief. What I usually do. You have to understand, there is a concept that this DSL V5 is for most of this pediatric fitting. True. But what is the concept behind that? So the DSL5, V5, it means it is a desired sensation level. So it balances the loudness. Because in pediatric cases, you see all those, the higher frequencies are affected, or, most of these frequencies are affected, or at the higher end, where you need more gain. But the same thing can be applied to an older adult also. So that is one thing. Then why are you giving NL1? What is the benefit out of that? Okay, so the concept is, it doesn't give much louder gain at the higher frequencies. Hearing aids, like if you look at mostly senior citizens or older adults, they get a presbycusis, which is your high frequency sloping hearing loss. So, if you give NL1, where the frequency response is very much smooth, and, he will get a better clarity. So that is where, if it is a sloping loss, I would recommend that you can go for NL1. And again, as Sadanand rightly said, some people, you give some experience that, in the initial, maybe they have gone for an analog hearing aid. They have gone for some basic hearing aids. After 2 years of experience or 1 year, they wanted to go for a better hearing aid. So they are shifting from analog to digital. So it is like linear technology to non-linear. So if you give NALR, so which is like, it transits, or it is a transition period where it smooths from analog to digital. So that is where you can give NLR. But again, you all have like 5 to 10 minutes when you decide for a hearing aid, or you do the programming. Try to check all these features, change it and ask the patient. It doesn't take more than 5 minutes. One thing I can assure, if you do all these things, that client will be for you. You don't have to do any marketing to get those clients. So that client will be there for you. Thank you.
Also, something which we forget, in the softwares, always explore the entire software, what options are there. Also, when you put a RIC or a BT, there is an option as to check which dome you are fitting. So many of the time, it is the default dome that is there. So that is not the dome which you have put on the patient's ear. So usually what happens is, either it is a closed dome or it a vented dome. So again, if you change it and see, the prescription formula changes. The gain that is given changes. So always see the dome which you are putting on the client's ear, and then select the appropriate dome in the software. Also, many a times, patient themselves will report a stark benefit when you change the prescriptive formula. They say, yes, this is much better, I like this. So
in terms of sound quality, we
sound
see
quality,
a difference and
satisfaction.
perception.
As Nihar has perfectly said, it doesn't take more than 5 minutes. So when you explore the software, only then you will know कि हाँ ये change हो सकता है. Plus there is also an option of new user, experienced user, power, if you need a power in the gain. So when by default, it is always selected as experienced user. So for an experienced user, the gain generally is given at a little bit of higher level. So always these are small things that you can select in your software when you are doing the programming. So changing prescriptive formula, changing the dome size, changing the type of user, and also when you put the birth date in, it automatically selects whether it is a child or an adult. So that also helps you to get
Select the
prescriptive formula. Yes.
Thank you. Yeah.
Hello. I completely agree to the fact when the patient changes from a analog to digital hearing aid. But as an audiologist, we learn about the prescription formulas. And some companies, many of us would be at least dealing with at least minimum 3 companies. Few companies have their own formula. We need to understand that formula is based or formulated on which base formula. And suppose a patient is coming to me today and he's using A company. And I feel that A company ka next hearing aid does not have that enough power. I need to change him to B. I need to understand he's been using this hearing aid for at least 3 years. His memory, his coding has been based on that. I need to next change the formula which is as replicating to that if it is on the basis of NAL1, NAL2, or it is on basis of DSL. We need to change based on that. So it is not only from analog to digital, but between digital, if they're changing the brands and if they have a prescriptive formula of their own, we need to understand which is the basis and from where they have stolen and made their own formula. So this is very important.
Thank you everyone for sharing your valuable input. So now let's have a look at the patients who do not benefit from the hearing aid. So in cases of sloping hearing loss, when there is a limited benefit from the hearing aid, do older adults generally accept the concept of cochlear implant or technology of cochlear implant? So what is their perspective about it? So Sneha, can you address the audience about it?
Older adults, so typically they are around 60, 65, around those ages. When you pitch about hearing aids, first of all, the acceptance of hearing aids takes a little bit of time. So when you pitch about a cochlear implant, that also takes a little bit of time for them to say, हाँ operation करायचं है, हाँ operation ला किती खर्च येईल. Then it always comes down to the cost of the operation. And when you tell them the operation is not going to cure your hearing, you still have to wear a hearing or a machine or a processor. They're like, नाही मग काय मग आपण hearing aidच लावूया, ते better आहे. Also, older adults do have lot of metabolic disorders accompanying hearing loss, diabetes, blood pressure. So surgery in those cases also kind of can, be a risk factor for them. Some do have some, we need to get a clearance from an MD to suggest cochlear implants. Older adults, yes, you can suggest a cochlear implant, but the acceptance is, I would say, 50-50. At least in my clinic, in my practice, when I say, yes, there is an option of operation, but still I have to wear a processor, then I'm not willing to go for a cochlear implant. So I don't know what others are opining.
Add?
Sure.
Okay. So I have a lot of patients severe to profound hearing loss. So whenever in our software, we have the facility that suppose they're severe to profound, and if I know ki this can be a BAHA or a CI candidate, then we mark it as a CI candidate. I keep it in the follow-up. I try to tell them whenever they visit, this happens, follow-up happens, that and definitely we have to talk to the family members, but still conversion is not that happened. It's not, I would say, low. It's not that happened till now. So they may go for more powerful hearing aid. They may go for upgrades, and their expectation from the hearing aid are now okay. If I can listen to my Sunbai and in a Mulga, it's enough for me. So that's how it happens for them. So the conversion ratio for cochlear implant in older adults is quite less.
Yeah, true that. Yeah. So let's move on to the last question. So this is open for Shamangi. Do you want to add something?
This is a very debatable topic, and Vanajam will agree with me because I advocate for CI, and it is debatable between our audiologist also. First thing, how much do we know to tell it to and counsel to a patient about cochlear implant? It is just not you and the ENT. When we come and talk about if he is not benefiting with a hearing aid, the first stigma, how much is the cost? Above, if I take an older adult above 60, he is dependent on his son or a daughter or daughter-in-law. We also have a hiccup. My hearing aid minimum will cost around 1 lakh. My cochlear implant will start around with a surgery 6.5 lakh plus 1.5 lakh is 8 lakhs. Do I make an investment? And my top end cochlear implant will at least go around 19 lakhs. Do I make that investment? Now, I understand they also have comorbidities along with it. The power of counseling plays a very important role here. We are magicians. Audiologists are the only people who can bring back the sense of hearing. No one else can do that. We cannot bring back vision. We cannot bring back olfaction. It is only the hearing. Secondly, when the acceptance is difficult, not many of us are aware that cochlear implants are now covered under insurance, under corporate as well as under a retail insurance. HDFC Argo, ICICI Lombard, they cover 95% of your insurance. All the older adults are covered in corporate insurance or retail insurance from under their kids. The major problem of decision making for cochlear implants is because it's not between the patient and the audiologist, it is along with the caregivers. So the counseling plays a very important role when they come in. When you know that the patient is not benefiting with a hearing aid, if anyone has ever read about Delphi consensus, we say, and Dr. Kirtane has mentioned in the video where average investment a patient does of a 7 lakhs with the hearing aid is a basic cochlear implant available. So there are a lot of reservations amongst us as professionals also when we counsel, but we need to show them a bigger picture. They are not going to be dependent after the cochlear implant. They are going to be independent. First thing, they are not a baggage on their caregivers. They can work throughout it. Cost can be managed if the power of counseling works. Insurance is in place, and comorbidities come in factor. ENTs, the oldest adult operated in Mumbai as of now is a 79-year-old. Age is just a number. If the patient has the willpower and you have counseling skills, you can do it, and we need to understand what are his needs. If he doesn't desire to have good hearing, if he doesn't want to have, then don't need to push. But if he is independent, you feel he has a potential, yes, we can do, and comorbidities can also be worked up and can be seen in that case.
So thank you for the insurance bit. We did not know that. So
Yes.
this information is useful for counseling now. Thank you.
I have a doubt. Can I ask?
Yeah.
So insurance covers the only the instrument, like instrument cost or the surgery. So instrument has to be purchased.
So when I say 95% of coverage and 5% of processing is inclusive of your surgery as well as your device cost. So suppose if a patient is having a billing of 9 lakhs with the surgery, almost 7.5 and 8 lakhs are covered under insurance. I guess not hearing aids are also not covered under insurance, but cochlear implants are. So even for pediatric cases, if we have, they are covered. People get insurance covered at up to 25, 30 lakhs. So it's the power of counseling and we being educated about the situation.
Thank you, everyone. Thank you, Shamangi, for adding valuable input. So now let's move. So now let's move on to the last question. So this is open for everyone. So can you all address audience about what are the best practices in hearing aid fitting in older adults? So just to summarize, and what precautions should we take, starting from the assessment till the follow-up?
So I just want to share a very interesting anecdote with a patient of mine who was a IIT professor, and he held a PhD as well in engineering. So he had come for a fitting, and believe me, I was feeling I was sitting for a viva, starting from assessment till the time he went out of the clinic. I was like, बाप रे, इतना तो मेरा masters का भी viva नहीं हुआ, जितना the amount of questions he asked was beautiful. So you have to be prepared for these kind of patients who will ask you about signal processing. They will ask you about frequency transposition. They will ask you about feedback cancellation. They will ask you every little thing that is there in the hearing aid. Right from your assessment, he asked me about what is the use of outer hair cells. So I went back to physiology and I explained the entire physiology with the ion exchange. So you have to be thorough when you see these kind of patients. Believe me, these kind of patients do come to you. So this is what sets us apart from any non-professionals, that we have the perfect knowledge about anatomy, physiology, signal processing, how analog to digital conversion happens, how digital to analog conversion happens, how our ear is made up of mechanical segment, electrical segment. So all these become valid points in counseling. So this is the best practice that I believe I follow, that I explain each and everything. Why this is your audiogram? What does this signify? What are these frequencies? What difficulties will you face? What are the real life situations you will face? These are the situations where you will have problem. These are the situations where you will not have a problem. Next, why am I doing another test? Why am I prescribing another test? Why am I saying we'll get an emittance done? Why am I doing this? So these are the best practices I follow in my clinic, where I give lot of information on day one as to what is happening. Then I tell them, ki this is the next thing that we'll do. Maybe we'll go for a hearing aid. Oh, what kind of hearing aid? So I show all, these are the hearing aids available. This is what is available to you. This is what is not available to you. So then they ask me, why can't I have a smaller hearing aid? Then I tell them, you are not able to you try this. You try put it in your ear, try to change the battery. Can you do it? No. Then this is not for you. So then they agree, okay, hamala yet nena mi ठेवून देतो. Then these are the options available. So this kind of practice, if everybody can do, obviously we should always follow evidence-based practices, but clinically, when you have a waiting room full of patients, these are some of the practices that I follow, which focus on scientific, giving anatomical information, giving physiological information, giving information about technology at day one. So, and counseling, lot of counseling. So that IIT professor, believe me, now he's happy, he's coming regularly for follow-ups, and every time he comes, I'm like, आता काय question विचारणार है? So I read Dylan, when he tells me I'm going to come tomorrow, I'm again, okay, chalo, Dylan पढ़ लेते थोड़ा, चलो थोड़ा cats पढ़ लेते. So that also keeps me on my toes, and these kind of patients make me believe in best practices. So I feel the younger generation, when they feel कि anatomy is not important, physiology is not important, Believe me, you will get such patients who will ask you about ion exchange happening at the level of outer hair cells. So be ready for those kind of patients. Yeah, thank you so much.
Thank you, Sneha.
I would just, like to add few things. One is try to do a good otoscopy examination. That is one thing. Then the second thing is try to take a good impression. And, it is my experience, what I have learned that, always try to have a vent, whatever is the hearing loss. At least try to have a pressure release vent because you are blocking the ear. So, theoretically or somewhere we have read that, it is a sloping loss, so you don't want to amplify the low frequency, so that is where you need a vent. But what I have learned till now, you need to have a pressure release vent when you are giving a ear mold. So, for example, it doesn't work. You can block it anytime. Ask the company to make it a 0.5 mm vent, not even a 1 mm vent, and make it a short canal. So most of these clients will get happy with that. And one more thing is every hearing aid comes with at least 2 years of warranty. So make it mandatory or compulsory that these two within that 2 years you should send the hearing aid twice to the company for a free service. So that you should maintain in your Excel sheet or any kind of reminder that after if the hearing aid is getting in 2024 May, then you should give a call on March 2024 before 2 months. So the hearing aid comes with a repair and service from the company, which is free of cost. So it will have at least another 1 year. So the hearing aid goes for at least 3 years without any cost. So these are the points which I wanted to. Yeah, thank you.
Thank you.
Everyone has said every bit. I'll just give a take-home message and a learning from a patient. Patient walks in from US, sits in front of me, and has a very heavy accent because stayed in Britain and then in US. I start counseling. I was counseling not for a hearing aid, but was an older adult. He opens his mobile and he was sitting. I was so furious that he's not looking at me. He's not giving me an eye contact. What it is about? Each patient is a learning. If you guys have network, this is something very important as an audiologist for all of y'all. That gave me an idea. First thing, if I'm ever counseling a patient, you should have a hearing aid put on him after the PTA, so for your ease of counseling and for him to understand the process better. And the one thing I learned from him was speech to text. It was a live speech to text X-Ria app. I diligently use it for all my patients now, whenever I'm counseling, or even when I have pediatric cases and the adults, old like Dada Dadi are there and they have hearing problem, I keep it in front. It's translatable in Marathi, English and Hindi as of now, and some foreign languages. Plays a very important role if you have a tab or even normal smartphone, and it can play wonders in your counseling and while you're treating older adults. So this is one take-home message, and not something audiological but very important when you meet patients with that.
Thank you, Shamangi.
Yeah. So when we talk about best practice, I'll just say 2 points. One is most of the audiologists are still on a paper and pen practice. Okay, even Pani Puri wala have a digital bill book. So I think everybody should have a CRM, customer relationship management software. That's what they call an e-com. But we can adapt it, we can change it, and so that every patient ka all data is there. Whatever his listening needs, uske ghar mein kaun kaun rehta hai, what is his life expectations, what he wants to do in future in life, who has accompanied him, what was his listening requirements and expectations from us, including everything we should have in CRM. So this will keep us track of, and whatever fitting you have done, details, if you have done something different, suppose purposely you changed the dome after the first visit, so you can mention that. So this will help us to keep the track of whether the patient wants any kind of, whenever it comes for the next visit, you can always refer to that data. And secondly, we should adapt active follow-up approach. So till now, traditionally, it's like we have prescribed the machine, and now only if the patient has a problem, then only he'll come. But you will also observe that patient has stopped using hearing aid and you don't know. So, and only when you call them, then they say, हाँ नहीं आता मी वापरायला चालू करतोय. It is important. We cannot, blame them. कि, okay, you have invested so much and you're not using, because it is a very difficult or a different lifestyle change for them. So we have to be empathetic about it, and we have to do active follow-up. At least first 1 month is the most crucial. After once they are used to, then they will not live without the hearing aid. So CRM and active follow-up, they are the two important things for me. Thank you.
Thank you, Sadanand. Thank you everyone for sharing the key points for best practices. So now to conclude, when we before we start the hearing aid fitting, so when we are considering the audiological evaluation, I think along with the pure tone audiometry, speech perception in quiet and noise should be considered must before doing the hearing aid fitting. When we are considering the hearing aid fitting in older adults, a combination of advanced technology, selecting appropriate parameters, personalized care and ongoing support is vital in enhancing hearing and communication experience of older adults. As we continue to innovate and improve our practices, the focus must remain on the individual need and preferences of each patient, ensuring they lead a fulfilling and connected life. So let's connect our efforts to create a world where every individual, regardless of the age, can enjoy the gift of sound and communication to the fullest extent. Now, I would like to thank to all our panelists, Nihar sir, Sneha, Sadanand and Shamangi, for their invaluable contribution, and to our audience for patience listening. Together, we can make a significant strides in improving hearing health for older adults. Thank you everyone for joining.
Vanaja ma'am and every other professional who are dealing with RCI, I always feel that we should start business administration and management subject in our field. Because what happens, we are doing business. For example, if someone is starting his or her clinic after SASLP, he is just 24, 25 years or maybe less than that. And suppose he is doing business around 4 lakhs or 5 lakhs per month, not immediately, but maybe after 2 to 3 years. He is earning 50 to 60 lakh rupees per year. Now he is not wise enough to handle that money. This is true. He don't go into the library, he don't read the books regarding business analysis. I know everyone should have a specific audio and speech, whatever the clinic they are handling. They should have thorough knowledge with that. But if they don't have knowledge how to handle see, at the end, on March 31st, if you will go to your CA, he asks how much business you did. He don't ask ki patient kiti aale and kai nahi vicharat. So while discussing with CA, you are businessman. While handling patients, you are clinician. So you are confused. Whether I am dealing with a patient, whether I am a clinician, whether I am a businessman, I don't know. And that's why this kind of dilemma is there, ki whether to sell 5x or whether to sell 0.5x. So if my showroom is a Mercedes showroom, patient or person knows that I am selling Mercedes. It is not my duty that, yes, you can go with the Maruti car. You can, he wants Mercedes, that's why he is there. If he don't want Mercedes, he will go to the Maruti showroom.
It's a very nice question.
Yeah.
I have one answer for it. If I could answer.
I am not saying that someone is wrong or someone is right.
No, it's not a
just,
question of
I
wrong
just
or
want
right.
to say.
I have a nice answer for you if you want to listen. When I started my practice, I was as clueless as you are.
Yes.
Even if my father is an ENT, I still was clueless. Okay, because his style of practice and my style of practice is a little bit different. So there is one person who guided me very nicely. And I feel that if you meet such a person, it's good for you.
Yes.
He is a company secretary. So a company secretary is a very good person who helps you set up your
Yeah,
practice.
that is what I'm saying.
So I'm just saying कि in your context, it doesn't have to be a paid consultation. You have family members around you. Okay,
Yeah,
तुम्ही तुमच्या परिवारामध्ये जरा विचार आजूबाजूला.
And to add on
Wealth
this
manage,
now-
another thing, wealth managers or even asset managers help you distribute your wealth
Correct.
equally
Now,
and
that's
gain
what-
from it very nicely.
See, just to now, as you have addressed this to Anaja ma'am, on behalf of her, I'll try to answer this. So now, with this all this experience, we have actually added value-added courses. We have started with. So this value-added course is for SEM 6, which is on establishment of clinical practice in audiology and SLP. So it is not a part of curriculum. This is extra in which once, if you wish to start a new clinic, so about all these aspects what you are talking about, so everything is given orientation to students about all these things. Definitely practicality will be different, but at least they have some idea that how to deal with it, where to start with, and what all things they should be considered. So we have a very nicely structured curriculum for this.
Yes. When I started my clinic, I read all these books, business related, and I attended few seminars also, which were paid. One example I will give. They said ki there is one doctor who is doing very good marketing strategies and everything. He is doing very well. He is attending, for example, 500 patients. One doctor is there. He is not doing any kind of marketing, nothing, just his clinic is also a very basic thing. He is attending 500 clinic. So you have an option, which doctor you will go. Yes, because still he is not doing marketing strategies, he is attending 500 patients, but if he knows how to do marketing, then he can give benefit to thousands of patients. So, ये उसकी गलती नहीं है.
But I think this comes with the experience and how much that doctor also wants to do.
Yeah.
It will depend on the practice that.
Yes,
and
true.
Yeah.
But he should understand everything.
Yeah.
Like,
Thank you so much.
Yes, thank you.
I think if we keep discussing, this will continue till another for half an hour.
Do we have time for one quick question? Yeah. Okay, I'll ask it later then.
So that was a truly insightful panel discussion. I would like to thank Ms. Nikita Nanavati for her excellent moderation and to all the panelists for sharing their valuable inputs and experiences. So with this discussion, I can remember a tagline given by our brilliant MSc SEM 4 audio students. It was, hearing aids are not abnormal, hearing aids abnormal. Now, I would like to call Mrs. Shweta Deshpande ma'am to felicitate our moderator and panelists.
must be that display का कुछ
रुको अभी रुको व्हाट विल डू या हो
I think इधर ही है
इनका डिलीट करना है ना बस और कुछ नहीं है
हाँ ये USB का है ना
कोई नहीं बट ये डिलीट ही करना है ना और
हाँ
कुछ नहीं है।
मैंने इसमें किया है सब कुछ नया वाला में
आ गया real-world implications of the research we have been discussing by delving into the case studies. We will see how theoretical knowledge translates into the tangible applications. We will be having 3 case study presentations. For this session, I would like to call Ms. Rachna Panikar to moderate the session. She is working as a speech language pathology and deglutology at Jahangir Multi-Speciality Hospital, Pune. She has precious 12 years of experience and her area of interest are dysphagia, voice, neurocommunication disorders, neurodevelopmental and acquired neurological disorders and neurorehabilitation. Please welcome her with a big round of applause.
Thank you so much. Thank you to the organizers for this wonderful opportunity. I will try to do most justice, and I think let's all learn from the case presentations by the wonderful presenters today. First, I'd like to call upon Ms. Shruti Bilwadkar. Welcome. Hi. She has completed BASLP and MSc SLP from BVP SASLP. She's certified in Brain Gym, UNESCO certified Nritya therapist, consultant ASLP at Sampark E-Polyclinic Pune. She's proficient in managing and treating child speech and language disorders, primarily ASD, dysfluencies, AOS, CP, and ID. Hands-on experience of working with AC for children with special needs. She is she works for speech language rehabilitation for adult neurologic cases also. Many other allocates, including telerehab, which is a shared interest in us. So welcome. Let's hear your case.
Hello. So hello everyone, myself Shruti Bilwadkar, presenting before you a case, Journey from Struggle to Success, Overcoming Challenges in Adolescent Dysfluency. What is stuttering? We all know what stuttering is. Many pioneers in the field of stuttering have given different definitions, which altogether mean that it is dysfluency in speech with affected rhythm and rate. As stated by Sheehan, stuttering is just the tip of iceberg, and we need to dive deep to understand the things which are hidden and unseen in this iceberg. The case revolves around understanding these hidden factors. Who needs therapy? Children who are not showing spontaneous recovery in the age range of 2 to 7 years and have other factors like muscle tightness impacting their social work, their job, education, and impacting quality of life need therapeutic help. These are the case details of my client who was 18-year-old female and had history of delayed speech and language skills. She had family history of stuttering and physical emotional traumas in her life, which led to increase in the stuttering. Fluency was highest in Hindi and was lowest in Marathi. Formal tests were done on her, which revealed that client had very high scores in all domains of SSI-4, with a total of 37, and the speech naturalness being highly unnatural, giving her a diagnosis of very severe developmental stuttering. The overall quality of life score ranged between moderate to severe, concluding that her quality of life was severely impacted. It was observed informally that client had clavicular breathing and stiffness in neck and shoulder. Her MPD was affected, but DDK was normal. She had difficulty in saying words that initiate with vowels and had hard glot attacks and hard presses with her limbs when she was conversing. Diving deep into her case and interrogating more, we understood that she was bold and clear in her thoughts, but had no confidence to speak and put forth things. Parents were authoritative type and very protective. She had no friends, but had good father and daughter bond. Mother and client had typical teenager fights at home. Video recording consent was not given by her parents. Physical concomitants aren't audible in the audio clip, but she had hard glottal attacks, pressing hard of her hands, was not giving eye contact, had facial grimaces. You can notice the stuttering behaviors in her speech. This is her audio sample.
माझा फेवरेट हॉबी लायब्ररीमध्ये बसून बुक्स आणि तिकडं बसून फ्रेंड्स सोबत बोलणं आहे.
So you could notice that after every word she had pauses and her speech was very robotic. It was not natural at all. Moving on to therapy approaches, it included Barry-Guitar's fluency shaping techniques and stuttering modification techniques by Vaindraipa, that is Midwas. We all know the techniques. In addition to these, brain gym and Nritya therapy was given to her. Brain gym has a technique called PACE, and there are a set of 26 movements for brain refreshment and channelizing thoughts that were used. And the Nritya therapy technique of progressive whole body relaxation with music and dance movements to create rhythm and relaxation in body muscles was used. In first 5 sessions, with use of different pranayams, abdominal breathing itself, the client had reduced physical concomitants, frustration and strain. Struggle for vowels reduced, improving naturalness with help of fluency shaping techniques and Nritya therapy. She reported that she had started approaching friends and initiating short conversations with them within first 5 sessions itself. Stuttering modification techniques of Midwas were used in next sessions, that is 6 to 12 sessions. But to my surprise, approximation phase where cancellation pullouts and preparatory sets did not help her. So then we used DAF, metronome, or not listening to own stuttered speech by putting headphones in ears and listening to music when she is reading aloud. That were used. Coming on to challenges in therapy, we had faced challenges in therapy as she was young but adult. So therapist had to be her good friend, like an elder sister. The things which her mom was finding difficult to make her understand were explained to her in friendly way by me. She had no friends, so I had to work and improve her social skills. Parents were very protective, so I had to counsel both mother, as she's an adult now, and giving her some freedom. Self-understanding of good, bad, she has that, so give her that freedom. And to the client that she is not that old enough that she can cross her parents every time and say that I am old enough and I understand everything. So the next challenges were no tangible reinforcements would work for her as she was adult. So deep explanations about how and what needs to be done to this young, logical and inquisitive adult had to be given. Had to work on each and every issue which was seen on the OASIS scale that affected her quality of life. In every session, 3 impacted points on the OASIS scale were resolved by counseling. As she was preparing for very difficult exam, NDA, cognitively loaded games were also practiced. Counseling was a major chunk in the stuttering therapy, which included points like parent counseling about handling teenager, parent and child interaction, that all were done by a psychologist. Giving her confidence that therapist is your friend. I have been in same boat when I was of your age. Boosting up her confidence and having fun talks, a secret sharing was done in the clinical setup. To add to it, information about vicious cycle of stuttering, analogies, parental role, family environment and stuttering was counseled. Experience sharing was a reinforcement for her, as therapist also shared her daily life experiences to make her feel that she is not alone. And even I have stressful situations. Activities hierarchy begin with simple tasks like reading to most complex debates with strangers. Surprise tasks, role plays, exchanging mother-child role, cognitively loaded tasks were taken. This is her post-therapy session, audio of post-therapy session.
What is your name? My name is Riya Khoth. आता तुझं नाव घ्यायला तुला सोपं वाटतं का? Do you feel comfortable? Yes, I comparatively do feel comfortable while taking my name. Very good. Okay. Now, currently you are studying where and what are you studying? I am currently studying in Yashutej.
So could you notice the inappropriate pauses have gone and she is now having natural speech. So then when she progressed in individual sessions, we started her group sessions and there she got confidence and feeling that she is not alone, but she also has a scope to improve. This is a role play between her and her stuttering peer who had severe stuttering and difficulty initiating any sentence. Here we could see how effortlessly and naturally she is having conversation.
Bio, maths, upon that social ठीक आहे. चेंज नाही आहे माझ्याकडे 50चे घ्या.
50चे ॲक्च्युली माझ्याकडे पण चेंज नाही. तुम्ही गेल्या पॅसेंजर्सला विचारता का?
ठीक आहे. तुमच्याकडे चेंज आहे का 50चे? नाही, 100चे.
So last 4 sessions were maintenance phase where she learned fact that she has to be her own therapist henceforth. Follow-ups were initiated after months. In those problem solving discussions and overcoming barriers were discussed. And finally then we will have meet and greet sessions after 3 or 6 months. These are pre-post comparisons and you can see how drastically the scores have reduced and diagnosis changed from very severe to mild stuttering. I would say along with frequency scores, her physical concomitants reduced to great extent, giving her a diagnosis of very mild stuttering. These are her language specific audio samples, so I'll just explain. English was her most comfortable language, so there we could see that stuttering was the least. Marathi was her mother tongue, but she was not finding comfortable to speak in Marathi, so the stuttering was still there in Marathi, but compared to English it was more, but she could converse in Marathi nicely with everyone now. For the ease, graphics have been displayed on the screen to have pre-post comparisons, and all the graphs show that there is good improvement in her stuttering in the SSI-4 score, and this is for the OASIS. So her quality of life also improved post-therapy. This is a take-home message. Every person is different and needs his or her own specific plan. Detailed case history will solve most of your problems. Parents and family are most important in any speech therapy success. Social life, when improved, improves quality of life of that person. So thank you. These are my references. Any questions?
Thank you for that wonderful presentation, and I really laud that your documentation is so on point. So that's a great example for all of us, why it's important to document. Is there any question from the audience that we can take? Late. Oh, last, ma'am? Okay. I have a question. Shall I ask that, ma'am? Okay. I have one question for you, Shruti. There was a question about the modification techniques that didn't benefit as much, but I have a bigger question for you. When you saw that there's a dynamic, family dynamic that was causing or probably even aggravating the issue, we do handle it, we do counsel patients, we help them. Do you think it's important we refer out?
Yes, as in my case, the counseling of the child or the client was done by me, but for her parents, even though I am a professional, I have done my master's degree, but some of the times parents have this feeling, अरे ये तो छोटी है, शादी नहीं हुई है, कैसे हमें बता रही है कि हमें कैसे manage करना है. So along with my counseling, I also had to include psychologist with me to make her parents understand कि घर पे parent-child interaction कैसे होना चाहिए. So that was what the role of psychologist was in my role, in my therapy. And during the psychologist interaction with the parent opened up and told so many things to psychologists that there are the argument topics are so tiny that it leads to bigger problems, and then she faces problems the next day because she is into thinking of I had a quarrel with my mother yesterday and then my day is going to ruin and then I'm not going to feel talking like anybody to everybody. So then psychologist played a great role there and counseling her and her parent as well.
Thank you so much, Shruti. So we'll take up other questions later. We'll move on to the next presentation. Thank you so much.
something of the kind, and those are my future plans.
Sorry for the glitch. Now we will be going forward.
I'd now like to welcome Ms. Fareen Khoja for the second case presentation. She's completed her BASLP, MSc SLP, CFCCC SLP. She's currently working as a clinical fellow CCC SLP at Kirani's Clinic for Speech and Swallow, Mumbai. She's won awards like the Stroke Innovation and Excellence Awards 2023, the Manohar Memorial Award for Best Paper in Speech titled Clinical Applicability of a Frame Model of Cluttering Intervention, a Case Study 2022. She's certified in COSME and MOCA. Congratulations. Also ACE3, I see. Congrats. Welcome. I'm really looking forward to your presentation.
Morning, everybody. So today I'm going to be present a case on swallowing apraxia. So yesterday we heard the concept of what is apraxia, and now we are well versed with what is apraxia of speech. Similar concept goes on with swallowing. So apraxia of swallowing is the incoordination between our tongue, lips and chin movements to trigger the swallow. So it is mostly observed during the transition phase of the swallow, and this leads into the incoordination of the articulators and the tongue, and hence it does not trigger the swallow. So there are very few cases published, or there is very limited literature on how to manage this. We know how to diagnose now, but we don't know how to yet manage it. So some of the techniques that have been put down in literature are using compensatory swallowing techniques like head, back and postural adjustments, using transcranial direct current stimulation, using SAR foods, or use of PEG tube or NG tube for providing nutrition. All these have been published, but there is no evidence-based practice that we still have for managing swallowing. So due to this, its incidence is also rare and the evidence is very little. It becomes very challenging to diagnose it accurately. The incoordination that we see in all of these structures is often misunderstood as weakness in them. Hence, it leads to the misdiagnosis as oropharyngeal dysphagia. The intervention is then concentrated on reducing the weakness and strength training. Hence, this leads to longer recovery time and usually no progress is seen in the patient. So here I present a 70-year-old male. He was admitted to the hospital with a complaint of slurred speech and left upper limb weakness. The MRI showed ischemic changes to frontoparietal region bilaterally. On discharge, he was discharged with an RT. So this is his journey from start to end. The patient had seen 2 more therapists before coming to us, and 6 to 7 months has been passed and there was no improvement in his swallowing. Hence, he was transitioned to an PEG tube. The patient then had heard and was convinced that only electrical stimulation was the cure for his swallowing problem. Hence, he was referred to us. We did an assessment wherein the clinical bedside swallowing findings are here. Oromotor revealed no sensory deficits, good gag reflex, slightly reduced tongue movements. On swallowing on trial feeds, while giving him the feeds, we could see that there was pocketing in the mouth and he was spitting out the feeds whenever given. However, on observation, we could see that involuntarily he used to swallow. When lying down, he was swallowing his saliva. While sitting, when nobody is commanding or nobody is talking, he used to swallow it involuntarily. E10 was done and it revealed a very high score which gave abnormal swallowing function. Language was assessed and apraxia speech was ruled out. The patient could answer yes/no questions, could speak in sentences also. So on OPME, as we see, there were no sensory deficits and no motor weakness. And when food was in the mouth and when asked question that do you feel that the food is there in the mouth, he used to say yes. But when asked, did you swallow it, he used to say no. Gildat ka no. He didn't know what to just do with the food. So we did an objective evaluation of it. All the assessment that we did, the good clinical the good clinical bedside swallowing examination, a high E10 score, all directed us to a suspicion of apraxia or swallow. Hence, to confirm it, we did a FEES. Here in the video, you'll be able to see that there is premature spillage, valvular pooling, forward the video. Here in the video, we can see that the food will reach to the valvula as it started to see. So we can see there is premature spillage. There was present of laryngeal adductor reflex, but still when the food touched the valvula and there was no initiation of swallowing. Hence, this confirmed a suspicion of apraxia of swallow. And when given cues for imitation or when the patient was shown how to swallow, he could clear out everything that was there. So that is how we progressed with our intervention. We used a mix of different techniques. First were the compensatory strategies that we gave to the patient, that is a head back posture and posterior bolus placement. This was given so that we could take advantage of the natural triggering of swallow that is present. Next was the imitation model that we used. The clinician used to sit in front of the patient and eat along with him. We used to give him auditory cues, visual cues, tactile cues, all kind of cues to help him swallow better. And lastly, electrical stimulation was given because the patient was convinced that this is the way to go. So we just placed the electrodes, no current was given, and this motivated the client to swallow more. Here we can see a video wherein the clinician is sitting in front of the patient and the bolus is given to him, and the clinician is eating, showing him how to eat, how to swallow, and he's just imitating. In the start here we can see that he's just holding the food in his mouth. He's not doing anything with it. When with the cues that have been given by the the clinician, he is able to swallow. So the intervention of the progression of food was as such that we started with semi-thick, moving on to water, to soft solids, and the 4th month was our observation period where the patient was taking everything orally and nothing through his peg tube. We then did a post-therapy assessment for phase. Here we can see that the patient can beautifully clear everything that is there. So with this, the patient was then weaned off his peg tube after the 4 months of intensive therapy. So there were some challenges that we faced here. The major were the fluctuating mood of the client. There were good days, there were bad days. Some days were so bad that he used to just abuse, he used to be violent, he used to not let anybody come near him. But the good factors in this case was that intensive and regular therapy was taken by the client and the caregiver support. They were so motivated that they were eager to, feed them also. Because many a times we see that the caregiver themselves are not ready to feed the patient. But here they were very much motivated and they wanted to feed him. So coming on to the conclusion, all of us need to be aware of this condition and need to know what the signs are so that we can establish a good diagnosis and then make up a treatment plan that will help the patient to get better. Thank you.
Thank you, Fareen. Amazing that you've brought out the importance of instrumental evaluation, just not depending on clinical evaluation alone, although it's a very strong indicator of the difficulty the patient goes through. What I need to ask you is, when we spoke about the consistencies that you've used, you did go from a thicker consistency and then to the thin and then to the solids. Can you just explain how you came to a conclusion and why?
Yeah. So the usual pattern of start is we go from water to semi-thick to soft solids to hard solids. This is how we usually progress. But here the major part was that he's not aware what to do and how to do. So we need to give a lot of cues. So using a semi-thick consistency will give us a lot of variations to do. Like we can vary the temperature, we can vary the taste, we can also vary the texture. So all this led to a better swallow and better motivation for him. So that is why we started with a semi-solid and then went on to the other consistencies.
Thank you so much, Fareen.
Thank you, ma'am. Thank you, everyone.
Yeah. Yes, Neha.
Did you seek any therapy or any consultation from anyone, or was he diagnosed, or any antidepressant or any
No, he was
management
not
was done?
diagnosed. His lesion, as we see, are in the frontoparietal and bilaterally. So his lesion were causing him to take care of all this. So along with our therapy, we were also counseling them. We were also using some behavior modification approaches, also consulting a psychologist as to how to go forward with it. But he was never given direct counseling with a counselor, like a psychologist, but we used to consult our psychologist and convey or counsel them accordingly.
How was his family support? Did his family support him in all
Yeah,
this?
the family support was amazing. The wife husband lives here and the son lives abroad. So even the son used to come on video call, motivate him. Everybody used to be there around. The caretaker and the wife used to be there. You know, you can do better, swallow, you can eat better. Oh wow, you've done so great. So the caregiver support was amazing in this case.
Thank you. Amazing presentation.
Thank you so much.
For the next case presentation, she has completed BA SLP, MSc SLP. She's currently working she was pursuing. All right, CCC SLP at Kirane's Clinic for Speech and Swallow, Mumbai. Her interests lie in dysphagia, aphasia, ANCD, stuttering, apraxia of speech. She's a BLS provider, Reiki provider, and a member of ISHA. She has also received awards to her allocates. So welcome. Looking forward to your presentation.
Hello. Yeah. Good morning, everyone. Thank you, ma'am, for the introduction. So I would like to start my case presentation. I'm going to be presenting on management of dysphagia in a patient with movement disorder. So the term movement disorder usually has hyperkinesis and hypokinesis seen, which is increased movement or reduced movement. Now, movement disorders and neuropathies, they share a very common neurological pathway, and all of this combined is definitely going to lead to disability, fatality in the worst cases, reduced motor performance, and obviously pain and neurological manifestations otherwise. So critical illness polyneuropathy and critical illness myopathy are severe complications that are seen when we are talking about the neurological system, especially in the motor and the sensory axons. And this in turn will lead to increased ICU stays, mechanical ventilator dependence, and this will lead to long-term disability. And we also seen a lot of coexistence of motor disorders in peripheral neuropathies, where you can see the orange box. So it's kind of a demyelinating neuropathy when we talk about CINM. So a 55-year-old patient, male, was seen with a history of diabetes mellitus, hypertension, chronic kidney disease. Status post CABG was he had a microvascular dysfunction with 6 grafts and 4 enderectomies. And his whole hospital stay was 4 months and 12 days. That is really a lot for a patient, because if one of us, our family members here to have a heart attack and go for a stent, you know what it would feel like. So I would like all of you to think in that way, that he had a hospital stay of 4 months and 12 days. EMG reports were suggestive of demyelinating neuropathy, possibly due to possibility due to demyelination. Number 8 tracheostomy tube was inserted in March, and a laryngoscopy was done in the hospital, where presence of myotonic dystonia and myoclonic jerks were present. TT was in situ with a urinary catheter, and he was also seen on a weekly basis for dialysis. RT was in place, and he required regular suctioning because he was not able to manage his secretions. And finally, the patient was seen for speech and swallowing on August 3rd of, August 8. Okay. So on clinical bedside evaluation, respiration was via the tracheostomy tube. He was able to tolerate speaking while trials no more than 2 to 3 minutes. Cranial nerves were affected where we could see the involuntary movements of the head, neck and the tongue. Voice was hoarse, asthenic, there was weak cough, and on 2 ml water trial and 4-finger test, incomplete hyolaryngeal excursion was present. On FIOS, level of 1 was noted, that is nothing by mouth. So we did a fees in September. Now I would really like to ponder on this because doing a fees earlier would not give us any more information. So also calling out a test is very important. We should know when to call out for an MBS or a fees. Not playing. Okay, anyway, moving forward. So there was showing you the clinical picture. There was a lot of vallicular pooling. There was pyriform fossa pooling. There was premature spillage, and the patient was aspirating. On PAS, the scoring was 7 was obtained, coming to a diagnosis of severe neurological oropharyngeal dysphagia. So swallowing intervention was planned where we planned on using NMES, that is neuromuscular electrical stimulation, along with direct therapy where we use the shaker's maneuver. Along with that, additional exercises like postural adjustments and passive oromotor exercises were given. We gave 6 days of therapy, 6 days a week therapy for 60 minutes each day. And this is what the session looked like. So initially we started with the NMES current, 10 minutes with a 5-minute break in between, followed by cuff deflation and corking. We also focused on speech because we just don't have to do swallowing as speech therapists. We also need to work on speech, followed by the oromotor exercise, and lastly, the swallowing. This is how we progressed for the food consistency. So for the initial 3 weeks, we just did water and get him to get that confidence that he's able to swallow. Next 8 weeks was done, we did semi-thick, and then for the next 4 weeks, because he used to really like cake, I think this was a major turn back in the therapy because he really liked cake. So soft solids was really easy, and after that it was just very fluent. So the hurdles I faced was using NMES and dystonia and psychobehavioral hurdles, that was fluctuating mood and patient frustration, of course. Prognostic factors were consistent therapy and caregiver support because the patient's caregiver herself was an occupational therapist, and she was very much vigilant, keeping in track of infections. So she used to, whenever we used to go for therapy, she used to provide us surgical gowns and surgical caps and, gloves and everything. So it was really nice. So here you can see the pre-video where we are giving NMES stimulation and we are also feeding at the same time. He's using little bit of a chin down, which is helping him. And he's able to swallow very nicely with the current. Now we see the post video.
फिर दूसरा लेना हाँ छोड़ दे
And this was the image. This was the image after the Riles tube removal. That's my colleague Fareen and Miss Nikita Kirana. Okay. Follow-up clinical evaluation was done in December, where respiration, he was able to tolerate 100% tracheostomy block for all waking hours and sleeping hours. OPME had improved lip, tongue, jaw movement, improved range and accuracy. There was significant improvement in voice as well. However, now we were at the stage to actually diagnose. So we came to a diagnosis of flaccid dysarthria because there was bulbar component. Cough was strong and swallow had a complete hyolaryngeal excursion. So on diagnosis, a normal swallowing function was reported, and on penetration aspiration scale, a scoring of 1 was given. the patient vocalizing. So to conclude my presentation, management of dysphagia and movement disorders is much more complicated when it comes to classic dysphagia management post-stroke, and you will see a lot of hurdles. So this case also displays interplay between the neuropathies, movement disorders, and dysphagia when we talk in context of CINM. And this has showcased improved swallowing function and safety and quality of life of the patient. Thank you.
Thank you so much, Kripa. Are there any questions from the audience? Okay. Yeah, for any of the presenters, please.
Yes.
Yeah, just a suggestion. Very nice presentation, Krupa.
Thank you.
One thing also, I guess, in future cases, if you find again something like this, it will be good also if you can track the SEMG, the surface EMG.
Oh, yeah.
So you can actually get a day-to-day tracking of how much improvement is happening over time on the muscle.
Correct.
Okay, and also you will get a visual feedback which you can give it to your patients. So that helps in motivation of the patient also, in order to understand how the muscles are actually individually functioning and how much he is improving on a day-to-day basis.
Thank you so much, sir. Yes, I'll definitely look into that.
Kripa, I wanted to ask a question. Can you tell me why did you decide to use NMES in this patient?
So, since we know that he had dystonia and that is a manifestation of movement disorder, and we usually contraindicate the use of electrical stimulation in movement disorders, for which we also got a clearance from the neuro. So the reason why we used NMES was because that he was really weak, and we know that traditional therapy methods would not be sufficient enough to get that swallowing power back. So it was really important for us to, really rely on the electrical stimulation.
This patient was seen at home visit.
Yes.
Yes. Was the patient seen bedside at all?
He was seen, but they were doing ice chip protocols and things like that, but it was not helping.
Okay. Thanks. Thank you so much. Any other questions for all presenters from the audience? Somebody wanted to ask for Shruti, the first presentation. Okay. Looks like no questions. So I think it's because of the amazing quality of presentations that you've put forward today, all three of you. Thank you so much for looking at your patients holistically. I think that's the biggest takeaway from the presentations today. And thank you so much for the opportunity also to the organizers. Thank you.
That concludes our session on case studies. A round of applause for Ms. Rachna Panikar for her excellent moderation, and to all presenters for sharing their valuable insights and experiences. Thanks to you, we all leave this session with a much clearer picture how research translates into the practical applications that can truly benefit the patients. Now, I would like to call Mr. Piyush Sone sir to felicitate Ms. Rachna Panikar and our speakers. Here is a riddle for you. I come mid-morning, a welcome sight, a pause for refreshment, a moment of delight. I offer a chance to chat and unwind, but return refreshed, a sharpened mind. What am I? Yes, it is a tea break. So have refreshments and please return in 20 minutes at 12:20 p.m. All right, everyone. May I get your attention, please? Welcome back from our refreshing tea break. I hope you all had a chance to recharge. We are feeling energized and ready to dive back into the exciting world of speech and hearing. Without further delay, let's move on to our next session, which promises to be a fascinating exploration. I would like to invite Ms. Mansi Karnad and Ms. Sakshi Pal to the stage to deliver a plenary session on the intriguing topic of bridging boundaries, journeying through natural language acquisition, and GLP insights. Ms. Mansi Karnad is Assistant Professor in Speech Language Pathology at SASLP. Her areas of interest are autism spectrum disorders, augmentative and alternative communication neurodiversity, neurodiversity affirming practices, relationship based therapy approaches. Once again, Ms. Mansi Karnad is Assistant Professor in Speech Language Pathology at SSLP. Her areas of interest are autism spectrum disorders, augmentative and alternative communication, neurodiversity affirming practices, relationship based therapy approaches. Ms. Sakshi Pal heads Speech Therapy Department at an inclusive school setup in Mumbai where she provides services to children with cerebral palsy and autism. Her area of interest are child language disorders, alternative communication systems, swallowing or feeding disorders, and cognitive communication disorders in adults. A warm welcome to the stage for Ms. Mansi Karnad and Ms. Sakshi Pal.
Hello. Good morning, all. I have lot of gratitude for two reasons. One, for giving me this chance to speak to everyone today. And second, I'm very thankful for the GLP enthusiast at college because a lot of things that I've put together is from our clinic and patients that come to us. We are the only clinic, I'm pretty sure, that has 14 SLPs that are formally trained in GLP. And we have one more that is trained under observation, so we are a team of 15. this is a topic that is very close to my heart, and I talk about it every chance I get. So, and now the only difference is I'm nervous more than usual because I'm addressing my teachers, my colleagues, my seniors, my juniors, my classmates. I'm addressing my students when I was a clinical supervisor, and I'm also talking to the students currently. So I'm extremely nervous, but yes, once I start talking, I think I'll feel better. We've divided this into 2 sections, so I'll be covering just understanding what Gestalt language processing is. I'll walk you through the stages, and then Sakshi will take over for what do you do when you find out that there's a GLP kid on your caseload. Yeah, so first I have an audio sample that I would want all of you to listen to, and I want you to tell me what would your label on your report be, like what behavior is this? Okay. Right, so it was na 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 na, and I said okay, and then na 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 na. So then our first thing is, oh, maybe I don't know the language, and that's why I'm not able to identify. But then the mom was there, and this child is a Bengali and English speaker. So the mom said she talks and I don't understand, it's not Bengali. Because I said the intonation seemed like it, but she said I don't know what she's saying. Think of a label. What would you write on your report, or just like when you're taking down notes? What would you call this? We are talking about just knowing communicative behavior, so we're not getting into the GLP stages, but what do we usually write? One thing that I have written as a student is I would write that jargon present, or I would have said irrelevant talk, non-contextual talk. I don't understand what the kid is saying, but there is something, so intonation present, but I don't know, meaningful hai ya nahi, like, right? So this is what I've been taught, and I've been taught by Tamil ma'am, and I don't want to convey it wrongly. Every behavior is communicative in nature. So whether it is verbal, non-verbal, it is even an eye gaze, it's that one sly look and then they try to be mischievous, all of that is communicative. And we've been taught strategies and we've talked about everything that I've written on the slide. But then when you say this, then what about the big echolalia that we talk about? Why is echolalia considered then? No, that's just meaningless jargon. If every behavior that you observe is communicative, and especially if it is verbal, then why is echolalia something that we say, oh, that needs to stop, right? So actually the categories of echolalia are divided on 2 parameters. So one, whether it is as it is, so as it is said, and the second one is whether it is immediately or delayed. So pure immediate, pure delayed, mitigated means altered, immediate or altered delayed, right? So then Korn et al. In 2022 did us a big favor. They looked up all the papers that talked about communicative functions of echolalia, and they said, here, if it is immediate, this is what it serves, like this is the purpose, and if it is delayed, these are the functions that it serves. So we don't have to go looking around because this is a systematic review paper that says, yes, there is purpose. So now when there's a behavior and we say behaviors are communicative and it is serving a purpose, then again, we must use it. And a lot of us have gotten this far. So I know echolalia, I'm going to put it in the strengths instead of challenges, but now what do I do with it, right? Or where do I take this? So the next thing would be talking about language acquisition patterns and not pattern. So the one that we have studied and the milestones that we have learned are analytical language processing, where we say that the first word comes and then there's grammar and then there's flexible use of these words and all of that. The one that I am concerned about when it comes to echolalia, or the one that we have to go back to, is Gestalt language processing. So if you think that, oh, we've never heard of this, this is a new concept, that's not true, because we learned about cognitive processing top down and bottom up. So when we talked about that, that's what we were saying. And when we said that, oh, you know, these kids, I need to do experiential learning and I need to do script training and stuff like that, we were acknowledging that, oh, their processing patterns are not the same. right? So this is not new. You all know this. Or I'll ask Navya ma'am to like say, yes, I've taught this. So analytical language processing, the milestones we know, and we are aware of what kind of approaches work there. But now in Gestalt also there are milestones. So the similarities being there are stages in ALP and there is a stage hierarchy in also GLP. And very important is that both of these patterns are going to lead to self-generated language. Because this kid is a GLP, he is not going to be able to speak in sentences is not a thing, right? If you go through the stages, if you guide the child through the stages, they are going to get to self-generated language. So what are gestalts? The stage 1 would be gestalts where everything is repeated as it is because I attach emotion to it. So every time mama gets angry, she said, pitai ho jayegi. And then the child lost a toy and needs to find it and says, pitai ho jayegi, and is looking for it, means he's angry. So I associate the emotion and the phrase that has been used repeatedly with it, right? So I will also show you how sometimes irrelevant talk actually makes sense. So these are episodes of life and these are soundtracks and these kids are more music intonation inclined, like, you know, they have likings there. Now when I play the audio. Okay. Right, so it sounds like there's a sentence, it sounds like she's heard something, she's probably associating it and saying it. What we have to remember is they're trying this big of a sentence. And their sensory, motor, phonological development is not enough to produce a intelligible utterance. So they are saying whatever they can and we are trying to make sense of it, right? It's easily identified by us if there's intonation like, and then you say, oh, that's wheels on the bus. But that's not the same thing for sentences that a person says or dialogues picked up from a movie. Okay, so I will now label it unintelligible gestalts and I will say that this child seems to be an intonation baby, right? Then the next thing, these are some examples from our cases. So if I pick out, or the child wants to play with animals, he looks at me and goes, B-I-N-G-O, B-I-N-G-O, because he's saying animals is what I want to play with, right? Or if I have played with the kid only by saying, Pika, 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 boo, and the child wants to play, they will not say Pika, boo, or they'll not say play Pika. They'll say Pika, 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 boo, because they're asking me to play that with that kid, right? Then the next thing is Peekaboo ICU is a name of the game. It's not Peekaboo and then ICU. It is Peekaboo ICU as one whole unit. Then this is one interesting thing, and I've put my friend's name because I had to hide the kid's name. I just wanted her to be a part of this somehow. So if the kid is crying and fussy and goes, Siddhi's a favorite laun there, Siddhi's a favorite video laun there, that's because the mom has been repeatedly doing this. This kid is cranky, baban kade phone deo, favorite laun there. Right? So Siddhi's a favorite. So now I am upset, I need comfort is Siddhi's a favorite video laun there, Siddhi's a favorite video laun there. But means hug me, pick me up, hold me, I don't like it, right? Then there's Gol Gol Firwa. So on a merry-go-round, Gol Gol Firwaitsa, and on the swing also Gol Gol Firwa becomes a thing, but you're not going in circles on the swing. Then the child talking to themselves constantly. So you say there's a lot of speech. कार ये वो बहुत बोलता है but हमें नहीं पता क्या बोलता है खुद से बोलता है. They talk to themselves and we don't know what it is. That's because they've not gotten a response from the outside world. So they're saying it to themselves to make sense of play and their own experiences. So stage 1 I think is clear. I'm rushing because I want to keep like the 15-minute thing. Stage 2, now here what happens is they realize, oh wait, this big thing can be broken down into chunks. So now I don't know to word level, but I'll break it down into pieces somehow. So maybe instead of A to Z, like A, B, C, D till Z, now it only becomes about A, B, C, D game. So I want A, B, C, D. ABCD day, ABCD mala paije, can become a thing because now they are attaching just that part of the thing. So here again I have an example. Did I finish 15 minutes? Oh my God, I'm so sorry. So, mm, yeah, let's just then listen to the kids.
मुंबईला गौरव मामा इनाम गावला गेलाय.
Mama Mumbai kira. Mama Mumbai kira. Mama Mumbai kira.
इनाम गावला.
Nala. Mumbai mama.
गौरव मामा इनाम गावला गेला.
Right, so now the utterance is Mama Mumbaila Gela. Now they're going to make sense of it and be like, I can change the name of the person. He is not associating it with everybody that goes to Mumbai. This is just people that have stepped out of the house. Right? So now the next thing would be.
दीदी सूत्रवाडीला गेली.
So it's like, Sattu Didi Mumbaila Geli. So that's the tempo that they're following when they say this. And now he or she is exploring with, I can change names of the people and it'll make sense that they've left the house. Stage 3. Oh no, so there are examples of stage 2 again where if in the previous session I have held the child, so this is these are all real case examples. When I held the child up and threw him on the beanbag and played with him and tickled him, he liked it. So the next time that the child came, he looked that the beanbag was far away. So he looked at me and goes, all fall down? Are we not doing all fall down today? And which is out of a rhyme actually, right? Or labeling the toys, everything black is Baba Black Sheep, or every sheep, whether it is white, pink, whatever, is Baba Black Sheep. So they have picked it out of the rhyme again and calling a star Twinkle Twinkle Little Star. Do you want a star? And you give a star and they say Twinkle Twinkle Little Star, or Twinkle Twinkle Little Star, just telling themselves that, oh, I've got this now. This makes me happy. Old MacDonald had a car because I'm playing a car, right? Making up lyrics to familiar tunes and saying saying I want to, you do it. So I want to is one of the frames that I know I want to drink because we script it so often. And then there is you do it. So they mix two. And it doesn't make, grammatically it may not make sense to you, but it's meaningful and functional. Yeah, so this is the previous one and then this one are case examples from Kuhu. I'm very grateful. This is my favorite illustration to use for stage 3 because it says cheese sock. And if I tell you cheese sock, there is no, like you would say Mansi's lost it now because 5 minutes are, I'm running short of time. But what happened was Kuhu appreciated that both of them were wearing colorful socks and the kid saw that she has a phone. So he said, cheese sock? Like, do you want to take a picture of the socks together? Because cheese, smile, take a picture, so all of that. So it doesn't make sense until you know your kid and know their experiences. And you say, oh no, what can this mean, right? So at stage 3 is when they come down to words. And they say, wait, I can put words together from different things. And I don't know the sequence or what order, but these go together and it makes sense somehow to other people. And, so this is one.
Okay, come. Mansi Didi, please help me.
क्या help करूँ?
Yeah, monkey hands.
Hand में put on my hand.
Put on my hand.
आपको पहनना है monkey?
हाँ, monkey पहनना है. I see monkey.
Oh, you see monkey. I want the monkey on my hand.
Monkey on my hand.
आ जाओ, आ गया. हाथ दिखाओ. You want to wear the monkey? Here, show me your hand. Push it in, push it in, push it in. Oh, there you go.
I तो आ रहे भी नहीं.
Yeah, so the first one, the sentence was अरे ये तो आ रहे भी नहीं. It is not grammatically correct in Hindi, but she's picked up from two places. अरे ये तो आ whatever, and then nahi is another thing that she's picked up. So ye little finger aa raha hai, all the numbers are the stages. So this kid you see is using a mix of all the stages and whatever they are most comfortable at is the analysis, our processing at would be at up to 50% of utterances, and then they are experimenting back and forth. I am not stopping. I wanted to have this slide up because I wanted to show you that it's a lot of work in terms of language sample analysis. This is not something that we can escape. Unless and until I don't write and code these things, I will not be able to pick out at what stage do I support my kid at. So it is messy, it is cluttered, it is not organized, but that is what this approach itself requires. Then this is stage 4. Here she's gotten some grammar. So this is the same kid that I showed you the 1, 2, 3 of. And we were able to get to sentence generation. So it is possible and the support strategies work. And this is not a case that I've gotten from somewhere. This is a case that we worked in India, is a bilingual, all Indian cultural contextual factors taken into consideration. So we are not trying to, reach a goal that's not possible, was my point.
टनल में से चले गए ना,
टनल में से
अंधेरा हो गया,
टनल
इज ओवर, फिर से लाइट आ गई,
फिर मुझे अंधेरे में डर लगता।
आपको अंधेरे में डर लगता है?
हाँ।
अरे बाप रे, फिर हम टनल में से जाएंगे ना, तब आप हाथ पकड़ लेना मम्मा का।
हाँ।
ओके?
लेकिन मम्मा तो अभी आने वाले हैं।
हाँ, अभी आएंगे तब।
6 o'clock।
ओके।
अभी देखो 6 o'clock नहीं बजे।
नहीं बजे।
थोड़ा सा और टाइम लगने दो।
ओके।
हम 20 तक बोले 1, 2, 3, 4, 5, 6 फिर मम्मा आ जाते।
ओह, ऐसा है?
फिर हम नहीं रो पाते अगर मम्मा जल्दी आते तो। लेकिन वो सैड क्यों दिख रहा है?
Yeah, so then she was talking to me and spontaneously sharing and all of that, and she's like, फिर मम्मा आ जाते तो हम नहीं रो पाते. Actually, she means to say that we don't have to cry. She'll be here. You just have to count and she'll be here at 6 or whatever. So what she intends to say is my job to make sense of it. What she wants to say, she's experimenting and saying is her effort of making sense of the language that she's been exposed to. And stage 5 and 6 are then the usual grammar or syntactic things that we do. And then you can finally get to, okay, then we're doing the similar things. But up to stage 3 or 4 even, we have to be more mindful of what kind of strategies we use when we support a GLP. Take home message, I'm just done, this is the last thing. So now we say echoes have hidden meaning. So that means if I think it's non-contextual, it's not related, I don't know what this means, does not mean that it doesn't make sense to the child's sense of the world. Right? Modifications in echoed utterance means progress. He used to say wheels on the bus and now he's adding words that are not even relevant to it. So, oh my God, that's a problem, is not a thing. That means they are trying to move forward to stage 2. Data collection is key and echolalia should not be stopped or eliminated. So this is what we would want to remember. These are my references. Thank you for listening.
Good afternoon, everybody. I'm going to be talking about stages of language acquisition in children who are Gestalt language processor. Miss Mansi has already explained it so well, but I'm going to do a quick revision. This is a top-down model that we have in language acquisition. So here the child learns a lot of words and a lot of vocabulary and a lot of phrases, but makes meaning of every unit of the sentence later on in language acquisition phase. So the stage 1, as Mansi has already explained, let me just do a quick revision. So it's language gestalt, where the child is singing the whole song, singing the whole rhymes, picking up scripts from movies, shows, and from the environment. And so when you have a child who's looking at a picture book and sees a picture of a cow, so instead of labeling that it's a cow, the child may start singing Old MacDonald Had a Farm. So that's your stage 1. So in stage 1, you will have children singing a lot of rhymes, having delayed echolalia, saying whole scripts from the conversation that they have heard in between mom and dad, or the child and the father, or the child and the mother. And in stage 2, we have mitigations, where a child is mixing and matching combination of scripts that they have learned. For example, the child has learned mama is beautiful and dog is barking. So they have these two phrases as a script with them. And now the child sees a pretty dog or a cute little puppy, but the child has not learned these words, or does not have that in their repertoire of scripts. So the child will mix and match these two phrases, mama is beautiful and dog is barking, and may say dog is beautiful. So grammatically, conceptually, it may not be right, but here the child is making sense and expressing himself or herself. Then in next stage, you have isolated single words, stage 3. So here the child is again at 2-word level. You see, at stage 2 also the child is at 2-word level, and here at isolated single words that we're calling. So the child can here be at single word level or 2-word level, and sometimes even at 3-word level. So the child may use words like dog sit. So the child is using more of referential words here. So dog sit means dog come here and sit. So that's your stage 3. And stage 4 is original phrases and beginning of sentences. So the child may again use only keywords, and the elements or the syntax may not be grammatically correct. So the child may say, dog sit no dirty, which means dog, please don't sit here, it's dirty on the floor. So here he's beginning to use sentences but not grammatically correct. Then at stage 5 and 6 you have more sentences, and with grammar getting better. So you can have a child like Mansi already showed an example where the child was in 3 stages, stage 1, 2 and 3. So your child can be in multiple stages at the same time. So that's why you need to have a language sample with you. So over a period of time, over a few sessions, you need to audio record the session and write down each an utterance that the child has had. And you need to associate meaning that for this the child said, so it's probably stage 3 and not stage 1. So you have to understand this well, because you need to formulate your goals based on at what stage the child is at. So now let's see what we need to do for children who are Gestalt language processor. One very important thing is, which is rooted into neurodiversity affirming practices, and that is doing child-led therapy, doing activities which are of child's interest, so that you build good rapport, good communication, and good trust. So the child is able to trust you, is more free, and is able to be more comfortable with you. So first thing you need to do is acknowledge communication. So if your child is at stage 1 and singing throughout, so you can join in the child and sing the rhymes with him or her, or you can smile and nod or repeat what the child says. Focus on the intent of why the child is singing a particular rhyme. So a child may sing Old MacDonald had a farm way too many times at home, but is singing Wheels on the Bus when outside. So maybe the child is exposed to a lot of pictures of animals through flashcards, through books, through movies, or just general objects at home, toys. So the child is constantly getting reminded of animals, and he wants to comment, and hence the child is singing the rhyme Old MacDonald had a farm. And the child is singing Wheels on the Bus too many times when outside, because he's constantly seeing buses or vehicles with wheels. Next is use pronouns, used person first pronouns. We already use self-talk and parallel talk language stimulation technique. But when we are doing that, suppose a child is swinging. So in traditional method, what we do is we say, oh, Ria is swinging, Ria is enjoying swinging, the swing is going up. So instead of saying Ria or she, you can use I, because the child is picking the script that you are saying. So use I always, and build on echolalia. Every echolalia that they have definitely has some meaning attached. So build on their echolalia. So again, use stimulation techniques like recasting and rephrasing. Identify context, why a particular script is being triggered. So you need to understand why the child is saying that particular thing. Use core words. For example, if you want to say your child is looking beautiful or handsome, so instead of saying, oh, you're looking very handsome today, you're wearing a new dress. So instead of using too many phrases and too many words, you can just use simple scripts like you look beautiful or you look handsome. And repeat phrases. So whatever your target phrases are, keep repeating them throughout the day and use it in more naturalistic manner when the child is actually doing some work or playing. Next set of do's are value echolalia that I said earlier. Use high frequency words. So a lot of times, vocabulary is our goal and we're using semantic categories, fruits and animal, vegetables. So instead of picking on, 30 fruits and 20 vegetables, we can only pick on which are more functional to the child. So we need to explore the environment or the food they eat and focus only on those particular high frequency words. And then expand words. So if the child just says come, so you can rephrase and you can say, Papa, come here. You observe and comment on the child, what he or she is doing. So again, you are doing language stimulation. Model simple phrases. And very importantly, take turns. A lot of times what we do in the session is we are talking to the child constantly and the child never gets an opportunity to speak. So it would be a good idea if we play along with the child and just stay quiet for a while, say about for 5 minutes. The child will have reduced auditory overwhelm. When the child is calm, the child will start speaking to you and you will have more opportunities to explore what the child knows. Use functional scripts. So a lot of times when we are asking something, it's just like, are you hungry? Are you hungry? Are you thirsty? Do you want to go to the washroom? We are asking questions. So rather than asking questions, use sentences. So for example, I want to ask the child if the child is hungry. So instead of saying, are you hungry? I'm going to take the child to the kitchen, open something and eat and say, I am hungry. And if the child is also hungry, he or she will ask for it or may repeat the sentence for you. So the child is picking the script which is more functional for him or her. Lastly, listen actively. Keep paying attention to what the child is saying because the child will move from stage 1 to stage 2 and you will not know. So your goals will not be valid. So listen attentively. Now here are some don'ts that you should not do with GLP. That is, don't ignore. Don't just say, oh, the child is just singing or just doing irrelevant talk. No, it has some meaning. So a lot of times I had a set of twin and they went for a vacation and I got to know what happened there because the child would just not keep quiet in the session. For about 5 sessions, she was 3.5 and she kept on saying the scripts. She kept on repeating conversation that the mother and father had, the mother had with the child. So basically, the mother did not allow the child to have more than 1 ice cream every day. So she kept on saying, no ice cream, no ice cream. 1 ice cream every day, 1 ice cream every day. This is what she kept on saying. So I just asked the mother that, did you not give her enough ice cream? So she said, yes, this was my rule. So this is just one example, but there were many like that. So I think I got to know about her vacation, like 30% of it I got to know through her script. The mother had to not tell me what they did there. So don't ignore their echolalia, don't dismiss, and avoid saying commands like say or repeat after me, tell. You say it, it does not work. We all know that. So there's no point saying say after me or repeat after me. And reduce questions. We do that a lot of time. We just open a book and say, what do you see here? What do you see here? Right? The child is not going to answer. So it's better that you start labeling. And keep it simple. Don't use very long and complex sentences. Keep them simple. Once the child is at stage 3, then you can start to use little more complex sentences. And don't take echolalia literally. Try to understand the intent and not the exact words. And don't force speech on the child. So for example, I've seen this a lot of time. I try to teach the child to use the word again if they want to go on the swing again. So I want them to say again, but they never learn. Instead, they use more, and it's fine. If the child wants to say more using gestures, that's absolutely fine. So allow the child to use a multimodal communication. So if you're working with a GLP kid, it does not mean that you have to only work on verbal speech. You can let the child use gestures, use alternative communication method. And avoid grammar lessons in the beginning. I would say avoid them completely until the child is in stage 4 or 5 or 6. And don't rush. It's going to take time. In my experience, if you have met the child at stage 1, it takes about 4 months or so for a child to progress to stage 2. And from stage 2 to stage 3, it may take 6 months or a year. And moving upward from that is really difficult for children who are autistic, but some of them do, so you have to be very patient, so don't rush and avoid criticism, especially in front of the child. So if you have any comments to make, it can be in private, and do not do that in front of the child, because the child is listening. Just because they are not expressing does not mean they are not understanding. So these are the do's and don'ts for the child who are GLPs. Thank you so much for listening.
Hi Mansi, it was a very good presentation, both of you. So I have a small doubt. When the child reaches the stage 3, so you have given an example of a child was telling, I count and mama will come and that's okay if she comes, something like that in Hindi she was telling. So it was grammatically incorrect. However, she has reached stage 3 using...
That was stage 4.
Stage 4, okay.
Yes.
So in that context, when child says long sentences in incorrect grammatical this thing, how our response should be? Is it just to
Right.
how it should
So
be?
when you don't know what to do, suppose now we've not known enough, or we don't know now what, I would just smile and nod and say, okay. I don't even use good job, very good, that's nice, you spoke so well as verbal reinforcers. We don't do that because that's what they pick up as a gestalt again. So we don't want them to do that. If you don't know what to do in that moment, just say and maybe imitate it after them also, they love it. So that they say 1, 2, 3, 4, 5, 6, mama aa jayegi, and I say 1, 2, 3, 4, 5, 6. No, try again or whatever, then shape it to something else. But there are support strategies for every stage, and in fact there's a website where all of this is freely accessible and you can read it up. It's called communicationdevelopmentcenter.com, right? And there's also like a free 1-hour tutorial that's coming up. So those kind of things, there is enough resources out there that is just available. But again, there are 2 challenges that we face, or I faced as an SLP. One, everything is in the Western context, which means it's all in English. And the examples and everything is non-cultural, non-contextual and all of that. So we have to sort of now see where bilingualism fits into this whole mix. And the other thing is, the kids, by the time that they come to me, they've gone through some portion of ALP strategies and they are then stuck at a stage. So think about it. If at stage 1, we've been drilling apple, banana, orange, that becomes my full gestalt. How am I going to break down apple? There's no app and there's no pill to make anything else meaningful. So those kids are stuck at that stage and we have to start fresh. And that's when we say open-ended play, lead, let the child lead, step back. Extension, expansions are not recommended. So if a child says big ball and you say, oh, the ball is big, but you rolled away. No, we don't want to do that at all times, because then we are just interfering with the repetition and processing and picking up. So there are a lot of ALP strategies that work against GLP, and if you're in a fix, the right way to go with it is just do whatever comes naturally, right?
Thank you.
So that's why, like, everything that I included was from Indian languages and stuff like that, because otherwise we would not relate to it. Like, if you have an example of, oh, popsicle, rainbow and stuff like that, our kids don't really, I mean, we don't know examples.
language, particularly Marathi?
So particularly Marathi, I think we have some clinicians working on Marathi with Marathi kids. I don't know where they are, but what we do is then just talk naturally like Gadi. Have associated gestures. Like when you enter the session, we say, "Chala basun खेळायचंय,
so
basun
that's why.
जेवायचंय, basun हे करायचंय." Because we don't say let's do something is not a thing
So this
in Indian languages.
this difficulty I'm
Atta
facing.
me, so now I
Huh.
is something we can use as a
Correct.
thing. Ki
Chala
fail.
is something that I'm
Chala
using.
is okay. And
Apan
also,
karuya, do you think apan karuya will
पण आपण something करूया.
हां, आपण काहीतरी करूया.
हां. आपण करूया then again becomes like a thing
तेच
that
थर्ड
we don't
पर्सन
do.
होतं ते म्हणून I'm just bringing it.
But that's fine. Let's, we is also okay. And fortunately, we are bilingual, so there's also a lot that you and I use in a mix, which is acceptable. So then we do a lot of that as well.
Okay, thank you so much. Excellent presentation, both of you.
Thank you, Ms. Kannar and Ms. Pal, for the thought-provoking exploration in GLP. Now I would like to welcome Ms. Sonal Chitnis for felicitation of the speakers. Now, let's move on to our next session of panel discussion on the topic of how satisfied are we with outcomes of cochlear implants. I would like to welcome Dr. Sharda Sarda on the stage to moderate the session. She is professor and HOD in audiology at SASLP. She has prestigious 18 years of teaching experience. Currently, she is also pursuing ICMR-funded extramural research project titled Audio-Vestibular Test Battery in Differential Diagnosis of Vestibular Disorders. Please give a big round of applause.
So I think we heard lots on speech language development. And I'm sure there are a few core audiologists sitting here who would want to hear now about audiological sessions. So let's move on to another upcoming topic and quite debatable with respect to how satisfied we are with cochlear implant outcomes. So I will call upon the today's panelist, Mr. Sarang Mistry. We have Mr. Ramji Pathak, we have Mr. Sunil Patil and Mrs. Swati Bhatt. So Mr. Sarang Mistry, he is BASLP passed out from BVP in 2010 and masters from TN Medical College, Mumbai in 2013. Right now, he is doing his private practice. He is quite actively involved in his private practice since 2014. And before that, he has worked at different setups like ENT setups and different civil hospitals at Dhule and different parts of the Maharashtra. His area of interest includes diagnostic audiology, hearing aid, and cochlear implant rehabilitation. I welcome you, Sarang. Second panelist is Mr. Ramji Pathak. He is an alumni of Sri Aurobindo Institute of Speech and Hearing. BASLP he has completed and Masters in Audiology he has completed from Bharati Vidyapeeth 2020. He is currently serving as Assistant Professor at Sri Aurobindo Institute of Speech and Hearing, Indore, MP. I welcome you, Ramji. He is kind of core audiologist because he's pursuing PhD in audiology from Sri Aurobindo Institute. He is very actively involved in teaching, doing research, clinical and admin activity. His area of interest includes diagnostic audiology, vestibular assessment and management, cochlear implant and no-bun hearing screening. I welcome Mr. Sunil Patil. I think many of us know him for his active involvement in the private practice. He has brought many positive changes in terms of private practice, and his career includes 13 years of experience. He has worked earlier in ENT setups, many corporate audiological clinics, government hospitals, and now he is running very successfully his private setup. He is also interested in clinical and research areas, and he has done publications, and he has also developed when he was associated with Bharati Vidyapeeth, the PB word list, Marathi PB word list. So I welcome you, Sunil, here. Now we have Mrs. Swati Bhatt. She has passed out masters from BVDU SASLP 2013 batch. She has worked for 6 years in Medal India Private Limited, and she is right now a founder of Earbuddy Hearing Center in Goa and South Maharashtra. So I welcome today to all our panelists. So we know cochlear implant. I think it's one of the, again, buzzword, and it is quite established, I would say, the line of treatment in audiological cases. We have seen the journey of cochlear implant development from its single channel implant, wherein it was always considered as second to hearing aids or tactile hearing aids, wherein the outcomes were very, very limited. And now we have seen that it has moved from single channel to multi-channel. We have seen that how the signal processing strategies have been revised from different, maybe from speak to Cs to As, and now we have FSP and high-res and so on. And we have also seen that the technological leap is not only in terms of the speech processing strategies, we have also seen the style of implants in terms of its size, in terms of its color, and we have, I think many of us also have studied in detail. Now, I think those who are doing masters in audiology, we have a separate paper on implantable devices. So we can imagine that how much improvement has taken place, that we have a separate kind of a subject wherein we study about the cochlear implant so much detail. It's not only cochlear implant, we do study other implants, but we know that the core thing goes into the cochlear implant. So yes, cochlear implant has been considered as one of the successful treatment option for many of the clients in audiological clinic. However, the question always remains that is it so successful that it is bringing out the equal outcomes and every patient is satisfied, or are we as a professional satisfied with the cochlear implant technology? Okay, so I will begin with the panel discussion. So my first question is to our, one second. So since we say that cochlear implant is bringing out miracles, or it is really giving a new life to many lives, okay? So how well it is it really so good, and what are the improvements or what all changes are happening in terms of different aspects related to cochlear implant we are going to discuss. So my first question is to Mr. Ramji. In terms of age of implantation, we all have learned lots about critical age and how it impacts about the speech and language development, and with regard to that we have seen that the age of implantation should be lowered so that we get better outcomes. I hope everybody agrees to that. And we have seen that the age is lowering down more and more because there is better success in terms of surgery, in terms of safer technology, in terms of thinner arrays, and so on and so forth. Okay, so my question is, with increasing, with more and more reduction in the implant age, are we achieving the expected outcomes in all the children? And how lower should be the implant age? Like we have seen that implantation happening at 6 months, 8 months, 9 months. So do you agree with the lowering the implant age? And are we getting the same outcomes in all of these cases where the implant age is lowered? So over to you, Ramji.
Thank you, ma'am. As also we have studied that the lower the age of any kind of intervention, it is not about only cochlear implantation, that we should go for cochlear implantation as early as possible. It is about the early intervention to any kind of disorder and all. But yes, if we go for cochlear implantation at earliest as it will be definitely beneficial. And as we counsel also to the patients and the parents that if you'll go for cochlear implantation at the age of 2 years or 1 year even, then you will have to do less work on that child, because even the nature is helping to that particular child. He will definitely learn from the environment, because siblings and peer groups. So I would definitely say as early as we can do the cochlear implantation, if everything is fine, like every criteria, and if child is matching with the candidacy, definitely we'll go for cochlear implantation at the age of 1 year. And even before 1 year, but definitely many people will say that it is quite risky because of surgical complications and also the proper training of the surgeon. So yes, I would definitely say yes for
Would
early.
anybody want to contribute in terms of lowering the age? Can we really be confident when we suggest a cochlear implant at as early as 6 months or 8 months?
Hello.
Yes.
Yeah. So, ma'am, I agree with the early intervention and early cochlear implantation. But before that, I would like to add, in this early term, many of the centers, being audiology or ENT centers, they are in a hurry.
Yes.
They always want to very passionate for doing surgery or switch on. And throughout my 10 years experience, I have seen many cases misdiagnosed and many wrong and unethical things they are doing. And after the EDIF scheme has come, launched by the government, even I'm proud to say that being a student of such a great institute, even for my PG and UG, somehow I get frustrated when we go for NRTs to attend the surgery or mid-procedure. After EDIF scheme, I feel many of the ENTs, they are also not properly trained for surgery. And when they go for cochleostomy and they go for insertion, multiple times, so many of the times we don't get NRTs also. And coming to the audiology part, when I say that when I'm going to counsel parents and when myself decide that this child should go for cochlear implant, always I ask myself, am I right? Have I done perfect diagnosis? Am I myself sure to that child should go for it? Because even when we go for BERA, we do BERA, many of the centers, they are just doing it perfectly and they are just giving diagnosis severe to profound, which is needed. So once we are sure and the child achieves his motor milestones, he is able to sit, he has the neck control, he is ready to wear hearing aids. Now the criteria which we decide, for example, the motor milestone should be there, proper diagnosis, at least the child should have worn hearing aid for 3 months, minimum 3 to 4 months. Even that is deleted. Many of the patients, they directly go for implant without using hearing aid. So I feel when we say early, then I feel professionally and considering all the factors, if it is okay, then only early.
Okay, so can
Ma'am,
it-
I'd like to add on to
Okay.
it. Now, whatever Sarang very well mentioned are the probably unethical or wrong ways of doing it. But if we look at the right way of doing it, there are a lot of practical difficulties. Once we covered yesterday that for intervention to start, it takes 6 months. One, after intervention starts, see, making a child below the age of 1 wearing hearing aids, ear mold is very difficult for a parent. So then we have to get 3 months of, then we have to find out whether it's benefiting or not. You know, we have to do BOAs or maybe aided ABRs, things like that to find out. So ye sab karne mein I feel a lot of time goes for us to be sure, and of course good therapy is also very important. We don't know what the child is doing at home. Is he sitting on the mobile phone or is he really, you know, are they practicing? So after all this, then we implant. So that's where probably earlier is a little difficult.
Okay, so I think all the panelists agree to the fact that there should not be hurry in terms of doing the cochlear implant, even though we know the outside scenario is quite different, as Sarang said, that as soon as you do the auditory brainstem response and you get no response, I mean, as soon as they see that the other professionals, I mean to say, there is no response on your ABR, it is like they feel that now, yes, this is a case for implantation. And therein, I think audiologists and other professionals who are involved play a very crucial role in terms of delaying the process of undergoing the implant immediately. So you have to defer, or maybe you have to convince your other professionals that how important for you to take little more time to decide upon it, okay? So that was a good discussion. So we move on to the next question, which is I would like to direct to the Mrs. Swati Bhatt. So we know that there are many advancements taking place in terms of cochlear implant technology, and one of them is different types of arrays. Okay, we know that there are many various types of arrays, and it has been well documented that with these arrays there are different outcomes. Okay, so how important it is to select the appropriate electrode array in terms of clients, especially when it comes to anomalous cochlea. Okay.
But all our nose sizes are different, then why will our cochleas have the same size? So there is a way in which you can get the size, an indirect method using the A value of the cochlear duct depending on the size of your basal turn. So now one size cannot fit all. Once we understand this, then the size of the electrode array is very important, because the limit of the lower frequencies is decided by the length of the array. Now, though it's being said, it's not very simple, because we know that speech discrimination is better if it's closer to the modulus, right? Then second is your insertion length is most important. You have to have complete cochlear coverage, because what we also need to do is matching neurotonotopicity, which we can achieve using full cochlear coverage, because we believe in some researches that the spiral ganglion cells are available after or around 680 degrees at least. Last, it should be atraumatic, right? Our insertion has to be atraumatic while insertion and while taking the implant out, because we know that implant is ultimately an electronic device. Sometime it has to be changed because of whatever reasons. So now, keeping this in mind, whenever we come across anyone with a severe to profound hearing loss, at least 20 to 30% tend to have malformations. Now, what are these malformations that we're talking about? First malformation is your cochlear aplasia or absent of the nerve. If this is the case, then probably we don't go for a cochlear implant, we would go for an auditory brainstem implant. Then is ossification of the bone. In cases of an ossification of a bone, we cannot go for a straight implant. You would require a short one, or you would require a one which has two branches. After that comes the common cavity malformations. Now, common cavity malformations, if your array is short and it's pre-curved, of course, you can't use it over there, because the kind of implant you would require is a one that can form a loop in your cavity, because here the neural elements will be across the wall because there is no modular trunk. After that, we have when in cases of malformation, there's a very strong chance of CSF gushing or oozing. That has to be dealt as well. So there are some implants which has a cork-like end at the end of the activation stimulation length, which can go and plug the cochleostomy. So after considering all of this, we talk about something called a unicorn. The unicorn is the most ideal kind of an implant. First, this implant has to be atraumatic, that means it has to be very flexible. However, if it's very flexible and it's not going in, multiple insertions is going to break it. Second, it has to be close to the modulus. But if it's a lateral wall electrode, it's straight, it can't be close, it has to be pre-curved. If it has to be pre-curved, it has to be stiff. Right? Their flexibilities are the picture. Last, it has to be easy to handle, because during insertion, the speed of insertion will determine also how much maybe there could cause a little bit of intracochlear trauma. Next is the translocation from the scala tympani to the scala media. We do realize that our electrode has to only be under the basilar membrane or in the scala tympani. And last is full insertion. So until we get our unicorn, we'll have to have a variety of electrode arrays. Thank you.
Okay, that was an extensive information. I think a lot of people got to know about that. There are different kinds of arrays. At least that much everybody got to know. And it is understood that yes, one size does not fit all. Okay. So the thing is, we all agree to the fact that yes, different people need different types of arrays. So we know that many of our recipients, especially at our institute or many other institutes, I know that they are receiving government funded cochlear implants. So is this provision provided to the patient in terms of choosing the different types of arrays? And if we are not providing, then are we doing the right thing with those clients? Can Ramji give some opinion on that?
Yeah, I'll just add, I think ADIP does not provide, however, because of the cost factor. But in some cases, like in, I think, Medel, the cost of implant does not change, depending on which, cost of the combination of electrode and implant does not change if you choose a different one.
Yes, in ADIP, even in RBSK, the two schemes actually I know only in children. So in RBSK also, they don't give you option of selecting the electrode array. It will be same because of the cost difference. So in ADIP, they are not providing, and even in RBSK, they are not providing. So you cannot choose the electrode array. You will have to go whatever they are providing. So yes.
So I think one point we come to the conclusion that yes, even though the different requirements are there, but it is not provided. So maybe the audiologists who are working for these schemes, maybe we can at least demand and put across to them that yes, it is needed and this should be also sanctioned under this scheme. So moving on to the third question, we know that there are multiple accessories provided along with the cochlear implant, and because of that the cost of implant also goes higher. And are we really telling about these accessory use to all of our patients, especially in terms of when the clients goes into the teenage or they start attending schools? Even though the accessories are provided, they are not immediately implemented as the child is young, but as he moves forward in his life and faces different problems, are we going back and talking the importance of those accessories, and what are the different accessories that are must to be given, because so many things comes along with the implant. So is everything to be provided, because everything is going to put a kind of cost a patient. So is everything required? So I would like to ask this to maybe Sarang, Mr. Sarang.
Yeah. So at the initial phase, when the baby goes for surgery, gets operated and we do switch on. Many of the companies, they are giving multiple accessories at the time of switch on only, because the main help of accessories is they are utilized to keep the processor safe. First is the safety, because if it a child, he's going to fall, he's going to run, he's going to play. So they are mostly used for safety purpose first. Second, when the child grows, mostly connectivity and being a barrier-free environment, they are helpful. So suppose if, and nowadays, all the things are becoming digital. Even children are using laptops, gadgets. They had online schools when the pandemic situation was there. So accessories are important. But for that, for example, if the child has been operated under ADIF scheme, or not all the processors are compatible with the accessories. So choosing it is the difficult at the different ways. So first of all, the processor should be compatible for same. And I agree, accessories, they do help in listening. And mostly most of the accessories like collar microphone or Roger, they help in improving the SNR, which is the most important thing in listening. And accessories, even the aqua kit, if they are going to swim, they are going to be in the rain. So to protect the processor, they are useful.
Okay. So would you like to add, Mr. Sunil, anything?
Yeah. So when we talk about accessories, actually one point which I would like to mention, especially the multi-mic, the remote mic which we can, attach with the cochlear implant. So that is a wonderful accessory. Problem with that is most of this, like we recommend that kind of accessory mostly to the children, wherein they can carry to the therapies and also in the school. So therapy, of course, like AVT therapists, they are well versed with the technology, so they they keep it, and it's very easy for them. Even the family, they use it. But problem comes when they go to school. So most of the teachers, they are afraid of about such devices, because they feel that this is something which is very costly. They don't want to take the responsibility. So in such condition, we should be advocating our children. We should also represent them to their schools, and we can also help them by helping them with writing a letter, that this is a very simple accessory. There is no much complexity involved. You just have to tuck it here. So that kind of confidence, if we give it to the teachers, so they will get encouraged to use it. Otherwise, simply I have got a patients, like parents complaining, they say, "Sir, we want this to be used in the classroom situation. You keep saying that, give it to the teacher, but teacher are not allowing it to come to the class." So I think there where we should write a letter, or we should talk to, I have personally spoken to the teachers, principals, and I have, told them that, please encourage class teachers to help the child, by giving them amplification through the mic. It helps the child a lot. Explain them what are the challenges they are facing. Just by getting the hearing aids, or just by putting the implant, they still struggle in the classroom situation. This will further enhance the child's listening capability. So that part we should, which everyone should encourage.
So anybody else wants? Okay.
Would like to add to it. In accessories, we also have to consider the kind of batteries that we're providing. Sometimes we give them the opportunity to use a module where you can use rechargeable batteries, then batteries that can be, tucked onto their t-shirts, which helps them maybe during traveling and all. And another are the dehumidifier kits.
Dehumidifier, okay.
Because in some places like in Konkan, Goa, Mumbai, humidity is a very difficult thing for them to take care of.
Okay. So I think not all the accessories are provided with all the implants, but I think we have to be careful enough to see what are the difficulties that child or an adult is facing, and I think we need to check if they have not been provided with particular accessories, if we can talk to the company people and procure those accessories and counsel, it will help the child to go a long way in terms of, and it will reduce the frustration of listening, especially in the noisy surrounding. So that is the conclusion. Okay, moving on to the next, the challenges in mapping and auditory verbal therapy related, follow-up related challenges, especially in government funded recipients and its impact on the outcome. I would like to ask this to Ramji, Mr. Ramji. What are the problems that we are facing in terms of follow-up for the AVT and the mapping? And what is happening with regard to that?
Thank you, ma'am. So, actually, there are some parents who are too much, concerned about therapy, and there are some parents also who are not even concerned about therapy. So, these problems are definitely there, but we'll have to counsel those. Sometimes what happened, it is not about that they don't want to come for therapy or mapping. It is about that they don't have money to even travel. They don't have money and they don't have even information that mapping भी कुछ होती है, ऐसा है. उनका कहना ये है that if once it is implanted, child will start listening from tomorrow or from today. So and after 1 year even government's providing therapy for free and mapping for free, and after 1 year, no, there is cost. They'll have to pay for mapping and all. Even in RBSK I'm talking about. In ADIP they are even paying for traveling allowance. I think they are paying, but in RBSK they are giving all the things are free of cost. Beginning from the assessment, they don't have to pay a single rupee. Full assessment is covered in this particular scheme, and 1 year for therapy and mapping. So sometimes it happens, even they want to come, but they don't have money and they cannot travel. So it is our responsibility to take follow-up to that particular parents and all. So it will be definitely beneficial for them.
How can we solve this problem, like this dilemma? We know that patient has been implanted, or we have only counseled the patient for the implantation, but due to whatever reason, they are not able to follow up. So whatever amount has gone into, like government has invested, if we are not getting the expected outcomes, then what are we supposed to be doing in such cases? How we can solve to some extent this problem? Can somebody say? Would Swati like to say something?
Ma'am, first of all, vigorous counseling, and when we counsel the patient for CI, I always feel let those parents miss to the patient who already have gone through this process. So many of the doubts they get clear. Even we are busy with the caseload and that. Sometimes we also may miss some point explaining to them, which they get to know from the another patient.
Okay.
And just to add the seriousness, we can tell them if you want the results as it is there in the another child, you will have to follow the procedure. There is no run away. If you run away, you will miss the results which we are expecting. And I don't think nowadays, when we say technology, science, the products, the digitalization, I think it is easy for patient to reach any place. Okay. If they want a bright future, they have to go, what I feel.
So in terms of counseling, as he's saying, we have to make sure that the counseling is done properly. And for that, the I think very practical solution that he has given is make the patient talk to other patient who is doing well, what efforts they have taken. And I think their steps, if they understand, I think that will motivate them, and I hope that they will get more motivated and they will do better. So maybe we have to take little extra time to find out which patient is having similar problems and how they have tackled this situation. And you can make the efforts to meet this particular patient who is undergoing implantation with the previously implanted who is doing well and who has also faced the similar difficulties. I think we should do that kind of advocacy by the patient itself. Okay. That's a good point. Moving on to the next question, that is challenges in accepting the cochlear implant in older adults despite of its known benefit over hearing aids. So I'm sure we know that there are many patients who are actual candidates for cochlear implant. They are fitting into the criteria of candidacy for cochlear implant, and they are not having adequate benefit from the hearing aid. But still, we always face the difficulty in counseling them. So what can be done about it? I would like to ask this to Mr. Sunil Patil.
Okay, so when we talk about older adults, now in older adults, cochlear implants comes into the picture when we have tried everything with them. We have tried all the different manufacturers, strongest hearing aid possible, and it's still not working. So in that case, now what to do? So most obvious answer should be a cochlear implant in that case. But as we all know, accepting hearing aid is somewhere now getting established. People have started in accepting hearing aid now, which is in good numbers now compared to earlier. So now again, when we talk about hearing aids, still severe category, it's fine. When it comes to severe to profound category, there where we struggle and patient also struggles. We struggle in the sense of giving him maximum benefit out of the hearing aids, and patient struggles by not understanding the speech. So there where we should be talking to patient about the cochlear implant. But when we say cochlear implant, now patient starts imagining something altogether. So in that case, like I would like to mention three of my patients so that you will understand how this whole process of cochlear implant goes in older adults. So the first patient, he's a 74-year-old. He got convinced. We did his surgery and doing fantastic. So in his case, he was a regular hearing aid user. He has been using hearing aids for almost 17, 18 years. I have been seeing him since last almost 5 years. So every year, that is a patient where every year he was spending 7.5 lakhs on a hearing aid every year. Every year, he will keep coming to clinic and ask me, Sunil bhai, kai now hearing aid available chhe? I would say available chhe, but it is, there is a technology has changed, but I don't think you will find so much difference. He will insist, you give me, I will try, let me decide. I certainly give him try, and he will come back and say that I want to buy it. Because he had that hope. New technology means something better definitely would have come. So that is the perception people have. Wherein I know that about understanding, his main problem is understanding, which is not happening, and that is not going to certainly happen with this hearing aid. But it's ultimately you have to go with patient's call. So one fine day, Shruti happens to be in the clinic, and she knew about this patient, and she told me, Sunil, that why don't you consider CI? He's the right candidate. Till that time, even it's a 3 years back case, and then I started thinking about it. Should I go ahead? Should I go ahead? Then we started seeding, about the cochlear implant idea in his mind, and then patient simply said, surgery nathi karwani. And then we got an idea that let's invite his family. Then his daughter came over. Daughter liked the idea. Then patient was still reluctant. Then we got an idea. Let's introduce him to adult who has done the surgery of the around same age. So cochlear company helped us arranging such candidate, and he got motivated, and that's how he got the surgery done. Now he is doing all good now. He's very happy now. So second patient, we are still struggling convincing him that he needs the implant, but patients simply don't want to do it. He still want to spend on hearing aids, but not on implants, because he himself is not convinced about the surgery, wherein when we talk about implant, then we have to give him the idea about implant. How does it look? How much does it cost? And what is the procedure? So when we showed him, there itself he said that no go, because the implant certainly looks slightly bigger. though it is something, the smallest possible available, but still he didn't wanted to opt for it because, the hearing aids, somehow we can hide it. Implant is certainly, it is noticeable. That is one challenge. Second part, family. Now, earlier patient family was somebody who got motivated and then they said that, no, let's do it. But this here, the patient is not getting support from the family and, they don't want to go for it. Now, the third case, I want to do the surgery. Patient is willing, but we can't do the surgery because patient is 94-year-old. So 94-year-old patient, he says that you do whatever possible for me. I'm here, let me do it. But there are very slight comorbidities, but doctors simply said no. At least in India, we are still not considering above 80 individuals. But when I checked with the cochlear company, they said that they have operated patients somewhere around 95. So I was quite motivated, and patient, he comes by himself. Patient has no problem at all. He comes by himself to the clinic. So we should not, age shouldn't have been the criteria, considering there is all physical criteria is good, his medical criteria is good, but somehow it's not happening. So these are the challenges, and at the same time, the cost of the implant, of course, that is a major factor. People are still, unfortunately, this cochlear, any cochlear implant company, they are expensive. So considering the cost, people are still hesitated. That is the primary factor actually. And second part is most of the adult cochlear implant, hearing aid users, they say that now I am retired. How much life I have left? That is something what they say. But I have at least half an hour session for that to convince them that age is not something which you should consider.
Okay. So I think we come to the saying that yes, you have different experiences with adult implants. Not everybody is going to get convinced, but you have to try at your level best. Maybe make the patient meet with the similar age patient and who has undergone, and probably some might get turned. But still in India, I think the acceptance is not so good. Moving on to the next, that is about the unilateral cases. We know that there are many unilateral cases getting implanted across the world, and I would like to ask this to maybe Mr. Sunil and both Swati, that is the cochlear implant really superior over bone conduction implant and over the cross hearing aids when it comes to unilateral implants, because we know that the cost, surgery and all those involved. So is it really superior as compared to your bone conduction implant? Should you really say about cochlear, should we really give about the cochlear implantation option over the bone conduction and over the cross?
Okay. So when it comes to unilateral hearing loss case, my obvious first choice is cross. Considering any age group, I have given cross hearing aid from 7 years till 92-year-old. All of them, they are doing fantastic. So about single-sided deafness and considering implant, even there are studies which mention that there was a wonderful study done last year 2023 wherein they took 85 patients with a single-sided deafness. Out of them, 17 were implantees, 37 were cross hearing aid users, and rest of them they choose not to treat their hearing loss. So when it is a single-sided deafness, people surprisingly people manage it very well actually. So so that is also one population we talk about. When the patient is coming to us and who is seeking for help, in those cases, of course my obvious choice is this one, cross. But study says that when there is implant done in a single-sided deafness, so those individuals, they are performing much better in terms of localization, and second part is better speech perception in noisy environment over the period. Like post 1 year, they perform excellently well compared to cross hearing aid users.
Okay, so study says that cochlear implants are
better. And one more
better.
part which is very important, that surprisingly they have found the individuals who have also got relief from the tinnitus when they got implanted.
Okay, so study says that they are superior, cochlear implants are superior, but I don't know if somebody has a first-hand experience with respect to comparing cross with cochlear implants in unilateral cases over here.
Unilateral cases, I think of recent they're pushing it quite a bit. So maybe abroad we could get cases. However, for CI, one thing most important is age. The younger the you are, I feel the most easier you can quickly, because what happens is that one side is normal and the other side is artificial. So you
Yes.
really have to, we have to talk about, how you're going to summate both those informations and then stay with it. So I think here age is going to come, and also willingness, of course, for cost factor, all of that. So with unilateral, other than cross, another option you have, of course, is going, as you mentioned, for the bone conduction. So in bone conduction, we are doing the same thing. We are stimulating the beta cochlea. There are two options. One is to go through surgery, and one is to use something like Adhere or the We Hear product that we had seen at Shark Tank recently. Surgery ultimately is injury. So people may not want to really opt for surgery when there are options available to not get a surgery done. With the Adhere, in Indian climates, it doesn't really stick to your skin, so there where difficulty is. And if there's a little bit of hearing loss on the other side, then maybe Bicross has much better acceptability.
So I think, as she said, maybe it's again debatable topic. We really don't know what is the best solution, but looks like bone conductions are superior than cross. But I think there needs to be more studies across, especially in India. And Adhere, as she said, is not really very applicable to the Indian conditions. So surgical bone conduction implant is the one option that we have. Maybe we can take questions later. The last question that we have is upgradation. We know that upgradation is always kind of required and kind of forced also by the different cochlear implant companies. They normally say that this processor is obsolete, it is no more existing, now you need to go for the upgradation. So is it really required? Because I remember two of our clients who are using the oldest implant, like oldest processor. Implant is of course not going to change, it is need not to be changed. So processor is the one thing which she is using the oldest one, and absolutely no problem she is finding, and no difference with the upgradation also, she says. There is no need as per that client. So why the companies are pushing up for the upgradation of implant? It is going to cause more, like it's not a cost effective option. It's going to cost a patient quite a lot. And how do you counsel in how do you counsel the clients for such benefits, and how do you go about it? Is it really required, is what I might, in all the patients?
So when it comes to me, what I usually like to give an analogy, simple analogy. So we all use mobile devices. So mobile also gets old in a couple of years. So there is definitely a technological degradation. But when it's, I think, in about our hearing devices, whether it is a hearing aid, whether it is a cochlear implant, upgradation should be encouraged when because we are dealing with the speech perception here. So we really don't know how good the microphone is performing, how good the amplifier performing, how good is the processor is performing. So speech perception, see what happens if the person is a long-term user in hearing aid. Definitely it happens that somebody who has used his old hearing aid for more than 7 years, 8 years, when you ship them to new hearing aid, they don't accept the new hearing aid because their speech perception is totally with their old hearing aid. So that should not happen. For that reason, I think upgradation is a better thing. But considering 5 years, 6 years, and if the family is well versed, we should recommend them. Considering is of course their choice. But considering speech perception, I am more concerned about that. Over the period, it should not happen that certain frequencies are getting deprived.
Okay, so I think government is again not providing any funding for the upgradation. So what anybody would like to say anything about it? This is the last thing. Yes.
When we consider upgradation, first we have to see whether the child is operated on one side or both sides. The main point is, because as you said, companies are pushing, and when I see my always the force is rather than upgradation, you go for other side implant. Because binaural, it is going to help him more than upgradation. But again, the cost factor. And another thing is, there are some limited centers which are providing almost 50% nowadays for another year operate.
Oh.
So when we consider the cost for upgrade and the cost for another year, after they get funding, it is the same. But because of the force from company side, and ultimately when you are a person and audiologist, you have to see which is going to help to your client rather than being financially involved in it. So I always go for other ear surgery. And unfortunately, recently I have lost 3 of my cases for suggesting the same.
I know. Other year means
They have been upgraded at other centers.
See, the point is, the question is why upgradation? Obviously, it's monetary benefit, right? So let's put that on the table. That is the one thing that is what motivates everyone the most. If, in my opinion, if it's working, let it be. But of course, the company has to manufacture those old products and then supply them. Those all things also they have to keep in mind. It's not a very easy thing to, because cochlear implants is not recent, it's going on since quite some time. Another question also that we have to see is how they're going to adjust, because now at today's point we are still in a generation who also maybe there are some single channel going around, single channel implants. When we say upgradation will give you, it's not true, right? When we get them to a multi-channel implant, we have to help them adjust. They're like, it's not loud enough. I had seen one where they're used to that boom, you know, and then right now there are better noise cancellation and they don't like it. They like that sound. So those are things also that we have to consider.
Okay, so I think
Hello, last one, ma'am.
Yes.
The sad part of EDIP scheme when it comes to upgradation, when they do the lot contract for providing implants to the government, right now we have AYJ. So what I've seen is the first lot, the first 500 patients, they have operated, they have digisonic implants. Right now, they don't have implants to provide. Suppose if the child is going for another ear surgery, so what they will do is the question. Another, they are not giving any upgradation. They don't have any upgradation only to their accessory. If the
So I think when we are counseling for the cochlear implant, somewhere we have to put them this point across that this will require an upgradation and this will be an expense over 7 years, 8 years down the line, and that is not been provided by the government. This has to be made very clear to the client, and I think that's where many a times I don't think everybody is able to put across, or maybe we are putting across but patients are not in a position to take it. So we can just simply write it on a paper, take their signature and attach it in the file, and we can show them later that, see, I had told you it's not like that, because many patients go actually hostile, sometimes they actually get very angry and due to different reasons. So I think we need to manage all their different ways. So this is what is my suggestion. Okay, so upgradation, again, different views. In my opinion, sometimes the upgradations are not required. If you really see, their speech and noise is also so good, they are doing so well, and parents are not really, for another 5 years, actually, they don't need it, so they can actually start saving when the child is really required. So when the company people are saying that no, you tell the clients to change it, you see yourself as an audiologist, is my client really requiring it? Okay, so I
one
think
point is good, ma'am, that now I can add one more extra line in my consent form about upgradation. That's a good suggestion from your side.
And I think we are having lack of time, otherwise there is lot many points to discuss about the reimplantation and so many so forth, but I think we'll end today's session, panel discussion, and thank you everyone for listening despite of being hungry, and thank you panelists for giving your valuable inputs.
That was a very informative panel discussion. I would like to thank Dr. Sharda Sarda for great moderation of the discussion and panelists to give their years of expertise in the discussion. Now I would like to invite Dr. C.S. Vaneja for felicitation of the panelist and moderator. Give a big hand. Big round of applause, please.
So we have afternoon session on vestibular disorder, challenges in clinical practices. And for this, we have today with us Mr. Sanket Karnik, Ms. Mumidha, and Mr. Sahil Sheikh. Sanket Karnik, he has done BSLP program from Bharati Vidyapeeth and then masters from Nair Hospital. He is working at Nair Hospital as assistant professor. He is teaching in UG and PG level students in clinical audiological aspects. He is owner of Karnik Hearing Balance and Speech Clinic. Then he has worked with Kokilaben Dhirubhai Ambani Hospital since 2018 till 2023. And he has experience in vestibular diagnostic evaluations and rehabilitations over 5 years and manage over 200 plus NRTs and switch-on cases. I welcome you, sir. Then we have Mugdha Akurdi. She is audiologist and speech language pathologist at Cochlea, Pune. And she is clinical audiologist at Orbit's Hearing and Speech Clinic. She has completed her master's from BVDU and bachelor's from Aliyevar Jung. Her areas of interest are diagnostic audiology, electrophysiology, assessment and management of vestibular disorders, and auditory processing disorders. Then we have Mr. Sahil Sheikh with us. He is currently all of you know, currently working as audiologist grade 1 at BVDU SASLP. He has completed masters from Bharati Vidyapeeth and bachelor's from Shah Medical College. His area of interest are assessment and management of vestibular disorders, diagnostic audiology, and electrophysiology. So should we start with our session? I welcome first Sahil, na? Mugdha.
Good afternoon, everybody. I hope everybody has had a good lunch and is ready to get into vestibular. So my topic is VEMS, part 1 of a 3-step vestibular plenary session. So I'll be focusing on assessment part. So just to check if everybody is awake, what VEMP is this? Who can tell me? OVEMP. Anybody else? CVEMP, okay. There's only one remaining now. MVEMP. Can we have a majority on one VEMP, please? No, this is MVEMP. Okay, let's hope by the end of this session, everybody will be more confident. All right, so these are the contents I'll be covering today. Now, when a vestibular patient walks in, this is the ideal neuro-otological test battery which we are expected to follow. We obviously begin by a detailed vestibular case history, which everybody knows, a complete audiological assessment, then we get into our subjective tests, then we get into VEMPs, followed by VNG, and followed by VHIT. So the subjective tests, which everybody is familiar with, so I won't be getting into this. I've just put up the names of the tests which we usually follow. That is Romberg, Fukuda, tandem gait, past pointing, finger to nose, diadokinesis, head shake nystagmus, and head impulse test. All right, everybody familiar with these? Okay. And now we come to the VEMPs. Okay, so 3 VEMPs we will be discussing today. The first one is cervical VEMP. These are biphasic surface potentials, and they peak at approximately 13 milliseconds and 23 milliseconds. Saccule is the organ which is activated, and then it is followed by a short inhibition of the sternocleidomastoid muscle. That is the CVEMP. Then we come to ocular VEMP, which is OVEMP. Again, a biphasic surface potential peaks at approximately 10 milliseconds and 16 milliseconds. Responses obtained by the utricle and are measured from the inferior oblique muscle. And then we come to masseter VEMP, a recently popularized VEMP. We have short latency biphasic potentials at 11 milliseconds and 21 milliseconds. Since MVEMP is something which is not known to many, I will quickly tell you the pathway. So the sound stimulus is going to activate the saccule. From the saccule, the stimulus is carried by the vestibular nerve. It will go to the vestibular nucleus. From there, it will go to the motor trigeminal nucleus. And from there, the mandibular branch of the trigeminal nerve will take it to the masseter muscle. It is an inhibitory potential. Masseter muscle will get activated, and then we will be able to measure the MVEMP. So the interpretations of CVEMP. Now, when we come to interpretations, there are 2 most important things which you are expected to look at. The first is the frequency tuning. The frequency tuning is where you get the largest amplitude and the shortest latency technically. So 500 hertz in younger adults and 1000 hertz in older adults is the frequency tuning you are expected to look at. Since amplitude is variable, what you should look at is the amplitude asymmetry ratio. So that is calculated by the Jonke's formula. In the modulus sign, you take right ear amplitude minus the left ear amplitude upon the right ear amplitude plus left ear amplitude into 100. So that amplitude asymmetry ratio, it should be between 35 to 40%. Moving on to OVEMP. Now the normative latencies we have already talked about. It is 10 milliseconds and 16 milliseconds. The frequency tuning can be 500 hertz or 750 hertz in younger adults, and it can go up to 1000 hertz in older adults. Again, the amplitude asymmetry ratio should be somewhere between 35 to 40%. And then we come to MVEMP. The frequency tuning expected is 500 hertz in younger adults and 750 hertz or 1000 hertz in older adults. Again, the amplitude asymmetry ratio should be somewhere between 35 to 40%. Now we come to the part which is most challenging for us. We all do VEMPs. Sometimes they are successful, sometimes they are not. So let's get into why they are not successful, why we face certain problems, and let me try to help you out if you're facing certain common problems. So we will be discussing about the pitfalls and the solutions for certain commonly encountered problems when it comes to VEMS. Now let's start with CVEMP. The first pitfall which you can get is the stimulus is not loud enough. So what happens that you get small waves or the waves can be absent. So the most important part, number one, should be that your system and your stimulus should be properly calibrated. VEMP takes a high intensity stimulus. So 95 dB NHL is considered as a starting point for CVEMP elicitation. But it may not be enough for especially older adults. So you should go higher, but not too higher, because then you have to consider how much sound exposure a person can be subjected to through the insert earphones. And secondly, normatives should be done on target populations. There are published normatives. You will find plenty of literature when it comes to VEMS, but every instrument is different. I cannot emphasize this more. So if you are doing a test, if you're collecting data, make sure you collect at least 10-year normatives is what I'll recommend. Second, muscle activity in SCM is insufficient, which causes small or absent or delayed peaks. Now in the image given here, you can see the difference. A weak contraction, I cannot spot any VEMP. For a strong contraction, I see a clearly demarcated P13 N23. Can you guys see it? Okay. So if muscle activity is insufficient, what can we do? We can decrease the EMG, but not by a large point. So if the head turn method is used, we can give a reference point to ensure a correct degree of head turn. Or if you have the patient's consent, you can press your hand on the patient's cheek and you can direct the patient to the desired degree. Next is huge electrical artifacts before obtaining the CVEMP response. It is given in the image here. So one might wonder, but I can still see the VEMP. So how does it matter if I am getting the electrical artifact? It may matter, it may not matter. If the CVEMP is very clear, it may not matter. But if it is small, you can confuse an actual response to an electrical artifact. So electrical artifact should be eliminated. So you check the electrode placement. You check the position of the sound generator. Sound generators can create big magnetic fields, and these fields induce large artifacts. Then insufficient number of stimulus repetitions. Let's face it, patients don't like when they have to look in a certain direction. You don't like when you have to stand. I didn't like it when I had to do it. So the easiest, most convenient option is let me take 50 to 70 repetitions. If I'm getting the response good, if I'm not getting the response, we'll see. So, but what happens is that EMG peaks can be mistaken as CVEMP peaks, which is what we see here. So if the VEMP is absent, okay, does not matter. But look at the image labeled C. So here, VEMP is present. Now look at what happens in 50 repetitions, 100, 150, and 200. For the EMG activity to average out, you do require somewhere between 150 to 200 repetitions. So do that so that you get clear, demarcated, replicable VEMs. Next is failure to account for neck muscle activation. If one SCM is stronger than the other, it creates a false sense of asymmetry. This happens, I have faced it, I'm sure you guys have faced it as well. If one SCM is stronger, there are a lot of studies which say that all VEMs have handedness, one side dominates over the other side. So it can create a false sense of asymmetry. You can be deluded into thinking that there is a pathology here. So you have to look at the EMG and you have to monitor it in real time. So you have to ensure that there is roughly similar EMG when you're doing both ears. You can repeat the trial with more or less level of contractions if necessary. SCM or any muscle for that matter does fatigue. So make sure that you're giving enough breaks, 2-minute breaks before every trial and a 5-minute breaks before every ear is what I would recommend. Now we come to OVEMP, insufficient upgaze. We've all had patients like this. So that causes small or absent responses. So just 5 minutes. So you can see the difference. If the upgaze is insufficient, I cannot see an OVEMP response in the first trial. But in the second trial, we see a clear N10 P15 response. So explain to the patient where you want them to look. Hold your finger up if required. You also get these vertical tapes which have degrees marked on them, so you can use those as well. Next is acoustic stimulus not loud enough. Again, what we discussed in CVEM. Normatives I would always emphasize on, but also note that the threshold for OVEMP is 5 to 10 dB higher than that of CVEMP. So keep it at the back of your mind when you are doing this. And then over-interpretation of absent AC OVEMPs causing over-diagnosis of certain otolith abnormalities. This can happen with elderly patients. This also happens in patients who are seemingly completely okay. OVEMPs you don't get, and then you are forced into thinking that there is some kind of abnormality. Please note that OVEMPs are associated with more false positives as compared to CVEMPs. So make sure that you do what Jerger told us to do, which is to follow a test battery approach. Correlate your results with the other results you're getting. That's why we follow an entire neuroautological test battery. Don't go on just OVEMPs. Okay? If you have to go on something, go on CVEMPs. And then MVEMPs. Now, MVEMP, the major problem, as all my friends who've been doing their dissertations will know, is that insufficient EMG contraction, response does not even start recording. So what to do? Now, there are 3 things which you can do, and I speak from experience. The first one is key EMG contraction for MVEMP is generated by clenching your teeth. So believe me, it is very difficult to clench your teeth for a long period of time. So you need to provide an aid to the patient. That aid can be a cotton ball, but I've had people tell me that you get a very strong gag reflex when you're holding that cotton ball for a long time. So a chewing gum can be used to get the desired level of muscle contraction. Again, a common problem is that should the person continuously be chewing, or should the person just clench and hold the gum? I suggest you leave that to the patient. Visually monitor the EMG in real time. If you feel there's a problem, you stop. Unless you're getting your response, all's well. Solution 2. MVEMP responses have a lot to do with electrode placements. So you make sure that you follow a thorough double cleaning method. First clean with an alcohol-based sanitizer, then clean with new prep, then place your electrodes, and make sure that facial hair and makeup products, they do interfere with MVEMP responses. So the ladies, make sure you wash your faces before coming, and men, just go for it. The next solution is check the patient's dental history. Now, MVEMP requires a normal stomatognathic structure, a very complicated word with a very simple meaning. Your mouth should be okay. So if the patient's wisdom tooth or molar tooth is removed or has cavities or has some issues, the patient will not be able to clench. Patients who are using braces or have used braces in the past may not be able to get the desired level of EMG. Now, this is experimental. We don't have published literature on this, but obtain the patient's dental history. If the patient has a dental history, is still able to generate a normal MVEMP response, well and good. If not able to generate a normal response, don't diagnose as a pathology. The next one is MVEMP responses not replicating in the second trial. Clenching is difficult. Prolonged clenching can trigger headaches. So make sure that you give breaks. When I was talking about CVEMP, I gave you an idea, 2 minutes, 5 minutes, etc. For MVEMP, it is entirely up to the patient. If the patient says 5 minutes, you go for 5 minutes. If the patient says half an hour, you can go for half an hour. A patient has told me 45 minutes as well, and I have given the patient 45 minutes. So that happens. I'm almost done. Now, this is a cheat sheet for CVEMP and OVEMP. I have mentioned different disorders and what are the expected CVEMP and OVEMP response. Since Ahil is buzzing, I cannot elaborate on this. And these are the clinical implications of MVEMP, since it is not very well known. Parkinson's disease, all VEMPs are affected, but MVEMP is most sensitive with smaller amplitudes. Multiple sclerosis, significantly prolonged MVEMP latencies, and for REM sleep disorder, you have significantly reduced MVEMP amplitudes. Thank you.
Good afternoon to all. So now I'll be continuing with the part 2, assessment of vestibular disorders, challenges in clinical practice. So basically in this presentation, I'll be covering the objective test, the VHIT and VNG, and what challenges you are going to face in the clinical practice. So starting with the VHIT, that we all know that it assesses the vestibulo-ocular reflex generated by the semicircular canals. It measures the corrective eye movement during an unpredictable head movement. We assess VHIT in 3 planes, which is lateral, RALP, and LARP. So how a typical head impulse matrix looks like. So first is the velocity should be greater than 100 degrees per second. Then angular extent should be between 10 to 20 degrees. Acceleration between 2000 to 4000 degrees per second square. And head to be turned at 45 degrees towards the posterior canal for RALP and LARP planes. The parameters that we generally assess are gain and number of seconds. And here are the normative gain values for all the canals. Now this is the typical image of doing a VHIT. Here is a difference between a normal lateral canal VHIT and affected lateral canal VHIT. You can see the gray lines in the left ear, in the left side. This is the blue one. You can see there is a gray line is very reduced. So it is indicating a reduced gain. After that, coming towards the challenges in VHIT. The first challenge, this is the most common artifact seen, which is bounce back. Okay, like whenever you are giving a jerk, your hand is coming back. So why it happens? The possible reason is stiff neck. The patient is keeping the neck stiff, and it can be clinician related. So what can be the possible solutions are re-instruct the patient, tell the patient to keep the neck loose, give the control to you, and controlling your force. Practicing more and more will improve your stimulation. The second, this is the second artifact which we see generally, which is higher gain values of vertical canals. Here you can see that this is the comparison of gain values for lateral and vertical canals. The left image is gain values, gain image for the lateral canal, and at the right side you can see for it anterior canal. You can observe that the gain values are much higher for the anterior canal. So what can be the possible reasons? So it is the improper calibration, or it can be because of the inertia of the instrument. And the solutions are repeat the calibration and develop a clinic specific normative, because you are not able to control the inertia of the instrument. Then there is a double pick artifact that we generally see when there is a hand touching to the strap, because we are placing it like this. Okay, so whenever your fingers are touching to the strap, it will result in double peak kind of things. And you can, this can be because of mini blink also. What can be the solutions are? Adjust the hand position. You can adjust your hand position, and after that re-instruct the patient to do not blink. Then this is an early response artifact. You can see the gray lines are much earlier than the red lines or the blue lines. Okay, so why this thing is happening? Because of the loose strap. If the goggles are loose for VHIT, early response artifact will be seen, and also hand touching to the strap. Because if your hands is touching thoroughly to the strap, it will move the strap before the head. And because of that, you will see the early response artifact. The solutions are tighten the strap and adjust the hand placement. So for this, what we generally do, we ask the patient, as soon as you feel the discomfort, you let us know, so that we have the perfect adjustment. Now this is a noisy waveform. Here you can see that in the right side specifically, at a peak there is a lot of noise compared to the left side. So what can be the possible reasons are faulty eye detection, poor focus by the camera, and higher hair density, specifically in the females. So solutions are reduce the light in the room. Okay, so if there is a improper faulty eye detection and you reduce the light in the room, the pupil will dilate and the detection will be improved. Then adjust the goggles to improve the focus. You can widen the goggles a little and put it again, so the focus will be improved. And for lateral canal, you can use the jaw placement rather than using the head placement. So for this patient, this is the image of the head placement. And now this is the image of the jaw placement. So you can see there is a significant reduction in the noise. Then this is the biggest challenge in VHEAT, that central pathology mimicking the peripheral pathology. So we all know that small pica and ica infarcts may cause isolated vertigo. A horizontal torsional spontaneous nystagmus beating towards the intact side and gaze evoked nystagmus towards the affected side is observed. We get normal hit in pica and affected hit in ica. The biggest solution is we can perform hints can be to rule out the pica and ica stroke. So this protocol is suggested by Kata et al. In 2009, where the test of skew plays a major role. If the test of skew is positive, it indicates the pica and ica stroke. Now we will move towards the VNG. So we all know that it assesses the oculomotor reflexes, vestibulo-ocular reflex, and also helps in distinguishing peripheral versus central vestibular pathology. And it includes a lot of tests like Sackett's test, smooth pursuit, optokinetic, gaze, caloric, and positioning maneuvers. So this is the typical setup for the VNG. Now moving towards the challenges faced in VNG. So the first is artifacts in recording. Okay, so you can see in the right side, there are fluttering kind of things are coming. So it is because of the improper detection of the eyes at the extreme. So they are at a particular extreme. So whenever the eyes are going towards that extreme, the detection is getting faulted. So what you can do for it, repeat the calibration or contact the company person for the software updates, because sometimes it happens if the software is older, this kind of artifacts are coming. Then the poor detection of the eyes. What can be the possible reason? The too small or too dilated eye pupils, and solutions are to adjust the brightness of the screen so that you can improve the detection. Then differences in the value of right versus left eye. This happens because of the improper calibration, patient not sitting in the center, or because of the handedness. The solutions are repeat the calibration, adjust the chair to the center of the screen, and develop the clinic specific normatives. Higher standard deviation in the normative values, specifically in the Sackett's test. If you see, there are 3 parameters: velocity, precision, and latency. For velocity and latency, the standard deviation is very high because there is a difference in the analysis algorithm of the software. And from one company to another company, the sampling rate is different, and because of that, across the company also you get a higher standard deviation. Then the solution is develop clinic-specific normatives, obviously, and do not rely on one parameter only. Assess other parameters also with the subjective analysis of graphs and the videos. Then difficulty in understanding tasks. Most of this happens with the optokinetic test, where patient is not able to focus on the center. So what you can do, you can keep your finger on the center, and after that when patient starts following, you can fade the prompt. For the Sackett test, most of time happens that patient anticipates. Patient predicts the Sacketts, and because of that, the prediction artifact comes into the picture. So what you can do, you can continuously instruct the patient to do not anticipate. And for the gaze test in without fixation, what happens that there is no light. So sometimes patients do not know where they are looking for. Where they are looking. If I tell them to look at the left side, they do not know where their eyes are. So what you can do, whenever you are closing the lid and telling them to look at the left side, you can just tap on the lid so that they will know that in this direction they are supposed to see. Then improper stimulation of the caloric test. So this is the most thing that we face in the caloric test. So it is because of the probe touching to the ear canal wall. So what can be the solution? First, you are supposed to ask to the patient कि आपको कान के पर्दे के ऊपर हवा फील हो रहा है क्या? Okay, so this is the most common thing that we do. And after that, with the experience, you will know that particular amount of noise comes when the air leaks. Okay, so that noise you are supposed to monitor. Endpoint nystagmus. So possible reason is the endpoint nystagmus. In the gaze test, without fixation, we see it. And sometimes we may misdiagnose as a pathological condition. So what is the probable solution is if the amplitude of nystagmus in without gaze, in without fixation protocol, if it is less than 4 degrees amplitude, it is mostly considered as a endpoint nystagmus. And for precise readings, what we can do, we can develop clinic-specific normatives for the amplitude and frequency of the endpoint nystagmus. Then issues during the positioning maneuvers. This is very difficult. We all know that. Why? Because during the positioning maneuvers, goggles may get displaced. Then patient may close their eyes and patient may feel nausea or vomiting during the test. So what we can do, we can tighten the goggles little more before the test, then hold the goggles with the help of fingers, give a mental task so that they do not close their eyes. And as soon as you complete the test, open the lid, give them visual fixation so that if they have induced vertigo, they will feel better. So these are my references. Thank you.
Hello everyone, glad to be here part of this alumni conference and presenting this major topic of management of vestibular disorders in front of my professors and fellow mates. So I'll start with the management of vestibular disorders. So as the topic says, from theory to practice. So it's like the practical aspects of how to provide rehabilitation to these patients with different vestibular disorders. So the roadmap for today is, I'll first go on to the introduction, then the differential diagnosis, test for identification, then the vestibular management part, and clinical considerations. Let's go to the introduction. As we know, vestibular dysfunction affects 35.4% of adults post 40 years of age. So do you know how the vestibular rehabilitation works? Anyone? Students? Okay. So the vestibular system is our internal reference telling the brain how our head is oriented in space. The visual and somatosensory systems are the external references. When there is a conflict between these both internal and external references, there's an inaccurate perception or hallucination of motion. So to correct this conflict between the internal and external references, vestibular rehabilitation has to be provided in the right way. Coming on to BPPV, as it's considered as one of the most common causes of vertigo, 26.9% had BPPV on the data collected from 13 countries over 28 months. The efficacy of treatment is dependent only on accurate diagnosis of involved ear canal and the ear, the side affected. The estimate annual cost associated with BPPV approximate 8 billion in the US. So that's much of a cost, and if we do the right assessment or the identification of the involved ear and canal, the cost will reduce. Vestibular rehabilitation is the successful alternative treatment for patients with chronic non-resolved motion, intolerance, and imbalance issue. Let's come to the differential diagnosis of BPPV. So there are two schools of thoughts that define BPPV based on the variants, that's the canalithiasis and cupulothiasis. So canalithiasis variant is where the otoconia, which are dislodged, are attached to the cupulothiasis, and the canalithiasis, they are dislodged in the semicircular canal. So as to evidence-based researchers say, cupulothiasis variant is most common in horizontal canal than anterior canal and is less common in the posterior canal BPPV. whereas the canal thiasis variant is most common for the posterior canal BPP. So here is the thing, how to identify which canal is affected on Dixell-Pike text. So the posterior canal, you will see a rotatory and upbeating nystagmus, whereas the horizontal lateral canal, you will see a horizontal nystagmus, which can be a geotropic type or an apogeotropic. So a geotropic is towards the ground, you can say, and apogeotropic is away from the ground. Anterior canal or the superior canal BPPV also has a rotatory type of thing, but the fast phase is downbeating. Appreciation for the direction of nystagmus is the key in identification of correct canal, which lead to selection of appropriate management technique. That's the maneuver, repositioning maneuvers. Okay? So BPPV can also be observed secondary to vestibular insults like vestibular neuritis, labyrinthitis, Meniere's disease. There are also two syndromes mentioned for BPPV, that's the PAN1 and PAN2, post-alcoholic nystagmus. First one is 30 minutes after ingestion, and the PAN2 is 5 to 10 hours after the alcohol is ingest. So those are the temporary BPV variants, we can say, types. So now, which are the tests for identification? First, we'll come to how to select the appropriate and safe tests for diagnosing BPPV. So as we know, patients for BPPV come to us, to our clinic like 40, 50 years. They do have cervical issues, spondylitis, lower back issues, VBI, and other back issues, cervical issues. So for that, before going on to the Dixell-Pike test, performing the Dixell-Pike test, we need to do a precautionary check. That's the vertebral artery screening test for each patient coming to you post 40 or post 50. So this test is like patient has to rotate the head to the right or the left side and then extend the neck and look upwards. So while the patient is doing this, the audiologist has to observe for symptoms like whether the patient is feeling dizzy, he is nauseatic, there is nystagmus, significant nystagmus seen on the naked eyes. There's dysarthria, which is least common seen on this vertebral artery test, and pain and discomfort. You should not only get your decision whether to do a Dixell-Pike test with this precautionary check on basis of pain or discomfort, because most of your clients will be post 50 and majority of them will have discomfort and pain, but the other issues have to be seen. For diagnostic BPPV, there are these different Dixell-Pike variations, we can say, based on the client or the patient who is coming to us. There's the modified Hall-Pike, sideline maneuver, fully supported Hall-Pike maneuver. This is usually done for patients having hip replacements and major cervical and neck surgeries. Then the head roll test and the Bolin test, which is majorly used for diagnosing of a horizontal canal BPPV. So first the thing is doing the correct test for diagnosing BPPV, then we'll go on the vestibular management. Coming to vestibular management part, so there are 4 management approaches which are done for vestibular rehabilitation. First is a self-directed management, which is where there's no supervision needed from an audiologist, and it can be done in a non-acute stage. So what I mean by non-acute stage? So what I follow in my clinic or at NIR is like there's a tinnitus fall risk assessment which has to be done before we proceed for any vestibular rehab. So if the score is within mild, we can go for this self-directed approach for vestibular rehab. And if the score is above moderate, moderately severe, we need to go for a balanced retraining or a proper vestibular rehabilitation. And in case of BPPV, for a repositioning maneuver, like the liberatory desensitization. Let's come to diagnosis-based strategies. So there are 5 categories on which diagnosis or the exercises used are to be delineated. So it gives a smooth map in our clinical practices, because we don't have much time, and this vestibular rehab is just like if the patient comes for a hearing aid evaluation or hearing aid dispensing, the patient is ultimately going to come to you. But for a vestibular rehab, the challenges faced are in one go, if you don't show the patient any outcome or you don't give any reassurance to the patient that his quality of life is going to improve, then he is not coming to you, obviously, back. And you lose out not on the patients, but on the quality of life and your expertise in that. So coming to the 5 categories, if it's a unilateral peripheral vestibulopathy diagnosed based on various vestibular tests like the WEMP, VNG, VHIT, you need to go for the adaptation exercises with the clients, with the patients. If it's a bilateral vestibulopathy, like both the sides are affected, both the ears are affected, you need to go for the adaptation plus the substitution exercises. BPPV, obviously the regulatory manuals, which are also specific for each canal, which I'll be explaining later. If there's a disequilibrium, which is related more to the proprioceptive and somatosensory system, then we need to go for the substitution exercises, also in case of central dizziness. So these are the vestibular exercises. These exercises are delineated based on the adaptation substitution categories. You don't need to do all these exercises routinely, like from A to B, but the practice which is followed routinely is any 5 exercises from each category which has to be done. And as we give patients a satisfaction questionnaire in terms of hearing aid, for this we need to check their SF36 questionnaire you can get, or DHI, or any, I follow DHI and SF36 mainly. So this has to be given pre-therapy to the patient, like in the first session, post 3 weeks to the patient, like the mid-assessment, as we do in therapy cases too, and after 3 weeks, like the discharge. Vestibular rehab usually is, if we give correct rehab and the patient is not actually a bilateral vestibulopathy, hello? Yeah. So bilateral vestibulopathy, then 3 to 4 months is enough for a vestibular rehab patient to get back, and we are on the stage of discharging the patient with all these vestibular rehab exercises and the manuals. There are some clinical considerations. So vestibular BPPV can be mimicked with, or you can say BPPV can be confused with vestibular migraine, or more often. But the distinguishing factor between vestibular migraine and BPPV is vestibular migraine comes with photophobia, then phonophobia, and it's a long-standing symptoms. BPPV is only the positional changes, the head shift changes the patient feels during the test, the nystagmus. But migraine is often, if you give a repositioning maneuver also to the patient with vestibular migraine, you will get no results, like the patient psychologically sometimes feels, हाँ ठीक है, अभी ठीक हो गया, but he will come back to you in like 2 days, he will give a call, and maybe the next hour also after he goes home, because there's no benefit if you give a repositioning manual to a vestibular migraine patient. So that's the distinguishing factor between BPPV and migraine. The other things are, if it is a central cause for BPPV or a peripheral cause. So as seen in the diagram, the latency for a central cause is short, or it can be absent, whereas peripheral, the latencies are present for a long period of time. Fatigability is absent in a central cause. Just 2 minutes. Habituation is absent for a central, and the nystagmus seen on Dixolpite test is pure torsional, pure upbeat in a central cause, whether it's upbeat and geotropic, or maybe a horizontal for a peripheral cause. Some important tips. So there are many aspirants, I think, in vestibular who are keen in knowing the vestibular thing and will do clinical practices as their best in vestibular, but a thorough vestibular test battery knowledge is really important for a vestibular, for starting a vestibular service at your clinic. Effective and efficient management goals have to be set. Realistic goals has to be set and has to be conveyed to the patients accordingly. there should be proper guidance given to the caregiver in terms of this vestibular rehab program. Okay, because they are the main people who will push the patient or pull the patient and get back to your clinic in the second or third visit. Timely referrals to other professionals, which is often missed out by an audiologist, because somewhere you get an referral from a ENT or a neurologist, but then you find it's a central cause, cervical cause. So then an orthopedic consultation is a must, and so on. Bringing the accurate balance in the patient's life is needed to live a happy and joyful life, and that gives us immense pleasure to treat these patients and get back their balance. So lastly, I need to say, in this world, everything is gone by balance. So maintain the right balance. Thank you.
I hope our students will remember all these tips which is shared by you. Now I request Dr. Aarti Vaknis. Before that, any questions for this presentation? Now I request Dr. Aarti Vaknis to kindly give the token of appreciation for Sanket, Mr. Sahil and Ms. Mugdha. By Mr. Aninda Banik from Advanced Bionic. He is a clinical specialist at Advanced Bionic.
While I'm loading this presentation, first of all, at the outset, I would like to congratulate the entire department. Am I audible at the back? Yeah. Entire department to organize such a beautiful alumni meet. I was just talking to my college mates, whom I've met. I think it's very important that the college recognizes, and I'm very happy to see that you all have given an opportunity to every pass out to come on stage and talk about their expertise, and that's a beautiful thought. So congratulations on that. I just hope this continues for you all. All right, so yeah, I'm Dr. Aninda Banik. I head the Department of Audiology and Research for Advanced Bionics. And I know it's post-lunch. I was, for a few seconds, even I got droopy. I'm sure many of you all are maybe in that stage. For 5 seconds, if I can ask you all, request you all, put your left hand up, right hand up, look to the right, look to the left. Now you're awake. All right. So we move ahead with this presentation. So I was told to give a quick presentation for about 15-20 minutes. And I was wondering whether should I be talking on evidence-based practice? Should I talk on clinical research? But then I was told there is a mixed bag of audience out here. A few who are already into cochlear implants, few are maybe just there, few are passing out, and few probably haven't ventured into that entire cochlear implant segment. So I thought I'll take this opportunity to maybe just touch upon just three things rather than going into a deep clinical research or an evidence-based practice at this stage of time. So I'm going to leave you all with just 3 thoughts today. As we were talking on technology, and there was a wonderful panel today on CI. I'll try and relate my presentation to whatever points was addressed during the panel, and maybe that could be a take-home message for you guys. So we're going to look into what's in the future right now, which we started. How many of you all heard about ECOG-Gs in cochlear implants? That's what we're going to, I'll just give you a small teaser on that. Yes, even it was new for me a couple of years back, but then that is what the present and the future is. I'll touch upon a bit on the 3D implant, which is the High-Res Ultra 3D, it's core technology, and what's happening in the artificial intelligence world. There's already a lot of work happening there, but what has come into the processors, because the moment you guys are going to pass out from here, and as you heard in the panel, you need to give solutions to your patients. Otherwise, they are not going to be your patients anymore. So that is what I'll just touch upon. So just to give a generic background, AB is a US manufacturing company, and we have worldwide presence, of course. There are more than 700 patents, and we are the only one to invest a lot on research and development. Yes, there was this question during the panel, why is it so expensive? R&D takes a lot of money, right? So we invest a lot of our time and energy also in rehabilitation, and because of the technology, it's a wider perspective. It's music-based rehabilitation, and you step up on that kind of a front. So that is where even a manufacturing company looks into pure audiology and rehabilitation. That's kind of a little timeline that we have achieved in the last a decade or so, after we have been part of a bigger company called Sonova. So how many of you are very well versed with hearing aid features or front-end processings or microphones? I remember there was a point on microphone during the panel as well. So what if I tell you for the last 10 years, all the processors in AB are actually 2-in-1. It has a hearing aid feature and a programmer. All the front-end processing and the microphone is all from hearing aids. And the back-end is of cochlear implants. It's actually a 2-in-1 processor. So that's been the change in the cochlear implant industry in the last decade. Yes, so it's not too different. There's a lot of culmination there of the technology. As it's a mixed bag, I know many of you all might be wondering why am I asking about MRI, and why to an audiologist? Because believe me, when y'all start practicing in cochlear implants, there would be one particular day, usually it's a Friday evening, that you get a call, my child has fallen down, got hurt, I need to do an MRI, what do? Then we are clueless, then we start getting calls. So the thing is, we need to know what's really matters is, can a cochlear implant child undergo an MRI, which is very tricky. And why we are trying to talk about this and why there is a lot of R&D which has happened in this, 1 in every 7, and this is going to be 1 in every 5 very soon. There's so much of work which has happened in the MRI space. Right, in the medical industry, that's moving a lot. There's intervention lines also on this front, I believe, in the future. And this is just going to keep getting bigger and bigger. Even a cochlear, doing an MRI for a normal hearing individual, sometimes there's panic attack, there's pain, there's so many other things. But when a cochlear implantee does that, so it's a lot of issues that they can undergo. There could be magnet dislocation, means it comes out of the pocket. That means a lot of pain. That means there's a surgery as well. Even without doing an MRI, you're already going to be undergoing a surgery. Even after doing something called a bandage protocol, you still can't do MRIs. And that's the reason there's a lot that had to be worked on this. And that's where AB worked on 3 things. 1, a patient does not need to think about whether before doing an MRI, you need to put a bandage or not. Second, you in the MRI, you put a bandage or neither bandage. Even if you do an MRI, when you think about MRI, it's not about the brain. Everybody must be thinking MRI of the brain, right? Even if you want to do an MRI of the leg, remember your entire body is into that area. You can't take a single piece of metal or magnet inside. So the head rotation, orientation, that's very important. An MRI is not a thing for 2 minutes. It can take up to an hour or more, and you'll have to come back again to even do an MRI again. So for that much of time, if right now you all are sitting on this chair, if I tell you for 15 minutes you can't move your head or neck at all, can you do that? You can't expect a patient to do that. And that's the reason one needs to think about, is a magnet actually MRI compatible or not? And the third is, obviously, you don't want anybody to undergo a surgery. If you want to remove a magnet, means do a surgery, wait for it to heal, do your MRI intervention, come back for another surgery to put a new magnet inside. So that's the reason why there has been a change, even how to make a magnet. So as you can see out here, the Iris Ultra 3D, that has a different magnet segment altogether. You can see a red line and blue line going at the side. I'm just going to shift into a different mode out here on presentation because it's not moving out here. Right. So as you can see out here, there is this red line and this blue line. In college, in school, we have learned North and South Pole. That's no longer the thing. So North and South Pole are together this way, and they start to rotate. It's called diametric magnets. And as you can see, an assembly, it has different parts even within a titanium case. So you have a different carbon frame, which rotates horizontally. And there are these cylinders. When the magnetic fluxes are coming from the straight or from the side angles, they all start to rotate. So in that way, in geometry, we have learned about the x-axis, y-axis. The problem in the cochlear implant industry, we never address the z-axis. So because of this design change, even magnetic flux which is coming from the side angles, these start to rotate. And that's how this is truly a three-dimensional magnet. And why am I telling you this? Because whenever you get that call, that's when we start to remove our technical brochures and realize which are the positions we cannot do a MRI. So that is why you want a magnet which is actually a three-dimensional magnet. So just because of this entire design change, just a small magnet, and it won the Best Medical Tech Award in 2019. So it was the Best Medical Device Award, which was given to Advanced Bionics just for this own magnet, nothing else. So nobody has seen such a kind of assembly till date, and that's actually a breakthrough technology in terms of the cochlear implant industry. And there are some other things, obviously. When we talk about MRI, you also got to think about demagnetization. So somebody can insanely even do 200 MRIs in an entire lifetime, and the magnet just keeps getting magnetized again and again, because again, sometimes you have a restrictions on number of MRIs that you can also do. So these are small things which I wanted to let you all know, which is there in the Advanced Bionics implants, which is the high-res ultra 3D, and you have a non-3D magnets, and both are obviously the thin implants. Now, sometimes just a little bit of understanding on what's the technology inside. In the panel, you all were discussing about technology, upgrades, and future technologies, speech perception. So when you want speech perception, especially in noise, you cannot be restricted with number of channels. And that's where your implant should be capable of. Now, why I'm talking about this, sometimes I'm being asked this question by audiologists, implants, I think you should talk to the surgeons and not me. I said, why not? Because a patient is going to come to y'all, and it is y'all to decide what would be best for speech perception in noise. And for that, the implant should be capable of doing it. So these implants can do 120 virtual channels. It has the widest dynamic range of 80 dB, and it's actually the fastest stimulation rate that it can cover, up to 83,000 pulses per second, which is really fast, which is like 3 times faster than any other popular implants in the world. So what do these virtual channels means? Basically, it can stimulate the spiral ganglion cells in between 2 electrodes. Have you ever imagined that there's an electrode here, there's an electrode here? They're stimulating in front of that. But what about these cells in between? That's what the virtual channels start to stimulate, and that's how you get better pitch differentiations and finer pitch differentiations, right? Moving ahead, again, for an audiologist, we talk so much about diagnostics. We talk about residual hearing. But one thing again, in the panel which was discussed is, already 15 minutes up? Okay. Yeah. All right. So ACI has released the 60-60 rule, which is actually, it gives us a great importance of an audiologist in the OR, because you and the surgeon together can be working on saving that residual hearing that's basically doing structure preservation. But how do you know you're doing structure preservation while the electrode is getting inserted? One, obviously you want better electrodes, which is atraumatic. So obviously the length of the cochlea may differ, but if you look at microanatomy, anything beyond the 23 to 24 millimeters of length, your lateral wall on the scala tympani that decreases, and that increases a risk of trauma. So it's an untold truth. 30 to 40% of even the best of the insertion may have a trauma inside or a translocation. And that's the reason why electrodes, AB at least decided to not go beyond the 23, 24 millimeter, right? Because it may do more harm than good. You can obviously frequency allocate and then make utilize of that spiral ganglion cells to give a complete speech spectrum there. So both the electrodes, something called the mid-scala, which sits right in the middle of the scala tympani, and a lateral wall electrode, both are for atraumatic insertions. Now, I wanted to talk more in details this, but because of the time I won't. But what we are doing a lot of research in this field, even in India. So if in the future conferences, if there's a possibility, I'll talk about the research that we have. We have some outcomes on this. It's called the active insertion monitoring. We use ECOG-Gs while the electrode is being inserted to measure any kind of traumaticity inside the scala tympani, and that's how you get an opportunity to preserve structure and indirectly, obviously, preserve hearing as well. I'll skip the video because there'll be another bell going on right now. So this is how things have been placed. You put a sterile tube inside the ear canal, and that's how you try to measure different ECOG measures on a graph, and based on what's happening to the amplitude, you can make a judgment whether there is, and it is so sensitive, even an electrode is slightly nearby any structure and it touches it even gently or the push is too hard, we get this information and the surgeon is immediately able to make those changes. So imagine when we talk about a ideal 60-second insertion, surgeons are not doing it for 10 minutes plus of an insertion. Very difficult, but it is achievable. And we can do, just like the ASSR, ECOG-based automated audiometry can be done even on the OR table, and obviously you can do it post-op, and that helps us for EAS stimulation as well. So we've been working a lot, and if you have cases, obviously we'll be happy to enroll them and look into India's clinical research study, because in the last 5-6 years we have been taking a lot of Indian data and then now showcasing to the Western world rather than seeing global data into back here. So that's the change that we are trying to get out here. And the last segment, artificial intelligence. I think AI is there. We just scratching the surface there, but Marvel CI or the Sky CI processors, they have an inbuilt, I'm sure many of you know about this because you might have heard from the Phonak technology, but it's all on a chip. It's a one Sonova chip. You have AI, you have Bluetooth, inbuilt Roger, you can do wireless programming. Going ahead, you'll have remote programming, you have cross, you have a hearing aid which actually works like a cochlear implant in all the 5 phases. And obviously for a child, you don't have to make the child sit right in front of you and do mapping. Let the child play anywhere in this room and you can do an online mapping. So why it's required, all of these, as in the panel you all were discussing about speech perception and noise, everybody is auditory fatigued, I believe right now. So imagine a cochlear implant is sitting here, there'll be all the more. That is why AI, which has like more than 200 programs, the processor just automatically decides and changes this. I'm sure there are few of you all have already seen some videos on YouTube about how AI works in speech perception. Is actually inbuilt into this processor. A lower version of this, but obviously it's got started in that. And yes, it does influence speech and language stimulation and skills even after a prolonged period of stopping therapy. We incidentally found this, and we started doing a research whether it does influence, and it does. And the results will be published soon. We presented this at various conferences to see how wireless technology and AI is influencing speech and language articulation and fluency skills as well. Everybody wants Bluetooth. So it's made for all. There's no choosing about a high-end here. So you buy a higher cochlear implant, you don't have to buy an iPhone. You can still, connect a Bluetooth to a 2,000 rupees phone. That's okay. Again, you all was talking about accessories and wireless accessories. This is something we often just read in the college books, but I would recommend you all start using it in your practice. It's going to really help and give that satisfaction. Roger, which is actually a digital modulation system. This is an Indian study we saw. As you can see out here, 20 dB boost is an easy factor that it can really get in. You should feel it, then you would realize that how effective it is for either your cochlear implantee or your hearing aid recipients. It actually does a change for them there. So yeah, so in short, if I put together, technology brings in a lot of change. This is just a few of them which I put out here on the board. Yes, SSD, single-sided deafness. I believe in cochlear implants. I'm not being biased there, but I think evidence shows that it is much better. You're giving senses to an organ. You don't want to be, just seeing from one eye. You want to see it from both eyes. Why not 2 ears, right? So in a nutshell, if I put it, anybody who walks into the center clinic, you would have a solution for 1 year or 2 years both, whether it's unilateral, bilateral, bimodal, or pseudo-bimodal. You have cross-in cochlear implants as well. So you should be in a position to offer them something for both the ears. That's how we are made, right? So when you do that together, I think that's when the brain will start to hear because better, and this, as I said, you want music perception, you want hearing better, you want quality of hearing, you need to have bilateral stimulation and think about speech perception, and technology is the one which is going to influence it. So just to finish my presentation, I'm just going to leave you all with a video. I hope the audio is on the speakers here. This is how implants and their testings have been done in the lab. Lovely. I just thought it might be interesting for, the speaker changed. Yeah. Not happening. Try this. I think it's stuck, sorry. All right, so if it plays, plays. Otherwise, I hope I was able to leave you all with 3 messages. ECOGs, that's the future. AI, we're just touching the surface. You're going to see a lot of it. I can't disclose the pipeline, what's going to come in, but there's lots that we are able to do on that display. And yes, MRI. Yeah. Thank you everyone for listening, and
thank you once again for, I'm not from this college, but you invited me for this lecture. Thank you so much for this. I've sent an advertisement. We have a vacancy in New Delhi. If anybody wants to apply for a clinical positions, feel free to apply for that. Thank you.
Thank you, sir, for a beautiful lecture. Now I request Dr. Sharda Sada kindly felicitate the sir. Thank our sponsors for these 2 days our workshop. Because of them, it is very successful event, I know. So I call upon Dr. C.S. Vanaja to please come up on the stage and present the thank you token for our sponsors from Phonak, Signia, and Universal. Now I call upon representative from Signia. Now I call upon representative from Universal Hearing. Solving solutions, exploring advances, practices, and innovations in dysphagia. And for this, we have today with us Ms. Nikita Kirane and Mr. Bhushan Jirgale. Ms. Nikita Kirane, she is representing speech, language, and solving therapist at Asha Ek Hope Foundation for MND ALS India, e-charitable foundation of MND patients, founder and speech therapist at Kirane's Clinic of Speech and Solving, Sion, Mumbai, visiting consultant, speech and solving specialist at Rajpal Hospital, Navi Mumbai. She has thesis on efficacy of neuromuscular electrical stimulation in management of dysphagia in patients with stroke. She has done fellowship in voice and solving pathology, mentored by Dr. Jaikumar Menon at Kerala Institute. She has certified and trained to carry out flexible endoscopic evaluation of swallowing and modified barium swallow studies. She has written a chapter titled Swallowing Disorders in Patients with MND, ALS in ALS MND, guidebook for parents and families. I welcome you, Nikita.
Hello, everyone. Thank you, ma'am, for the introduction. My topic today is advances in swallowing therapy and assessment. So we've divided the topic between myself and Bhushan, where I'm doing the advances in assessment and pediatrics, and he'll be covering the adult portion of that. So I think we're still waiting for the PPT to open. All right, so just to give you a gist, I have not put anything which is yeah, so I haven't put anything which is basic swallowing therapy because clearly the title of my discussion is not that. Yet if you feel that I have, unexplained certain concepts or anything, please feel free to ask any questions after the presentation. Okay. So we know the assessments that we do in swallowing is modified barium swallow and fees, and I think all of us do know a little bit of the basics of that. So what is the advancement in MBS that is going on right now? So we'll just have a look at this video. So I want you all to understand where the arytenoid is. Try and understand where the arytenoid in the video is. Can you all spot it? If you all can spot it, just put your hand up. Okay, so a lot of people are not able to spot it. All right, so that is the epiglottis. Is everyone okay with that? If you all are okay with it, just put your hand up. Okay, and we know that this is the UES over here. So right here we have the, oh, do we have a pointer? Okay, so that is the epiglottis, that is our UES, and right here we have our arytenoid. So you can see a slightly differentiated area over here, which is the vocal cords, and I'll replay it for you. So basically our patient is saying in that, where you can see that the arytenoid is moving forward and the cords are making contact and the voice is getting produced. So why we locating the arytenoid is because the advances in MBS is they are concentrating more on the pharyngeal portion, pharyngeal and laryngeal portion, which involves the constrictors, the arytenoid, and all of that. So we'll look at the next video. So I believe we all know that the tongue goes into stripping movement. The uvula will seal the nasopharynx. It will stop the food from going into the nasal cavity. The epiglottis will drop. We know all of that. So what we need to understand is, again, I want you all to look at the arytenoid. So the arytenoid will close much after the cords. I don't know if you could see that. Again, these are the cords. I'll replay it for you. The cords close before, and then the arytenoids close later. So something that we learned that they all close together is no more the theory, and we are now slowly able to locate as to what closes first, what closes later. And what is the advancement? The advancement is we're doing measurements in all of this. We're trying to understand if the arytenoid is really affected, whether it is a functional problem, whether it is a muscle tension dysphagia, like we have muscle tension dysphonia and stuff like that. So that is the latest advancement in MBS. Going ahead with the fees. All right. Again, I think we are well versed with fees. The two advancements are O fees and feast. Again, I think a few of us will know of that as well. O fees is the oral fees, where basically the disadvantage of fees is that it skips the oral phase because we're putting the scope right into the nose and we're looking at the larynx. And therefore, we try to invert the scope at the level of the oropharynx so that we can also observe the oral phase. So that is O fees, versus feast is basically fees along with the sensory stimulation, sensory testing. And it is also done with, something like a citric taste, where the taste is introduced into the scope from the suction channel or the working channel. And then we see whether we are getting the LAR reflex or not. So that is the advancement in fees. All right, I'll come to the pediatrics. So I've split my presentation into three parts. One is the NICU babies, one is sensory feeding disorders, and one is motor feeding disorders. We'll talk about NICU babies first. So usually we get a call for evaluating an NICU baby after 2 or 3 days of their life, and it's usually because of problem like the child is vomiting every time the child is fed, or he's not able to suck the milk right, or it's probably because he is diagnosed with pneumonia or some other problem, and after which we have to go and see the baby. We usually see the baby during the KMC time. So there is something called kangaroo mother care that is done for all NICU babies. And that's when wow. Okay. So that's when the baby is, given some time with the mother where the baby gets some skin-to-skin contact. And that's where we get a chance to see the baby and, work with some therapeutics. it's because we usually are not allowed to enter the NICU with all the other, things like a katori and some water or some milk and all of those different things and a bone and all of that. We are not allowed to enter the NICU with all of these things. And that's why that is the best time to see the baby. So what are you usually checking? You're checking the sucking reflex, you're checking the rooting reflex. I think we know of these reflexes, the blinking reflex. We're checking the basic reflexes. But there's something more that we're checking. We're checking a lot of pre-procedural things, like, is the baby on a Ryle's tube? If he is on a Ryle's tube, is it inserted from the nose or from the mouth? Now, what happens if the Ryle's tube is inserted from the mouth, like in the case of this baby? So clearly, because it is hindering the tongue movement, the lip movement, this child is obviously going to have delayed, tongue movements, a reduced range of movement. The lip movement will be, a problem. So because of this is something that we need to go and tell them that, can you please insert the RT from the nose instead of the mouth, which is a very small change, but it really makes a lot of difference going ahead as you work with the child. Along with that, you also need to see if that child, the baby is on other tubes, like, you can see some respiratory support over here. They may have any other medical comorbidities. So anything of that sort needs to be ruled out in pre-procedural checks. So another myth that we have is in NICU babies, we cannot do FEES or MBS. It's not the case. We can absolutely do it. I hope this plays. So we'll just play the video for you. In this, we can see that we're doing FEES on this baby, and the usual concept that we have is, it'll probably be a big problem. It's a big challenge. The child. So we usually feel that, there might be bleeding, the baby may not allow us to do the test and all of that. So there's a different certification which is to be done to do FEES in babies. If you do not have the certification, you can always do it along with a pediatrician or an ENT who is, well-versed with doing these things. And you can always observe or tell that, we want this consistency to be tried and all of that. Usually with NICU babies, there are very few consistencies because obviously we're doing usually only liquids with them. But maybe slightly older, like maybe around 7 months or 1 year, 1.5 years, you may want to try like a slightly thick pudding consistency or something of that sort.
Sacral is an organ which is activated and then it is followed by a
Oh, it's not playing, so I'll just continue. There was mainly something that I wanted you to see that, the baby really doesn't cry when you do the FEES procedure. That's our usually that's what we think that, okay, when we do this, the baby is, going to cry and we are not able to see anything, but that's not the case. If you, go very gently and the doctors who are trained to do this, they know how to do it very well. If you go very gently, you can, actually reach the larynx, you can do all of that, you can give all the feeds and the baby will be just fine. All right. Okay, that was again an NICU larynx video which is not playing, so I'm just going to skip. Okay, coming to MBS, so you can see the difference between the two pictures. One is the adult MBS versus the MBS in a neonatal. You can see the resolution difference. The resolution difference is because the baby will keep moving. So there is no anterior, posterior, and lateral in a baby, because in like a split of second, the baby is going to move like that, and your entire position is lost. So because of that, you do have to cut down on the frames per second, which is usually 30 frames per second is what we do for adults. But you may have to do it at lesser frames per second, so that if there is any movement, the video won't just go white. It will still keep recording the video, and you may get some time to put the baby back into the position. So that is why there is a difference in the resolution. Okay, I don't think that's playing either. So this is the AP view where we are giving some liquid through a syringe, and we are doing an esophageal trace. This is a normative video that we are seeing. And this baby is slightly older. She's about 9 months old. And this was post-therapy that we were seeing. So we were not seeing any penetration or aspiration in this case. All right, coming to ARFID. ARFID is a term which is recently coined by the DSM. Usually we were referring to these disorders as picky eaters or sensory feeding disorders earlier on. And now they've coined one term called as ARFID. ARFID is basically avoidant restrictive food intake disorder. And we can diagnose the child with ARFID only and only if he is showing any kind of nutritional deficiencies. That is, if you do like a blood test or some other medical test and you see some deficiencies, only then can we label the child as ARFID. If you do not see any of the malnourishment or deficiencies, then we still diagnose the child as a picky eater. One thing that is not clear in the definition in DSM is who diagnoses the child as ARFID. They have not mentioned whether it's us, whether it's the gastroenterologist, whether it's the pediatrician. We still don't know. It is a very newly developing concept. Maybe in some time we will know. So there are mainly 5 types of ARFID. It's avoidant, aversive, restrictive, ARFID plus, and adult ARFID. So I think I would just like to ask, I think we've all worked with ASD children. They usually have feeding disorders. The parents will usually come and say that he probably eats only like 4 or 5 things and that's about it. Doesn't eat anything else. So and then we sometimes feel that अरे मम्मी को ही खिलाने नहीं आता, नहीं तो अरे बच्चे कोई behavioral problem है. Sometimes we genuinely feel no, there is a sensory problem. So we are quite confused as to whether it is a behavior that the child is showing, whether it is a genuine sensory problem, what is the problem. So ARFID kind of helps us to understand, what falls where. So avoidant is something where the child has tried a food type before, has not liked it, and therefore is not going to eat that food again. So those children fall in avoidant. Aversive is where they've had a fearful experience. So usually there are theories like, NICU babies fall more into aversive because they were, the mothers didn't know how to feed the child, and then they were probably force-fed at that point of time because they weren't given the right training. It's also because more mothers are coming up in nuclear families now, and they themselves don't know how to feed the baby. So therefore, there is some incidents where the child was probably given a larger bout of milk than what the baby could actually swallow. And therefore, there is a fear set from that point of time, and therefore, the child is not able to, have any food even as he is growing older. So that is aversive. Aversive is always related to some kind of fear. There is restrictive. Restrictive is, usually those children where if there is food over there, I'm just going to change my direction and go on this side. So they're not even going to try to go near the food. The room in which food is kept, the child will not go in that room either. So that is restrictive. ARFID plus is where there is a combination of one or more of these types. And adult ARFID is untreated ARFID, where the child, grew to adulthood and still continues to have the same problems. So because this is slightly complicated to understand what percentage of behavioral problems does he have, what percentage of parental issues are there. So we mainly, while assessing in the clinic, we diagnose the child on 4 basic parameters, and we're also now developing a test on the same. So the parameters are motor, sensory, behavioral, and we call it social, but it's mainly the parental, where the parent is not even trying to feed the child. She's the parent, probably the mother or the father is just saying that, no, he doesn't eat, so I don't try also. Something of that sort. So that falls into the social. So we do get like a pie chart where we understand what is the percentage of the behavioral, what is the percentage of social, and then likewise we can work, we can plan a therapy session for the child. So these are few, it's working, okay. So this is the pre-video. You can see every time the mother is taking the food close to the child, he's coughing. Otherwise, he's okay. Every time the spoon goes, he coughs. There. All right? So this is a post-session. The same child nicely eating Maggie out of a bowl. He's very comfortable. So all we did over here, so this child mainly had a lot of behavioral issues. He was a twin, he wanted a lot of attention, and it was all getting, sorry, just 5 minutes. It was all getting manifested in food because probably the parents used to give the other child more attention or what. So it was mainly behavioral and a little bit of sensory issues. The child did not fall onto any spectrum. He was a neurotypically developing child. So that's all basically we worked on. The next child is, he was diagnosed with ASD. No? All right, so in this video, it was basically, you can see this idli, the idli in the father's hand, and you can see his hand. So he draws the father's hand, and he kind of licks the idli, but he has complete control on the father's hand. So the father can't push the idli even thoda sa more. Like if he feels it's too much, he'll quickly, push the hand away. So he draws the hand, licks a little bit, and then throws the hand away again. So basically, he's trying to explore the food himself. That's what we worked on, more. And this is him where the mother is now feeding the child idli, and he's, happily enjoying. Now his favorite food is idli. The main concern with these parents are, if we go on a trip, if we go to the theater, I have to carry all my food along. There's absolutely no time that I can just go and buy something out of a hotel and, just give it to the child. So now she's overcome that problem, and she's quite happy with that. Okay, so I think someone mentioned in the, doesn't work, okay. So I think Mansi mentioned that, some children, not some children, I think all children are very specific as to what they want, and it's just that we kind of don't understand what they are referring to. So again, you can see a plate over there. There were different pieces of food types kept on it. There was carrot, there was cucumber, there was khakra, and there were some kaju pieces. So every time I used to, give the child, maybe I give carrot, he throws it away. I give him kaju, he throws it away. Cucumber, he throws it away. The moment I give him khakra, he'll open his mouth wide, and he'll eat it. So now for me to diagnose the child gets a little difficult because all of them do fall into solids. So how do I understand which consistency is he okay with? So this is also something that we need to understand with feeding disorders, that it may not be a consistency, it may be a combination of the consistency and the texture, because the cucumber was watery and cold, but still a solid. He did not like it. The carrot was really hard, no taste, until you actually bite into it. He did not like it. But a khakra, as soon as you give it to him, it's kind of, partially soluble, starts kind of melting into your mouth. So he enjoyed the khakra, and that's why he liked it. So one thing that I would like to add on is, don't stick to the child eats solids or the child eats pudding. It doesn't work like that. You need to kind of understand which kind of solid, which kind of pudding. So that is also equally important. Okay, I'm just going to rush through this. So motor dysphagia, I think we all do oromotor, and we've been doing it time and again, and so I've not touched upon that at all. There is something that is an advancement in motor dysphagia, which is basically the ribcage mobility. The ribcage mobility is when the child, usually seen in children with cerebral palsy, when the ribs do not flare enough, therefore the abdominal muscles are not strong enough, therefore the jaw kind of remains always open, so these children are always like that. They're always like kind of getting support from their jaw. But the moment you put them supine, like you put them on the floor and they're okay. They'll close their jaw. The mother will tell you they drool also a little lesser when you put them on the floor. But if you make them sit, they'll start drooling so much and all of that. So it's happening because of a reduced core strength. And the key to that is no matter how much oromotor you do, it's not going to improve. We need to start with the core and the abdominal muscles, and then we have to work our way upwards. So that is an advancement. So I hope this works. Yeah. Okay, so this is a child with CP. You can see the mouth is open, and the food remains there. Can you see that? Until, he takes like one gasp of air, and then he swallows. We'll see it again. You can see the mouth is continuously open. Can you all see it? Yeah, okay. And when I give him the food, it kind of stays over here at the pharyngeal level. He does not swallow the food until he takes one gasp of air, and then he is okay to swallow the food. So that is what is happening with all the children with reduced strength, low tone, GDD patients, all of those patients, where until you don't work on their core muscles, it's not going to improve. There. You can see that it stops there, and then one gasp of air, and then he can swallow. Okay. So so this is a adult, pit. It's usually below the xiphoid process, which is the last edge of your rib cage. You'll see like a very deep pit over there, which you can see in the earlier photos as well. So if not resolved, that goes into adulthood, but there are rib cage mobility exercises. Here is me doing them for a child. You can see the rib cage. It's quite closed. The child is unable to flare the rib cage, and there are certain scapular and rib-related exercises that you do which helps them to flare up. I think I'll skip this because I'm out of time. Okay. One last thing I would like to add is we all know exercises like Shaker's exercise and other strengthening exercise like Masako, Mendelssohn's. We use it all for adults, but somehow we are very, very hesitant to use it with babies or children. And the reason why when I ask is they say, but how do you do that? Like, because they don't follow commands, so how do you do that? So this is one way of, I've just put up one Shaker's exercise. You're supposed to put the chair at like a 30 or a 45 degree inclination, hold the head back. The hand, I'm just holding because she was just like all over with her hands, just like me. Then you are slowly supposed to, show either some toy. I had used a screen at this point of time because the child was really cranky. Show the screen and then kind of move the screen so that the child comes up against the resistance. So that's how you do Shakers in babies. So just how this is one exercise that I've shown modified for babies. We can do absolutely every exercise like Masako, Mendelssohn's for children, for babies also. It's just that we don't know how to do it, so that's why we kind of get stuck working with babies. But that's not the case. We should try and work around it. All right, these are some of my success stories. And this is a small initiative started by me and Bhushan. We are trying to educate and advocate about dysphagia. It's called bolo dysphagia. This is my team back home. And I'm open for any questions if I have time.
Bhushan Jirgale. He has done BSLP from BVDU and Masters from Nair Hospital. He has certification of Langmore, FEES and MSM. He is working with Hinduja Hospital, Raheja Hospital and Nanavati Hospital. He has been invited for CME programs and co-founder for a bolo dysphagia. And he is also Reiki trainer. So I welcome, sir.
Thank you, Ashwini ma'am, for the introduction, and thank you, my college, for inviting me and giving me opportunity to speak. So we are going to talk about the swallowing solutions, advances, practices, and innovations in dysphagia, okay? So something a little more than what we do in our clinical practice, which may not be doing or about which we may not be knowing much about it. So how our testing or our role is important into the differential diagnosis as in our practice, when we see the patients with dysphagia, patients come to us directly having a difficulty in swallowing or a coughing, or there is some kind of a pneumonia. They directly will come to the swallow therapist or a speech therapist, and based on that, we will do the video fluoroscopic examination or a fees testing, and based on that, we will be able to differentiate between there can be any neurological issue or a disease, there can be a presbyphagia after ruling out all the things. It can be a muscle tension dysphagia, which is a new term which is coming into the picture nowadays, which is mainly related to the stress, anxiety, and because of the pain while swallowing. When you rule out all the neurological and mechanical dysphagia causes, then you can go on to the muscle tension dysphonia. Also, when we do a evaluation, there can be a pharyngeal growth or a laryngeal growth which can lead to this. Other than this, in the esophageal state, we can see a esophageal web, dysmotility, Zenker's diverticulum, hernia, or a tracheoesophageal puncture. So, in this video, we can see a very big Zenker's diverticulum where the patient is trying to swallow the food bolus, but it's not going. So this patient, these type of patients will came to you with the complaint of khana kha rahe, but it's not going down. I always feel some sensation inside the throat, so it's not going down. So that is the key point where we should go for a instrumental evaluation of dysphagia. Video is not playing. I will show it all the videos later altogether. It's a case of amyotrophic lateral sclerosis where we can see a severe bulbar weakness which can be identified on the modified barium swallow. Also, we can see a severe oropharyngeal weakness. This is a case of muscle tension dysphagia where when we have ruled out all the signs and symptoms related to the neurological and the mechanical dysphagia, as a part of the procedure, as a necessity of a diagnosing muscle tension dysphonia, this case was taken for the video fluoroscopy, and this video fluoroscopy study shows it's a normal findings. Okay, then only when we rule out all the clinical features, there is a normal findings, all the instrumental analysis, normal findings, then we can go to the conclusion that muscle tension dysphagia can be ruled out or can be diagnosed. This is a pharyngeal weakness in the dermatomyositis. It's a typical case where in this case, we actually see there is a pharyngeal opening is not happening. There will be a laryngeal weakness and patient will be aspirating, but we can see a severe stasis and intermittent opening of the pharynx, and the barium is passing through the pharynx. The case of myasthenia gravis, in this myasthenia gravis patients where you can see clearly a swallow fatigue can come. Patient in between stops while swallowing. He will be aspirating, but again you can see multiple attempts of the patients to swallow the whatever given the bolus. So you can see the picture. This was the case which came to the clinic with the complaint of having a difficulty in swallowing the food. Solid food was a very difficult, and on the liquids also he used to have a difficulty. So generally, which we all of us we know, the neurogenic difficulty, the liquids will be a difficulty. In the mechanical dysphagia, like a oral cancer or a pharyngeal cancer, the solids will be the difficulty. But this case with the complaint of all the difficulties where we can see the patient was walking, able to phonate, MPD is okay, everything goes okay, voice was a little hoarse. So by ruling out, by making a clinical decision, I decided to do the laryngeal scopy, and over here we can found a massive mass on the arytenoids. So now in such situations, we can refer the patients to the oncosurgeon, to the ENT, to the neurologist with our video fluoroscopy or a fees report saying that these are the difficulties, kindly evaluate for the further evaluation. So this way we can also do a differential diagnosis. It's an upcoming field in our domain where we have to be really alert while doing our clinical testing and the instrumental analysis. So treatment advances. We are going to see a lot of treatment advances. Most of the things you might be knowing. Everyone knows the patients having a tracheostomy tube. There are different types of tracheostomy. There are different reasons why the tracheostomy has been put. And there is a specific protocol which was been given by the ENT or the MD physicians before we are involved into the decannulation process or using a speaking valve or doing our intervention regarding the swallowing. So in tracheostomy practices, we are more active these days in the corking trials. What is corking? Closure of the tracheostomy tube. So when we evaluate the patient, though it's a neurological or a mechanical dysphagia patient, post-radiation or a post-chemotherapy, visualization of larynx is very much important, and the swallow evaluation with the video fluoroscopy is very much important. Either of the two, you do the test based on the secretions, based on the penetration aspiration scale, you evaluate the patient, and you can recommend the patient, this patient is fit for the decannulation trial or not. We are not saying go for the decannulation, we are saying go for the decannulation trial or a corking trials can be seen. Most of you might be seeing a lot of patients with the tracheostomy patients were not able to tolerate the speaking valve. So our role comes in that also. Before doing a corking trial, a deflation of the inflation of the cuff, doing some breathing exercises, this also our role in the tracheostomy care and management, where we have to work on their swallow saliva, tolerating of the speaking valve, and going for the corking trials and giving the green signal for the decannulation. As we know, there are two approaches, direct therapy and indirect therapy. Give the food and don't give the food based on the clinical evaluations. We know the traditional swallow therapy program where we uses the compensatory techniques and the rehabilitative techniques. We combine all the things and we give the patient to exercise and we go ahead with the swallow rehabilitation. But more than this, there are few different swallow therapy programs which has been there and which are the certified program. To learn this, you have to go for the special certification and which are very, very costly. So the few basic and the famous programs are LSVT, IDR, MDTP, and RMST. All these programs might be using whatever the traditional exercises we are doing, but among this, they have given some specification, which exercise to use, how frequently to use, how alternately we use, and that way they have said there is an improvement in dysphagia. All of you must be aware about the EMST, expiratory muscle, and IMST, inspiratory muscle strengthening training. So you know this is a device which we have to hold in our mouth and we have to blow out for the EMST. For the IMST, we have to inhale and we have to do. It directly works on our expiratory and inspiratory muscles. It leads to increment of our respiratory muscles. So the voice and the cough of the cough efficiency will become better. So what are the effect of EMST? It's not only increasing the cuff strength, but also gives the improvement in the velopharyngeal seal, hyoid exertion, epiglottal approximation, and pharyngeal wall shortening. You can see the measurements they have mentioned, the pre and the post. So you can see the laryngeal elevation is happening a better way. So this shows that this advances helps in to have a better swallow rehabilitation. We might be seeing a patients having a poor laryngeal elevation. Till now, we might be knowing the electrical stimulation, shakers exercise, and all those things. But working with the EMST can help you in that also to have a better and safer swallow. What is the IMST? Is the inspiratory muscle strengthening training. Not really, we are more interested in that, but inspiratory muscle training will help you to have a better vocal cord mobility. When we inspirate, it will help to abduct the vocal cords. If the abduction becomes the better, the adduction will also become the better. This way, if required, then we have to work on the IMST also. And these are the diseases or disorders on which we have to work. Let's go ahead with the LSVT. Everyone knows that LSVT, दूसरे building से बोलो किसी को पुकारो और बात करो, right? We know the basic, but it focuses on the voice effort, high effort, intensive treatment, calibration, and quantification. It's like you demonstrate the patient, you give the signal, in the few minutes of signals, you train the patient to do it again and again, again and again. So you go for the different kind of a motor programming. So what this author says, as the voice becomes better with the LSVT, the involuntary swallow will also become a voluntary swallow. It comes into the motor function, it becomes a voluntary swallow, and there will be a multiple swallows, and the patient will be able to swallow better. Okay, so we can say it's an indirect way of working on the dysphagia. Moving on to intensive dysphagia rehabilitation program. So they have they have given the specific set of exercises, which are the lingual exercises, pharyngeal exercises, and suprahyoid exercises, which basically works on the strength and the coordination of the muscles. What they say, don't do all the exercises daily and every day. Just do it 5 times a day. And just do 2 times a day, 2 exercises a day. If you are working on the lingual and pharyngeal, next time you work on the suprahyoid and some other set of exercises. So they highly recommend to avoid the fatigue. Do not work on all the exercises daily. And what we do in our clinical practice, we tell the patient, "Acha, chalo, pura, sara, kar lo, आधा घंटे का program कर लो." So, but their ideology is little different. They say, work on the specific targets, change your plan every week, and go for the swallow rehabilitation. Next is McNeil Dysphagia Therapy Program, which is very famous these days, which is a certificate program. It's a 3 weeks long intervention program, 5 sessions a week only have to do. The cognition is very much important. This program works with the chronic dysphagia patients. This program works with the chronic dysphagia patients, and they tell to execute this program at the nursing care or at the hospital level where all the facilities are available. So how they use? They use very specific techniques. They don't use the electrical stimulation or a NMES. They use the hard swallow, effortful swallow, and they highly believe that swallowing is an exercise for swallowing. So what they say, if your patient is aspirating on specific consistency or all consistency, find out the safest consistency, and with the very small trials of swallowing, you start giving the oral diet to the patient. It might be a distilled water, it might be a distilled water product, and you ask him to swallow, 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 swallow. And as you ask the patient to swallow, it will become a pattern, and his swallow will work. So their target is 100 swallows a day. So your patient may not be initiating a single swallow, but you train him and you push him that way, where he will keep on swallowing, and he will do it. So there is a new thing, which is an electrical stimulation. You might be knowing the Vital Stim is available, eSwallow instrument, eSwallow USA, which I use personally. There is a new advance in this is a pharyngeal dysphagia, where we can see a complete pharyngeal palsy. The electrodes will be placed inside the pharynx, and the pharynx will be stimulated with the electrical stimulation. Moreover, the era has come, now the thickeners are available in India. So these commercial thickeners can be used for the dysphagia rehabilitation. RT can be removed in such patients, or patients who are not able to tolerating liquids, for them it can be used. Also, the important part, patients who are going for the radiation program, with them, as a prerequisite or a practice trial, the thickening agents can be used, and the swallow, we can keep their swallowing intact or keep on practicing. This is a new thing, IOPI, Iowa oral peripheral instrument, which basically works on the lingual and the posterior pharyngeal muscles. The electrode will be placed, the electrical stimulation will be given, and the strength and the range of motion of these structures will be increased. The next important part, soon it will come into the India. At few centers it is available, which is a digital swallow station, where high resolution fees and video fluoroscopy testings will be available. All the motion analysis will be done. All the measurements will be done. It's like you have done the testing. Laryngeal elevation is not there. Closure is not there. So there will be markings and indications will be there where you can calculate it into centimeters or millimeters, and it will be done. So you can do the pre and post, more useful for the research, and visually, if you ask, it is way better than our regular instrumentations. These are the swallowing applications which are available. You can tell your patients to use these applications, but remember, our role is important because we will be telling them which exercise to use when and which exercise not to use. It's not like that patient has recovered and he will be going on doing the exercises for 6 months. That is not the right. So dysphagia apps, definitely it's helpful, but for the education purpose. Okay? So to conclude, our swallowing field is evolving, focusing more on assessment, quantification, consistency in the rehabilitation, and decision making is important. A constant learning certification is important for providing a better swallow rehabilitation, because we have to update ourselves now and then, right? And finally, talk about dysphagia, ask about dysphagia, speak about dysphagia, discuss about dysphagia. Let's bolo dysphagia. Thank you. Time.
No questions? Thank you, Bhushan, for a wonderful presentation. Now I call upon stage Dr. Pallavi Kerkar to felicitate the Bhushan and Nikita. now that we have gained so much insight from our speakers, it's now time to deepen our conversation with our next panel discussion. And for that, I would like to invite Dr. Piyush Sone, moderator for this panel discussion. Dr. Piyush Sone has completed training in voice rehabilitation after laryngectomy and assessment and management of individual with cleft lip and palate. He has 12 years of professional experience, published 11 articles in national and international journals, author for 3 copyrights, presented posters and oral research papers in various national and international conferences, speakers in various national and international workshops, and recognized as PhD guide in speech language pathology at BVDU SASLP Pune. Welcome you, sir.
Thank you, Ashwini. Yeah, so after now speech language pathology, now we will have a panel discussion where audiology and speech language pathology, both things are going to be combined together. So it will be interesting for everyone, I guess. So I just want to actually call all the panelists here. So first, I want to call Isha, Miss Isha, Miss Akshi Kaul, Miss Arunima Santosh, Miss Rucha Palkar. Yeah, I'm really proud because all these 4 panelists, they have done the master's dissertation into the auditory processing disorder or literacy related things. Okay, and Akshi has completed the bachelor's and master's program here itself, and she is she runs her own private clinic at Delhi, and she works she's associated with the NGO also. Whereas Isha she works at Mumbai right now in the Here lab. Whereas Arunima is working in Dr. Chandrasekhar Institute of Speech and Hearing, Bangalore, and Rucha Palkar, everyone knows, she is at our School of Audiology and Speech Language Pathology. So we have very interesting actually panelists here because both of them are a speech therapists, speech language pathologists, and they are at the institute level, and where these 2 are they are a private practitioner and they are an audiologist kind of thing. And our panel is going to be based on the assessment of auditory processing disorder and literacy disorder, the role of audiologists and speech language pathologists. So let's begin. So before starting the this panel discussion, I just want to have some background kind of thing related to what is how auditory processing and literacy part is associated. So let's understand, and for this the best model would be the spoken language processing model. Okay, so let's understand how the different models have been proposed historically and how it has been proposed come spoken language processing model talks about, and how it associates auditory processing and the phonological awareness and the literacy part of it. Okay, so regarding the auditory processing part of it, if you look into it historically, whereas the Ettors Boca, who was the first person who used to who talked about the auditory processing disorder, and then further there were a lot of research and that part of it. So there were still some kind of debate was there whether the APD is really is a distinct clinical entity or it does not exist. So some audiologists kind of thing every authors had their own kind of point of view whether it is exists separately or isolatedly. So where SLPs they talk about it can be the just merely reflection of the language disorder part of it, whereas the auditory processing disorder audiologists used to some of them they says that it is not the reflection of the language disorder, it is purely the auditory processing deficits are there. But still the question comes to the thing is what is the APD's clinical distinct clinical entity or not? So for this short answer is no, and the long is it is complicated. And for this Asha has there were 2 task force were there. So in 95 and then 2005 where they had looked into what exactly the auditory processing is and how it is. But still, there were like no consensus among the audiologists, like what exactly the CAPD is, and like the test battery or the management part, like that needs to be there. So later on, so the models, like always, it helps to simplify any complex process. So there were like Bayes-Ferris model, Buffalo's model, and the spoken language processing model, where spoken language processing model that we are going to look at it very shortly right now and see how exactly the spoken language processing happens. So everyone knows, like first thing happens is the acoustic signal transduction, where like the acoustical energy is getting converted into the neuroelectrical patterns. Second stage, like decoding happens, whereas the segmental, suprasegmental aspects gets like to the right hemisphere and the left hemisphere. Then sufficient attention plays an important role, where like the matching of the whatever the input and the whatever is being stored, that happens, where the short-term memory plays a very important role over there. And along with that, like your auditory linguistic integration, where the suprasegmental aspect and the segmental aspects are integrated, then we understand the what is the meaning about the whatever like comprehension like happens. And also the sequencing and the memory part also plays an important role. Apart from this, like selective auditory attention, also divided auditory attention also plays a very important role. And very important part is the phonological awareness, where it gets the signals gets like the meaning out of it, like it tries to like for the decoding the message, what like one speaker wants to convey to the listener, that happens. Also the phonological awareness also helps in the literacy part also. So we want to now look at this phonological awareness, which is the bridge between the auditory processing and the literacy part of it. So let's look at how exactly the phonological processing is associated. So you know that auditory processing means the temporal processing is very important. So my first question is to Akshi, what is the temporal processing? And to you, my question is like what is the auditory process, temporal processing is?
Hello. Yeah. So basically, temporal processing refers to the ability of the brain to process and perceive temporal, that is time aspect, which involves order, duration, and timing. It can be argued that temporal processing is a fundamental component of auditory processing, because every auditory information, some or the other way, is basically involves time. It can be at a very basic level, that is in differentiating time differences, or at say at a level wherein you have binaural hearing and speech perception as well. Now the tasks that involve temporal processing are detection of gaps in a sound stimuli, changes in the sound stimuli, rapid changes that happen in the sound stimuli, and rhythm also is involved in it, temporal processing. So altogether, this temporal processing is very important for speech perception, I would say.
So now my next question is to Akshi, that how the temporal processing is important for the speech perception.
Hello. So as Isha mentioned, that temporal processing is the fundamental of auditory processing. So when we are talking, we sometimes use similar sounding words, like the basic, we start from, let's say, the bilabial sounds, p and b. The placement, the articulation, it's exactly the same. The finer discrimination is the voicing. So these nuances of the speech has to be perceived only when your temporal processing skills are at par or adequate enough to discriminate those finer distinguishes amongst the different speeches. Similarly, if we say we are in a group of people like over here, there's audience speaking at the back. You are speaking to somebody else. The noise or the background speakers, they might affect the speech understanding of the speaker that you intend to speak to. So these discrimination between the noise or the unwanted speech versus the speech that you intend to listen to, these finer discriminations, or also what we call as auditory closure, are what needs to be differentiated, and that is what our temporal processing helps us to do.
So the auditory processing, like the temporal processing, then speech in noise and divided auditory attention, that all these things helps for the perception of the speech also. And now let's understand how exactly all these things are associated with respect to the phonological awareness. So since Rucha has experience on all the spoken language processing and the phonological processing, how exactly it correlate with each other. So can you please elaborate on this part?
Hello. And for this awareness, the perception, discrimination, and identification or manipulation of the sounds play an important role. So as Isha already stated, that if a person has problems in temporal processing, so that discrimination, identification, or the duration may be affected. So when these processes are affected, they affect the phonological code of the child, which leads to reading and writing difficulties as they disturb the phoneme graphing correspondence of the child. So once the phoneme graphing correspondence is disturbed, they are not able to identify the similar or the different words, what we call as rhyme oddity or phoneme discrimination, phoneme segmentation. All these aspects are affected. And literature has also suggested that if there are deficits in temporal processing, the phonological acquisition gets delayed.
So the phonological awareness, it is associated with the auditory processing also. Now let's try to look at how phonological awareness is linked with the literacy part. So I just want to request Arunima, can you just elaborate on this part?
Okay, so when we speak about literacy, mainly we are looking at the reading and writing part. So just to add on to what Rucha had told, so phonological awareness, as we know, is the way a person understands or a person is aware about how sounds are exist or how we can manipulate the sounds. So one has to have the understanding of how each of these sounds are represented in a printed way, that is a combination of printed letters or isolated letter. How does it correspond to each of the sounds? So that is how we can understand how a person can read, that is the spoken sound, how it is corresponding to the printed word, or the vice versa, that is for the writing part. So that is how we can understand how the reading and writing happens in a person, or a good reader or a reader can read words.
Yeah, so it is very clear that the literature also says that auditory processing and literacy, in between the bridge is your phonological awareness. And so phonological awareness plays a very important role. So ASLP as an audiologist and speech language pathologist, we have to focus at all the assessment as processing, phonological awareness, and the literacy skill. Now let's understand how the assessment part is being done as at a private clinic versus the at the institute level. So maybe we can check it out first with the private clinic how it is being done.
Hello. So I work in a very private setup. Whenever a patient comes in, and usually we always start with PTA. If it's a kid, the parent always says that after I'm done with the PTA, and if it is normal, the parent always has this thing where, no, we've been to the school and the teacher always says that the kid is not hearing, or I don't know, he's not responding, or he wouldn't pay attention. So when there is something, some complaint like this, what I usually do is, I do SCAP. And then I do speech and noise. This is something that we all have and we all should do this. In private setups, mostly we do not have CAPD testing, test battery. We do not take it for some reason, and we all should. So in assessment wise, if you don't have anything else, I would suggest that at least do SCAP and speech and noise. You would get an idea if the kid or the patient has difficulty in understanding or basically has CAPD. You'll get an idea and then you can work it out. So with assessment part, I feel this is what in a private setup that I have been doing. We've been trying to get CAPD tests because a lot of referrals have been coming in for the same. So that is how in private setup is what we've been doing.
So maybe at the institute level or like an SLP point of view, we will check it out like how it has been done.
Okay, hello. So here what we follow the protocol is when we get a referral for the child, we first do a detailed case history of the child, then detailed speech and language assessment is done, and if required also we do a speech sound assessment of the child, and then detailed literacy assessment is done. So the literacy assessment mainly focus for the reading, writing and the spelling skills of the child, and we have a few specialized tests for literacy assessments as well. Like we have the test for pre-academic skills or the DALI, which we have in 3 languages, which is a very good one actually. And then ELST also, so we follow this protocol. And then we refer the child to the audiological department to get the hearing testing done. You want to add on it?
So in my institute, most of the referrals usually come from the psychology department. So when the client comes, then already they know that, okay, there is a difficulty in reading, writing, or academic issue. So we'll do a detailed evaluation. So other than that, whichever patient comes with a difficulty with speech or language related issue or articulation, fluency, for everyone, we are doing a screening of literacy skills. So we use ELST for all the kids who have a language age of more than 3 years. So 3 to 6 years, whichever patient is coming, we are doing a screening for them. And we find that whoever has difficulty, we'll be doing a detailed evaluation after that. Just like Rucha told, we have many tests that we use for reading, writing skills, and most of the tests are done in English, and if needed, because we get mostly Kannada population, so Kannada test also we usually do. That is what happens in our institute.
Yeah, so there is a difference, like, when it is at the clinic, when you do it and at the institute also. But, like, I think somewhere the holistic assessment is required. The test batteries are required, and all the processes that are as a part, just now we had seen in the spoken language processing also, what are things it includes. So all the tests, those are important to assess, and wherever the deficit is there, so we have to work with respect to that. So the holistic assessment, and along with the audiologists and SLPs, we should work together, so then we can identify the issue thoroughly. And remember that, like, it is sometimes it is just a tip of the iceberg. So that it can be just like, the misarticulation, but beyond that, when you assess properly or like, check it out, it could be the phonological awareness is affected, or like, some part of like auditory processing is affected. So that is why it is very important to do the holistic assessment, and based on that only, like, based on that taste battery, wherever the deficit is there. So deficiency based management is important. That intervention is very important then. So based on that, like, we have to plan it out. Yeah, so we had seen that right now there are challenges in the field of like, auditory processing disorder and literacy. So let's check it out now. What are the challenges are there for the audiologist and SLP to for the assessment and management part of it? So let's look at from the Akshay's point of view now.
Hello. So from a private clinic point of view, if we look into APD management and assessment, so the assessment we've said that because of the lack of auditory processing tests, we are not able to diagnose the patient correctly. However, we are still performing SCAP and we are still doing speech and noise test, which gives us some idea into the processing issues that the child may have. So over there, we can at least start with that. Secondly, in a private clinic, we have very less time. We are bound to have the time efficiency. We have to manage the time efficiency according to the other patients as well. So it becomes a little bit difficult. Also, the enthusiasm of the parents, sometimes it's not quite what we expect to have. We say that your audiometry is done, the child is normal, then, but we need further management for this child. We need to give him some more tests or some more assessment should be done to look into the matter deep, to look into the deep processes and all. So over there, it becomes another challenge because some parents, they feel like, it's okay, बोल लेगा, ठीक हो जाएगा, whatever, आगे बढ़ेगा, तो he will catch up with it. So the enthusiasm of the parents also matters over there.
I think what she said correctly is like, the awareness. That is very, I think, important part of it, where the parents, other professionals also is a very important, like, that we have to create regarding what is the APD part of it. Still, I think there are cases like, when it happens, like, hearing is normal. So, like, what to do, like, further. So we don't test. So I think that needs to be done, and that will happen with respect to the awareness part of it only. So among the professionals also, like, we have to create that awareness, and even the parents, especially the teachers, they play a vital role in this part of it, especially in the school. We can train them properly. We can have, like, some sessions for them. So they definitely we can identify. We can and through that, like, we get the society will get more aware about all this issue, and then we can have the more assessment part of it.
I would like to add few. So availability of resources and professionals. Now, if I have a patient, I need to refer. There are barely few clinics or hospitals who do this CAPD testing. So if a patient walks in, I need to refer. So I work in Mumbai. I refer them to Nair. Patients usually don't prefer going to hospitals because then it's like, okay, it's going to take a lot of time. So that is one thing. We need more people doing this. Another thing is language barrier. Now, even for me, when I wanted to get the tests, what language should I get? So should I get the test in Marathi? Should I get the test in English, Hindi? And because it's in Mumbai or anywhere else, we have a diverse culture. We have many languages. So it gets difficult to, as in which language should we get the tests in. So that is another thing that is been concerning, and it's something to think about.
Language is one important thing, and then where we used to lack, I think 1 decade back, where, like, for my PhD thing also, the phonological awareness test, we did not have, so, like, that part, like, we had not included. But right now, also, like, we have. Aarti ma'am had, like, in her thesis, like, the PAM has been developed and that part of it. So we have certain tests, like, in the different languages also now. So I think it is our now responsibility that we should procure all this tests into our clinic, I guess. And I think in private clinic also, I think we should set it up, all the test battery. And see, we also have at Bharati Vidyapit, like in School of Audiology, we have all the test batteries also related to the central auditory processing disorder, and even PAM and all these things are there. That is why, like, we had a stall also right now. So maybe all those things also can be procured, and maybe that can be used in the assessment part. Once we identify, then only we can start, like, the management part and that related to thing. So I think instead of, I think, referring, I guess, we should have now all the tests. I hope this also is a good point, right? Yeah.
If the cost, we have to look into the cost also.
Yeah, the cost is also matters a lot actually, but that also like we can check it and then can do it. Yeah, now maybe we can look at the SLP's point of view on this.
Challenges, of course, is the awareness between parents and teachers and everyone, because I'm working in an institute setup. Most of the other professionals already, okay, they understand that if such a child comes with this difficulty, they have to be sent to the speech and language department also. So it is already understood to them. So from the other departments, referrals usually come, but with respect to the schools and all, it was a difficult thing. Like, they are not aware about most of the role that we play in this academic issue. So one thing that we did from our institute was to start a school screening project. So 2 years back, we started with a project where we went to at least 4 to 5 schools around our institute itself to give orientation to teachers so that they can identify kids from their own class itself who has difficulty, and then maybe refer them to the institute so that we can do a detailed evaluation. But initially that was also not working. Then we had to go do the screening and then get the kids from there, talk to the parents after going to the school. So after maybe 1 year, when after it started, we could get many kids from different schools coming to the institute. But again, one of the other challenge we faced was the management part. So parents were not at all accepting. So most of the kids came to the institute for the rehabilitation only after maybe they complete their 5th or 6th grade, when it becomes very evident that, okay, they have an issue. So the initial years, it was very difficult for them, and most of the parents were not accepting at all that their child had an issue. So counseling sessions had to be given, and after that only, most of the kids started coming for management. Then also, now also, I think most of the management part is not at all happening, only the identification is happening. So that is one challenge we are facing.
Not true. I think what you pointed, that is also correct. So that is how, like, a few years back at our college also, we had a center in the school itself. So there, like, we had, from the classroom, we used to, pull out some children and then used to provide the therapy also. I think this model also works very well, where, you can take it out, some children who needs the therapy for the reading writing issue, or the auditory processing part of it, that also will help. So I think we'll have to have some modification into our thing also. That is also very important. But one thing what she said is very important, this school screening. That I think everybody should start doing it, and that is very important. One I think 4 or 5 years back, I just want to share one experience where we had gone for a camp in nearby Satara. So where, in that school, almost 100 to 200 children failed in the reading writing part. So we said, how come, this many children had the issues with the reading writing part of it. Then again, when we looked into, one thing was common was, in otoscopic evaluation also, they had otitis media. So that was a trigger, thing ki because of the otitis media, the perception, the whatever processing part should happen, that was lacking, and then because of that, it led to the issues with the further learning problem, and the reading writing also was affected. And when we investigated more further, what was the cause for the otitis media also, it was because of the swimming. So they used to go for a swimming and in nearby village and that part of it, and then everybody used to go in the same part. So that is why they used to have, they got a lot of otitis media, and then it impacted on the reading writing issues also. So we have to be careful when we go for a camp also. We need to check thoroughly, why all these things are happening. Then we can identify, and then we can try to sort out the issue. This is again, we can stop this thing also, we can avoid by educating them. So awareness plays a very important role, and I think we need to take more role into this part of it. Okay, so these are the challenges and like a few things we have discussed about like how to overcome also. But like, do you think our curriculum is also whether it includes the auditory processing part of it thoroughly, UG, PG, both the curriculum part? What is your opinion on this?
So talking about the curriculum, when we were in the undergraduate course, we just had an overview of what are CAPD disorders and how to assess and how to manage. But then we never got any experience on doing it on patients. We just tried it ourselves. So we could not really discriminate on this. And in the undergraduate course, we never had an overview of literacy disorders. What are literacy disorders? How are they? What causes them? So when we came to the postgraduate course, we had a specified subject for language and literacy disorders, where we study in depth about what are these actually. And I would also like to prefer, we have specialized courses for various other disorders like voice disorders or swallowing disorders, where they provide 1 or 2 day courses are there. So if something comes up for literacy or such things, it can be very helpful for all the students and professionals who want to learn in the field.
You want to add something, Arnima?
Like she told, in the syllabus mostly for UGs they don't have much, just maybe one topic on what is LD and what are the characteristics. So I think we should add on how they can at least identify such kids, so that after UG when they go for working somewhere, they can at least identify and refer such patients to places where testing can be done. So for, of course, MSc, now we have a separate course, subject itself for learning disability. So that, of course, is there. But again, when it comes to the practical part or how it can be done on a child, the test or the management part, that I think have to improve now also. Because only the assessment has come up now, like management, again, we are not getting much patients also. So that practical part has to happen. Otherwise, I think syllabus has most of the things for, with respect to masters.
Want to add something?
Hello. I don't want to add anything, but we have bachelor students here. Do we have bachelor students? Yeah. Please do your masters. We never know when the RCI might change the curriculum, but for now, please do your masters. Yeah.
Yeah, so.
Also, not all of us want to do masters, so at least some changes in UG curriculum should also be made, so that they are much more aware of what they can do to help the field of auditory processing grow. So that is what I think.
Yeah, so UG has a restriction kind of thing, like, the curriculum part and that part. But I think somewhere, there has to be some specialization into the postgraduate also, where this thing. But I think, some kind of, cases and case observation through that, they also learn. But specialization happens in the master program also. But along with that, I think some kind of certificate course or some specialization into the for the audio, where the APD and then literacy part where it has been involved, that has to be there. Okay, so some special courses or something like that, it is required. So then it can give the something like an educational audiologist and speech language pathologist, and such kind of things will definitely enhance this area also, as well as to the children, see around 8 to 10% children can have the issues with respect to all this thing. So we can work, we can help them out prior only, so the early identification will happen, so early intervention, and that will definitely will help the whole society. So with this, I want to share this particular thing also. Soon we will be having one next year, the CRE also on auditory processing and then literacy part of it also. So that definitely will enhance the some more knowledge into this part. So we'll share that details later. Yeah. So to conclude, the today's panel is auditory processing and literacy, both the things are important, where the phonological awareness plays a very important role. It's a bridge, and we have to look at all these things, like, from the perception of not just audiologists, not just speech language pathologists, but, we, as an audiologist and speech language pathologist, where, we can look at it, yes, processing issues are also there, where phonological awareness or the literacy, what all things are there. So we should not ignore any particular area. If you want some help, so, we can refer to the specialist over there, so that also can be done. Okay, so any questions?
It's not a question actually, it's just one more thing. Like we spoke about the cost that is required for the procurement of tests and about the BASLP syllabus. So I just want to say that BASLP syllabus is limited and that is all we can accommodate. More than that, it becomes difficult for the person to comprehend and manage that. So I think it is for now appropriate. And like Isha said, please do your masters. So, so secondly, when utilize whatever we are learning, and it has to be done holistically. It is actually a huge area where all of us can tap into and contribute to a large extent and profit also in the same situation. For both SLPs and audiologists, it is not something that needs to be done with multiple follow-ups. There are many apps, there are many newer technologies which are working beautifully. But that amount of counseling and asking the parents to follow up is also a little difficult task. But I genuinely feel that all of us should at least start, because unless there are multiple success stories, we are going to be stuck for a very long time in trying to convince people to come to us for auditory processing and phonological, any kind of remediation. So we need to have our success stories out there, and that will happen only when we try.
So in short, the problem hai, but uska solution bhi hai. So we need to actually go ahead with respect to that also. Sneha wanted to. Okay, so thank you so much.
Thank you, sir, and all the panelists for the valuable insight in this field. Now I would like to request Sharda ma'am, kindly felicitate the sir and the panelists.
So I think everybody is waiting for the validatory function. So I welcome all of you for the validatory function. And we'll just finish with the short time only. So just first part of the thing is I want feedback from the alumni, students. So one UG student, one PG SLP, and one PG audiology. So maybe so I hope everyone has enjoyed the conference, and I'm sure, like, from the day one, first session to till now, like, everyone enjoyed, even especially the banquet also people enjoyed. So we just want your valuable feedback also. How was the conference, and then any suggestions for the further thing then?
Good evening, everyone. I know everybody is waiting for a hot cup of tea, and Rachna here told me there is vada pav. So please, let's wrap it up. So, on behalf of alumni, I'm really thankful to the organizing committee to think of such a novel idea to call the alumni back, not just to do danga masti time pass, but to learn from each other, to kind of reconnect with each other and understand what others are doing in their own clinics, in their own sort of niche that they have made for all of us. And also, I thank Bharati Vidyapeeth School of Audiology and Speech Language Pathology from the bottom of my heart to call us back. And, so many memories were rekindled, right from the breakfast to the banquet to the last day. I'm really going to, keep fond memories, and I look forward to the next alumni meet. I hope everybody is looking forward to the next alumni meet. And I'm hoping next year we'll have more numbers rather than just the few hundred that we had. So, ab ki baar 200 par.
Wow, that's nice. Any this side?
Hello. Yeah, hi everyone. I was given the mic, so now you'll have to listen to my views as well. First, I'm very grateful that I was made the panelist. Like, I've always been used to be sitting on this side. Now I was there, which was an opportunity given and in this conference. Thank you so much for that. One thing that I loved was that we get to learn from each other. And what was very homely was that when we are teaching, we didn't feel like we are elsewhere and maybe we are going to be judged, because everyone felt like, Are, hum hi hai, I'm just teaching a bunch of my family. So that was very great. Thank you.
Anyone from, again, organizing committee? Like, Sneha spoke, but still, like, one more person.
Hello. It was an amazing conference. Actually, all the committees here, they played their role very well, right from venue management, the banquet part especially. I liked it because we never had such kind of party during our bachelor's masters, so we got to have that as well. And all the topics, all the panelists, they all, everybody had something to, for us to take home. And I really want this event to, at least, like I was just talking to Aarti ma'am, so maybe once in 2 years or 5 years, but please keep having this, because this is something, which we are looking forward. Thank you.
We had a lot of parties. He lied about the parties.
Even the alumni meet can happen anytime. You also need to plan it out, and then we can execute such part of it. So, so maybe I think midway can be alumni meet can happen 1 year, next year alumni conference. So something like that. So next will be now, yeah, so alumni meet should happen with all the alumni should invite kind of thing to us. And then later again the alumni conference can happen next year, where we'll organize it again in the Bharti, something like that.
Sunil can sponsor anytime.
Let's do the needful.
He said, I will very lot of conviction.
So the motto, is to come together and to increase. Yeah. Okay. So now students. Quickly, MSc Audiology. Yes. And MSc SLP, please be ready.
Hello. So we are the final year students right now, currently pursuing masters, and within few months we will also be the alumni, right? But see, we study theories, we study the practicals and all, but we never knew the what are the practical challenges which we are going to face when we will be in the market, right? So that really threw us into the light that what challenges we will be facing and how we can tackle it, right? I mean, not only the problems matter, but what is the solution behind it, right? That's what matters the most. So this was really a successful conference for us. So we are really thankful to it. Thank you so much.
MSc Speech Language Pathology. Next, BSLP. One person, please be ready.
Hello, hello. First of all, I would like to thank each one of you who have come, and you get to know about the alumni who is working outside, and we'll get to know what all challenges we are going to face after this. Because I am the final year student of speech language pathology. The topic that it's already covered in the conference, it was like few topic from every area, which is really good, and I could able to brush up my audio part also here. So thanks for that also. And they have covered a little bit, like very small thing they have looked on. So thank you very much for all these things. And we are also looking forward that we all invite us as a alumni next year. We'll come and we'll definitely share our experience as well. Thank you, thank you.
Really like to, first of all, thank the staff and the faculty for inviting all the interns. We're glad we could come back from our outposting and get to witness this. And yeah, especially since we'll be graduating in a month now, it was very insightful since most of us are figuring out if we want to go and work or pursue our masters. So it was very insightful, and the topics discussed were very elaborate, and just like to thank you all for inviting us. Thank you.
And not to speak in the mic for the past students. Because going with a tagline from alumni to alumni, so I said, okay, I will not speak. So I did not answer any questions. But I'm happy that all questions were answered. And I just want to say that I'm really, really proud of all our students and alumni. And this I'm saying on behalf of all the staff. I'm sure all of them agree that we're really so proud to hear all of you speak so confidently, so well, and the points that were given were also so good. And we learned a lot. All of us learned. It is not just the students who learned, even the staff learned. And this is really a very, very, very proud occasion for us. And I'm happy that we thought of this, and I'm happy all of you came. And I know that people have come across we have people coming from Delhi and other states, Gujarat, and all over Maharashtra. So I'm really, really very happy. So I'm happy you enjoyed the scientific feast as well as the get-together. So keep continuing this. Thank you.
Next stage where we are going to, the very important part was the organizing committee. And all the organizing committee and all the members had really worked hard, and we want to just appreciate everyone. So I just want to call upon one by one, all the alumni. So first, Miss Abigail Soni, please come on the. Ma'am, I want to request you to please hand over this certificate. She's not here. She's not. Akshay Kamble. Bhushan Jirgaye, Pareen Khoja, Hariom Bhagat, Miss Isha, Miss Megha Bhagat, Megha, Murdul Raut, Mudra, Miss Mudra, Miss Mugdha, Miss Nikita Kirane, Mr. Pankaj Shinde, Putsia Khan, Pankaj Shinde, Kumel Sheikh, Rachna Panikar, Rutuja Vispute, Sadanand Gore, Sakshi Pal, Chamangi Nakhre, Sneha Kulkarni, Snehal Purkar, Sunil Patil, Aditi Oswal, now I would like to call upon BVD SSLP faculty, Dr. Sharda ma'am. Miss Sonal Chitnis. Sonal ma'am. Dr. Pallavi Kekar. Shweta Deshpande ma'am. Nikita Nanavati. Anuj Newpane. Priya Kapoor. Apasa. Christy Datta. Kalyani Ghate. Mansi Karnad. Ashwini Kunjir. Madhuri Bogad. Kuhu Kulkarni. Rucha Palkar. Sahil Sheikh. Miss Lisa. Thank you, ma'am. So thank you so much. Without the whole organization committee, like it would not have been possible. So vote of thanks now again. So I would really like to thank. I would really like to thank Vanaja ma'am and Aarti ma'am for their brainchild as a alumni conference, and because of both of you ma'am, like it could happen this alumni conference, and it was grand success because of your planning, your directions, whatever like we had got it. So thank you so much ma'am. So everyone should clap for them. Sorry, one Rucha ma'am's name is, I forgot. Yeah, sorry Rucha. thank Bharati Vidyapit deemed to be university for providing this platform, medical college, campus committee for providing this venue arrangements and everything. Our sponsors who had sponsored the banquet and lunch and all other part of also. I'm really thankful to them. And special thanks to the organizing committee. So first, starting with the finance committee. So it was a time we wanted to structure this particular thing, alumni conference. So definitely without fund, it was not possible. And I'm really thankful to all the members of the finance committee. They have really worked hard to get the finances, the funds from all different companies. And after, beyond this finance committee also, some people have really helped. I should say Mansi Karnad also had helped, getting the some part of it. So, these are the people, who had, helped in the funding and getting the sponsorship from the different companies. So, I'm really thankful to all of them. Even Akshi Kaul, and I'm sorry, if I forget some name, but these people have really helped out of these members also, beyond this, everybody had helped actually a lot in getting the funds also. Also, a big thank to the scientific committee. The scientific committee work was tremendous. It was, but really thank you to scientific committee. You people had worked day and night actually, and then got all the panelists and the speakers and everyone. So thank you so much for this wonderful all the resource person what you had got and the whole plan. So it was a very tedious job, but it was done very beautifully. And then that is why we could see now these 2 days how everything just went very smoothly. Next committee is registration committee. Registration people also had worked really day and night. So whatever the queries are there, quickly it used to get resolved. The certificates and everything, really these people have worked day and night, one call itself you give, it is to get sorted. So really thank you to the registration committee. And then souvenir committee. Souvenir committee also had really helped a lot to get all the messages from the alumni, the pictures. It was a really tough job actually to collect all the stuff, but they have really worked hard. Publicity committee, the publicity in the social media and all, also publicity committee also had helped a lot. Food committee, that was also, food was the major part of our alumni conference, and I hope everyone has enjoyed the food part also. So deciding the food menu and everything, food committee has really was keen on getting what are things, everything was selected by the food committee, and alumni, everyone has contributed into this committee. The venue committee also had help in arranging all the venue related part. The AV related part was excellent, it went very smoothly, no technical glitches, hardly one or two, but still it was really good. Even banquet committee also had helped a lot in arranging the banquet, starting from the venue of the banquet was a tough job. I should really say the Akshay had really identified a very good banquet, and it was very nice and we had enjoyed. So all these committees has helped. Along with that, all the resource person who had participated, I'm really thankful to them. Even all participants. Without you, it would not have possible. So all the participants also I want to thank. Faculty member, administrative staff, really thank you, because the college support was based on you. So thank you so much for everyone. Also, the special thank to the Tambe ma'am who came for both the days she was here, and all the former faculties, and the guest faculty also who visited. So thank you to them. All the students, yes, students also had helped a lot. You just tell them, they quickly they do it. Even the AV team also here, or registration, stage committee, everywhere. Really thank you to all the students. All the vendors, food, gifts, then mementos, praise, photographer, still they are working, audio system. So they have also helped a lot to us. So thank you so much. Also, we can't forget the Mama Maushis, who had helped. So thank you to them. Directly, indirectly, whoever has helped. So thank you so much for everyone. And with the ma'am's permission. Yeah.
a last word from the organizing chairperson. I think we should give a huge, huge, huge round of applause to Piyush sir. Throughout the 1.5 months of planning and execution, I think he was omnipresent. I don't know how many hands, legs, and brains he has, because he was coordinating everything all the time. You just ask him anything, he knew about each and every committee. He knew exactly what was happening on each committee, and he was everywhere. I don't know how he manages that, but it is like super human being, I would say, because entire communication with the sponsors, entire communication between the committees was something I think he did superbly, and he was here probably day and night last 2-3 days working on this conference. So I really, really appreciate Piyush's contribution to this conference. I don't think we would have been able to do it in this grand way if he would not have contributed even 1% of what he did. It wouldn't have been this. And I really appreciate all our alumni. I think BASLP and MSc, we give you like a launching pad, but all of you have done super specializations in so many areas which I have learned about in last 2 days. May it be hearing aid fitting, cochlear implants, ANSD, APD. You just name everything from the curriculum, and we have our alumni who are working so beautifully in all those areas. So as I told somebody in the afternoon, I feel like, you know, when I leave from here or when I retire or whatever, I think I should spend some time in each of your clinics and learn what you have learned, at least a little bit, and be an observer. It was so interesting to hear all of you sitting here. Thank you so much, all of you, for coming for this conference. Just one phone call or one message, and you agreed to be panelists, moderators. Panelists changed into plenaries, plenaries changed into panels, and then everybody still said, yes, okay, we'll do it. Even 2 days ago, we changed something, and people said, okay, we will do it. So that was something really, you know, it's very, very, I should say, a heartfelt thank you to all of you for, it is your conference, I wouldn't say cooperating or anything, but for doing this conference and doing it at this level and contributing to it. So really we are looking forward to more and more of these interactions. I'm sure our students will benefit if you come ahead in and contribute in whatever way to future generations of ASLPs. And I would say all of them, you know, are specialized in their own field. So after you finish your graduation, post-graduation, if you, I don't know whether they would want it, but I would think you should at least offer to go and observe maybe what they're doing and how they're doing things. So that would be a great learning is what I would think. If I was a student and our alumni would have come, I would have really caught on to some and learned a few more things, because everything is not possible at college level. So you have to develop your areas of interest. And I'm sure our alumni will welcome their juniors with open arms for the observerships or whatever ways that you can contribute. And your contributions to college is always welcome. You come up with an idea, share it with us, and we will take it up in whatever way. So it's an open invitation to all our alumni to keep contributing to the betterment of the college and to the future generations. Thank you so much, and I hope to meet all of you soon. Thank you.
Come to the end of the session. I know many of you don't want to leave, still want to be there, but still we can meet outside. We have the high tea right now, and we can interact there. So thank you so much, and see you soon again.